Good afternoon, everyone. On behalf of the organizing committee of 42nd Annual Conference of AOGD and first e-conference, it's my privilege to be a part of this workshop on endoscopy, enhancing surgical skills in gynae endoscopy, organized by Dr. Kanika Jain, Dr. Mamta Dagar, together with Dr. Debashish Datta, Dr. Richa Sharma, and Dr. Madhu Goel. The program is planned in such a way that we move from basics of endoscopy to advanced endoscopy techniques. Both hysteroscopy and laparoscopy has been touched equally. The program is nicely knitted and crafted by Dr. Kanika Jain and her team, and we have galaxy of international and national faculty members sharing their videos and experience with the benefit of the audience. I'm sure all the PG students, residents, and young buddy delegates aspiring to become endoscopic surgeons will highly benefit from today's e-conclave. I take this opportunity also to introduce Dr. Kanika Jain, who is the Vice President of AOGD, organizing co-chairperson of this annual conference. She has been the mind and person behind this entire workshops. She is the workshop convener of this workshop, and she is the Senior Consultant, Institute of Obs and Gynae of Department of Endoscopy. It's my pleasure also to introduce Dr. Mamta Dagar. She is the Secretary of AOGD, also organizing secretary of this entire conference. She is the Senior Consultant, Institute of Obs and Gynae, Sir Gangaram Hospital. I also take pride to introduce Dr. Debashish Datta, who is the convener of this workshop, and he is the Senior Consultant, Institute of Obs and Gynae, Sir Gangaram Hospital. His field of interest is exclusively endoscopy. It's my also pleasure to introduce Dr. Richa Sharma, who is the co-convener of this workshop, and she's the Professor of Obs and Gynae at GTB and UCMS Hospital. Dr. Madhu Goel, who is also the co-convener of this workshop, and she is the Senior Obstetrician and Gynecologist at La Fame Hospital. I was supposed to hand over to Dr. Mamta Dagar to carry on the day's proceedings, but we have the pleasure of the presence of Dr. S.N. Mukherjee, who is a patron of AOGD. So we take this opportunity to invite him to bless us in this occasion and give good blessings and good wishes for this workshop. And I also wish all success to today's workshop, and I hand over to Dr. S.N. Mukherjee to bless us with his kind words. Over to you, Dr. S.N. Mukherjee.
Thank you very much, Dr. Mala, for giving me this opportunity and this task. I'm really very glad to be here in this wonderful morning and to say a few words on this workshop, which is being organized by Dr. Kanika Jain, Debashish Datta, and all our colleagues. I wish them all the best of luck. Gynecological endoscopy, you all know, is an important part and parcel of present-day gynecology. It has opened up an opportunity, a vista for the gynecologists. It's a real new armamentarium in the gynecological stock, and it gives the gynecologist a lot of scope and help in the different diagnosis and treatment of different gynecological conditions. I hope that the learned speakers will do a great job and the delegates will enjoy the scientific deliberations to a great extent. Best of luck. Thank you all very much. Okay.
I'll just hand over.
My duty is okay.
Thanks, Dr. Mukherjee, for your kind words and your blessings. Now I hand over the proceedings to Dr. Mamta Dagar to carry on the day's proceedings. Over to you, Dr. Mamta Dagar.
Thank you, ma'am, and good afternoon, everyone. On behalf of Organizing Committee of AOGT, I extend my very warm welcome to the pre-conference workshop, all the faculty and viewers on enhancing surgical skills in Gynae endoscopy being organized by Institute of Obs and Gynae, Sir Gangaram Hospital. I am very happy to share that Dr. Kanika Jain, who is Vice President AOGD, who is not only the convener of this workshop, but also the chair of the workshop committee of AOGD, and hence takes the credit of handling all the 11 pre and post conference workshop, which is a mammoth task. I hand over to Dr. Kanika Jain now for further proceedings. Over to you, Dr. Kanika.
Thank you, Dr. Mamta and Dr. Mala for the kind words of appreciation. It's an honor for me, and it's an honor that we had Dr. Mukherjee today in the morning to be able to give us his blessings. I feel honored to be bestowed with the responsibility of holding this first virtual gynae endoscopic workshop in this entirely e-conclave. While endoscopy has really evolved over the years, from HD cameras to HD and then 3D telescopes, from laparoscopic assisted vaginal hysterectomies to total laparoscopic hysterectomies, to lap radical and then now to robotic assisted laparoscopic hysterectomy. We've seen it all. And now the vaginal route is being used for laparoscopic surgeries as well. Still in India, less than 20% of the gynae surgeries are being performed laparoscopically. Our aim should be to make gynae endoscopy as the absolute norm, to minimize the open surgeries as far as possible. And in this endeavor, we have invited the eminent national and international faculty today to showcase their skills and mentor our budding endoscopists and help them carve their career graphs in gynae endoscopy. I welcome my co-conveners who have been introduced by Dr. Mala. I welcome all the faculty, the chairpersons, speakers, and the delegates for this workshop. I would request the chairpersons to give their expert comments at the end of each session to ensure that the sessions do not overshoot the time allotted, and to ask the relevant questions from the speakers. And I would request the speakers to adhere to the time scheduled and address the questions from the audience in the chat box itself as far as possible. I hereby also take this opportunity to seek blessings with folded hands from the Almighty, and blessings from my parents, Dr. P.R. Jain, Dr. Kamal Kanta Jain, my mentors, Dr. S.K. Bhandari, Dr. Indrani Ganguly, and Dr. Kamal Gujral, who bestowed trust upon me and thought that I was capable enough to hold this responsibility and nominated me for the post of Vice President AOGT. And now, without much ado, I would like to start with the proceedings, and I would like to invite the chairpersons of the first session. I would invite Dr. Geeta Mehndiratta. She's the Senior Consultant, Institute of Obs Gynae at Sir Gangaram Hospital, and she's the scientific chairperson of this conference of ours. We welcome you, ma'am. I would invite Dr. Angam Jyotsna. She's a Senior Consultant Laparoscopic Surgeon at Jahangir and Jupiter Hospital, Pune. Dr. Chandan Dubey. She is a Senior Consultant Gynae Obstetrician at Sharjah, UAE. Dr. Swati Agarwal. She's an Associate Professor in the Department of Obs and Gynae at Lady Hardinge Medical College. I would now like to introduce the first speaker of the day, Dr. Sandesh Kade. He is from Sholapur, Maharashtra, a senior gynae endoscopic surgeon, and he was a team member of the first uterine transplant of India and a laparoscopic surgeon par excellence, and is a mentor for many of the budding endoscopists in Maharashtra and all over India. So welcome, sir. Over to you.
Words. Hello.
We can hear you, sir.
Yeah. Can you see my screen now?
Yeah, we can.
Okay. Thank you very much for those kind words. let me start with my presentation today, and it is the understanding of the avascular spaces in the pelvis. This is a must if you want to be a competent gynae laparoscopy surgeon. Now, what exactly is the pelvic spaces and why we need to understand the anatomy of the avascular spaces? Day by day, we are performing very difficult laparoscopic surgeries. Now, take example of this patient who wants to conserve her uterus, and she is for infertility, and hardly you can make out where is the uterus, where are the ovaries. What you can make out is just fimbrias which are seen there. But it is quite possible, if you know the pelvic spaces, to perform this surgery very efficiently. And the whole concept of pelvic spaces is that the pelvis is divided parts. The most innermost part, the muscular layer, most superficial, the peritoneal layer, or the bands, round ligament and the ligaments which we see. In between these two layers, there is a fibrofatty layer, and this layer is distensible. It is a potential space. It is in a compact stage. Surgeries, you can open them, allow the CO2 to enter, and help you delineate vital structures and preserve them, avoid injuries. So this is the whole concept. And why you have a fatty layer in between? Because the pelvis is pierced by the bladder and urethra, the uterus and vagina, and all these organs are distensible. They have to distend and contract. So you need space. And if you don't have this fibrofatty layer in between, that is the avascular plane, it is impossible for these organs to function. So this is the deepest layer of the pelvis, which we call the pelvic diaphragm, which is made up of muscles. And we generally levator ani muscle. Now, levator ani muscle is not a single muscle. It is a group of a pair of three muscles. So the muscle arising from pubis to rectum is puborectalis, ischiorectalis, and iliococcygeus. So these three muscles, they merge in the midline, and the puborectalis part in the anterior part of anterior half of the pelvis, you will see it is pierced by three organs, that is the bladder, the vagina, and the rectum. So, and the most superficial part is the peritoneal part. It is as if you have placed a curtain over a table, and you can make out the shape of these ligaments which are there, the infundibulopelvic, the round ligament. These are appreciated by the folds. So the topic today is pelvic spaces. Now, first we have to define what is a space. A space is an area. A very important requirement is there when you call any area in the pelvis a space. It has to be lined by fascia of different origin. Now, if you see the space between bladder and vagina, which is the vesico-vaginal space, the vesicle, that is the bladder, is covered by a vesical fascia, and the vagina will be covered by a vaginal fascia. So these are two different fascias, and when you open that space, only then it is called as a space. So practically speaking, there are 8 spaces in pelvis. This is because of the 3 ligaments which are there, 3 pairs of ligament: the vesico-vaginal ligament, the uterosacral ligament, and the carpal. So what we say is there are spaces and there are lateral spaces. By and large, the benign surgeons use the midline spaces, and the oncology persons, they use the lateral spaces, because in oncology you are talking in terms of how much parametrium has been removed, how much paracervix has been removed. So to evaluate and make your surgeries safer, we need to dissect into these lateral spaces. So first we will go with the space of Retzius, and if you see this diagram on the lower right, it shows the Retzius space. We are using this space in our practice for stress urinary incontinence, performing Birch operation. So most of our surgery again to Birch, where we take suture at the mid urethra and fix it to the pectineal ligament. If you see, there is a white line. This is the line which holds the proper approximation to the lateral pelvic wall and in a particular axis. So this is important for lateral cystoceles, so where we can do paracolpus stitches. If you go behind, when the bladder is bulging down and you are putting some mesh under it, then this will be helpful in pectineal pectopexy. So all these procedures are performed in the vesico-vaginal space. So here I am showing you one short video where we are repairing the lateral cystocele. So here you appreciate we are into the space of Retzius, and here you will appreciate the pubic symphysis. Now I am cutting the fascia. You can see there is absolutely no blood supply in this area, and you can dissect it very, very easily. And that is the reason it is called as the avascular pelvic spaces. Here you will see we are just above the urethra, and now I am exactly at the pubic symphysis. So this is the space of Retzius. This is a particular case of lateral cystocele where I have to expose the pectineal ligament or the obturator internus muscle, and you can appreciate the white line also. This is the arcus tendinous fascia pelvis, which extends from the pubic symphysis to the ischial spine. So this is what we use in our regular surgery. See, I am taking a stitch into the paracolpus. Like I said, the vagina is attached to white line. So this stitch will go into the white line or the obturator internus muscle, and it will approximate completely. Unlike the Birch operation, where it is a slings stitch, you don't approximate the para-urethra directly up to the pectineal bone. Then it will actually obstruct the urine. So in paracolpus, we approximate. In Birch, we don't approximate. Next is the most commonly used vesico-vaginal space, which we are using in our regular hysterectomies. So here you will appreciate we are just dissecting. First, I have bulged the balloon Foley's bulb to appreciate the apex of the bladder, the highermost part. Then we pick up the peritoneal fold and cut it. Now appreciate when I pull, the fascias separate, and I am cutting exactly between these fascias, and I am pushing some fascia towards the bladder, and I am keeping some fascia towards the vagina. And that is the reason why these vessels are not bleeding, because the blood vessels are always under the fascia. If fascia, then they bleed. Otherwise, the surgery goes bloodless with a little bit of minimal staining that can happen. So here appreciate how I am pulling the tissues to see the stretching of the fascias, and then we divide it between the two fascias, because we know this is a natural space and is bound by two fascias of different origin. So here you will see in the midline, there's a huge cystocele. There's a big gap between the vagina and the bladder. This is the Yabuki space under the ureter. The lateral part of the cystocele under the ureter is Yabuki. Now appreciate here the tissues are sticky and it bleeds. This is because Yabuki space, although called a space, is not a true anatomical space because it is not lined by different fascias. Now I'll skip because of paucity of time. There are multiple videos. You can go to YouTube and you will see the lateral window technique and the various methods of using vesico-vaginal space. So this is the Yabuki space I was describing, which is the around the cervix where the ureter curls over the cervix and enters into the bladder. This is very important because there are nerves under this Yabuki space which we have to spare. Otherwise, in our radical surgeries, if you cut these nerves both sides, the patient lands up into atony and the patient has to do self-catheterization because she cannot contract the bladder. Next we come is to the recto-vaginal space, which we very commonly utilize in the endometriosis surgeries. Next, the most posterior space is the retrorectal or presacral. It is between the rectal fascia and the sacral fascia, presacral fascia. This we are using most commonly in the pelvic floor surgeries when you want to anchor, if it's a vault prolapse, the vault to the sacral promontory, or you want to conserve the uterus and fix the hysterosacropexy or colposacropexy. So in the sacral, into four parts. The right lowermost part is the most safest part to perform surgery in the pre-sacral or the retrorectal space, because you have the left common iliac vein, which is very, very dangerous. It can actually come very low down, occupy almost half of the sacral promontory. Next important structure to be seen here is the vertically running mid-rectal vessels. And thirdly, here you have a nerve complex which is called as the superior hypogastric plexus. The superior hypogastric plexus is made up of only sympathetic fibers, and they are present anterior to the aorta, and all this chain of sympathetic fibers merges at the pre-sacral area to form the superior hypogastric plexus. And it is from here the two right hypogastric nerves come, and they run along the right uterosacral and left uterosacral ligament and go down to the uterosacrals, where they will be joined by the parasympathetic fibers, that is the inferior hypogastric plexus. Now we come to the pararectal spaces, the lateral spaces. On either side of the bladder, the spaces are called paravesical spaces. On either side of the rectum, they are called pararectal spaces. The paravesical spaces, it's a single structure. So the landmark which divides the paravesical and pararectal is the uterine artery. Here you can appreciate all vessels are running parallel towards the pelvis, going out of the pelvis, the external iliac, the external iliac vein, whereas the uterine artery is the only vessel to begin with which crosses the pelvis and runs from lateral to medial side. And this uterine artery, the area ahead of this is paravesical, the area behind this is called as pararectal. Now this pararectal again is divided by the ureter into lateral, that is the Latsko space, and medial, that is the Okabayashi space. It is in this Okabayashi space the superior hypogastric nerves and the S2, 3, 4 parasympathetic, they will join just besides the uterosacral ligament, between the uterosacral and the ureter. So when we are taking uterosacrals, don't be very large uterosacral and low down, because that will involve the nerves. So when you dissect these avascular spaces, you get more area to perfectly delineate the uterosacral attachment and just cut that, rather than cutting the nerves which are here and damaging the functions of the pelvic organs. So I think here we have a case of high uterosacral ligament suspension where we dissect the pararectal spaces. So, and we are dissecting lateral to the ureter. You can see the peristalsis of the ureter. So this is actually the pararectal, but the Latskos part of pararectal. Same way on the left side, I am going to dissect the same space between the uterosacral and the wall. That is if it is between the ureter, it is the Okabayashi space. If it is lateral to the ureter, it is the Latsko space. And here we dissect the ureter and just dissect down along the ureter. We preserve the fat, and the nerves are always traveling in the fat so that we don't damage these nerves. So you don't need to identify, catch them, pull them. It is just you preserve, be aware of the anatomy and the landmarks where and the distance where the nerves are traveling. Just conserve that area, and that should be able to do a nerve sparing surgery. Now
Dr. Sandesh, 2 minutes to go.
Okay, fine. So this is a case of vesico. Here we are going to use both the vesico-vaginal dissection as well as. So when you are aware of the anatomy, one surgery might require multiple areas to be opened. Now in this case of pectopexy, where we are opened the vesico-vaginal, now I have seen the external iliac. I will identify the obliterated umbilical. When I just cut between that external iliac and obliterated umbilical, it will take me to the pectineal bone. Immediately I see the pectineal bone. So here we are utilizing the anatomy, the knowledge of anatomy, the vesico-vaginal, the paravesical and the pre-vesical to perform the dissection and help us perform a good pectopexy, where we are suturing, conserving the cystocele, and we are also pulling the uterus, which was actually very heavy and causing the cystocele. Then we use it in the lateral spaces. So this is the, I'll just use one more slide. This is the Okabayashi space. Like I said, these two spaces are not true anatomical spaces, but their clinical application is so immense that they have been included into the pelvic spaces. So we have 8 anatomical spaces, and 2 which are not anatomical but very clinically significant. So I would like to thank AOGD, and this is the case which I showed you to begin with. With the knowledge of the avascular spaces, here I dissect the paravesical and identify the tubes. Then I dissect the rectovaginal and identify the uterus. And finally, we are able to dissect and identify the ovaries also, and the tubes are very nicely delineated. So a case which was looking impossible, because of the knowledge of anatomy, it is possible for us to do a good within the good planes and avoid damage to the vital structure. So thank you AOGD for this wonderful opportunity. I hope there are any questions, I'm here to answer them. Thank you.
Thank you, Dr. Sandesh. That was a very well outlined program. And I think we will proceed with all the 3 lectures.
Dr. Geeta? Okay, thank you, Dr. Sandesh Kade. That was nice. And I think the questions can be addressed in the chat box also, and chairpersons would be discussing them at the end of the session together. So we move on to the next speaker. Am I audible? Yeah. So I would invite Padma Shri awardee Dr. Malvika Sabharwal. She is the founder chairperson of the Delhi Society of IAGE, the president of the Gynae Delhi Forum, and the chief of the Department of Obs and Gynae at Hospital, Apollo Spectra Hospital. So welcome you, ma'am. And she would be talking on the energy sources in gynae endoscopy then and now. Over to you, ma'am.
Thank you. Thank you very much, Dr. Kanika. Let me first congratulate Dr. Mala, Dr. Kanika, you, Mamta, the whole team, Richa, Madhu, Devashish, everybody, a big mammoth task in this stressful time. My topic that you've given to me is extremely important and very close to my heart, actually, because I feel energy sources is something which should be very well covered for every program. Okay, so electrosurgery is used in the majority of endoscopic therapeutic procedures, and understanding of fundamental electrosurgical principles and the various settings that are available to us on the ESUs is extremely important to make it safe and effective. If you look at the first electrosurgical unit, the Bowie's unit, which was used in Boston, this was in the year 1926. And by 1928, Cushing had published series of almost 500 neurosurgical cases, which were put on the front page of the papers. Before 1968, the technology that was being used was spark gap technology, till solid state started in the ESUs, and all this is now obsolete because the various complications, the sideburns, etc. They've all grounded, no more being used. Today, the present ESUs are balanced with return monitoring systems. They are able to give us the bipolar outputs. Current waveform is constant and reliable, and it gives predictable power output and tissue effects. Basically, electrosurgery is based on the transformation of energy from high frequency electric current into heat, with the resulting effect of cutting or coagulation at the point of the current application. Coagulation is temperature rises within the cells, which then dehydrate and shrink. Cutting is when the heating of cellular wall occurs so rapidly that there is a cell burst. Now, if you look at this particular diagram, the principles of electricity, wherein the V, the voltage, the driving force is equal to the current into the resistance being offered by the tissues, and P is the power or the heat being generated. If you look at the tissues, the resistance depends upon the degree of vascularization and the water content. Now, tissue resistance, if you look at bone, is more than fat, is more than skin, is more than muscles. Also, the fact that when you progressively desiccate a tissue, there is increased resistance, which reduces the current intensity. If you look at the Joule's law, it is the heat that is produced, which is inversely proportional to the surface area of the electrode. These are the two high frequency currents being generated by the electrosurgical units. Cutting current is when there is a continuous waveform with high frequency and a low voltage. The temperature is very high. The coagulation current is a pulsed wave wherein it's a low frequency, high voltage of 3500 and above. The temperature rises slowly, the coagulin gets formed. We all are familiar with the normal hemostasis. How does it happen in our body? There's vasoconstriction, there's platelet aggregation, and fibrin deposition. What happens in electrosurgery? There is compression, there is heat, application of heat to the tissues, and the time of application. So all these three variables in front of you are very, very important: the heat, the time, and the compression. What happens when you want to seal the vessels? There is collagen and elastin in all the vessels. So as you compress, there is increased hemostasis because there is a decreasing tissue volume and the water content decreases. It promotes fusion of the collagen within the vessels. There's decreasing time for the tissue effect due to increased resistance. It promotes intima to intima intact contact. So am I audible? Excuse me.
Yes, ma'am. Yes, ma'am. You're very much audible.
Okay.
You're very much audible. Very clear.
All right, thank you. So principles of sealing. If you see this is just to share that the various modalities that are available to us are majorly working in between 80 degrees to 100 degrees. You know that before 40, in front of you can see there is reversible tissue damage below 40 degrees centigrade. And beyond that, there is irreversible tissue damage. There is protein and the collagen denaturization. You know the modalities that are giving to us are working in this level. Beyond 100, there is drying or the desiccation of the tissues. And at 150, there is pure carbonization or the charring. The energy types available to us are electrical, laser, or ultrasonic. Now, this is just to share the ESU, what they do. In front of you is a principle of electricity again. You can see that the electrosurgery depicted in red is from 200 kilohertz to 3.3 megahertz. This is what the ESU does. The regular electric current is being converted into the electrosurgery, which we are using for our endosurgery. The regular household appliances, whether it's the radio, whether it's a dryer, etc., they all are using, up to 60 hertz. So basically at 100 kilohertz, muscle and the nerve stimulation ceases. You can see that in the household appliances, there are current, people can be getting electrocuted, wherein the fibrillation and the cardiac arrest takes place. But beyond that, beyond a certain frequency of the current, there is no effect on such. So myocardium sensitivity decreases with increasing current. These are the generators which we are using to convert the current to radio frequency, the household frequency to radio frequency. This is just to share with you that as you increase resistance while doing tissue desiccation, remember that the electrons seek the path of least resistance, and resistance is inversely proportional to the water content of the tissue. So you can, if you are continuously desiccating, you can have the electrons moving on to the other sides and they can be spread. Coming on to monopolar electrosurgery, the current passes through the patient and returns from the return plate. There is extreme heat, in compression is minimal, time is very short. Advantages, you can use it routinely, easy to use. Both cutting and coagulation, both are available to you. You can use either. Disadvantages, that there can be electric spread, the vessel sealing is minimum, insulation failure can happen, should not be used with patients with pacemakers. We should keep in mind the complications like insulation failure, direct coupling, or capacitive coupling. Coming on to bipolar electrosurgery, the electricity flows from active to the neutral electrode, both of them being located in the close proximity on a single endoscopic device. There is heat that gets produced, the compression is needed, time taken is relatively more. Now, this is just to share with you that the approach of the vessel is extremely important. That 90-degree approach is what, if it is a 5 mm vessel, it will be a 5 mm. But in case you were to approach it tangentially, 5 mm may not be that because the length may just increase. So advantage of bipolar is that there's no need for a grounding pad. It is safer for the surgeon and the patient. Surface oozing can be controlled. Less spread is there and it can be working under saline. Disadvantages that frequent probe change because of eschar formation is very common. Lateral thermal spread is possible in bipolar. Also, high voltage limited coagulation happens only to the superficial layers, but the deeper tissues may not be desiccated as well. Also, the accumulation of the steam and smoke decreases the visibility. Going on to the advanced bipolar, which is available to us today, is a LigaSure vessel sealing technology. It uses body's own collagen and elastin to create a permanent seal that can withstand 3 times normal systolic blood pressure. It uses high current and low voltage. It measures the tissue impedance between the jaws and continuously adjusts the delivery of the current. There's uniform mechanical compression. It works well on the arteries, also veins, but on capillaries with little collagen, it doesn't work well. So it can seal vessels up to 7 millimeters comfortably in very less time. The sealing time is totally controlled and the response is extremely free of the user. There is upgraded LigaSure available today. This is extremely efficient. It's got a Maryland jaw. Also, there is a non-stick nano coating on the jaws, which makes it less sticking. So it's done away with that. So it's 97% less than the end seal. It's more effective cleaning with less eschar formation. I'm mentioning about the standalone vessel sealing generator. So many of us may have already a theater which is all set up. Now you're only looking at a vessel sealer. One can use this Varilab LS10, which is available to us, which is more cost effective because the only thing is that you want a vessel sealing. So we can just add it to our armamentarium and go ahead with the spectrum of surgeries, moving on to TLH, etc., etc. This is the F4 triad, which was there from the Medtronics, giving you monopolar, bipolar, and LigaSure outputs. Now we have additional FT10 as also improved version, which is giving us the improved bipolar resection, which can be now used for underwater current. By that, I will just explain you that in case you want to step up, you want to buy a stores, maybe a resectoscope wherein you want to manage hysteroscopic resection of larger fibroids, wherein glycine is not the limiting factor and you're working on the saline. So this is the unit to be used, wherein you improve bipolar resection can be very comfortably done because it has to be, if you have the handpiece, you have to have the generator, which is in sync with that. So this is what it does. Now, NSEAL is available, which is another bipolar by Ethicon, and it uses the nanotechnology at electrode tissue interface. The jaws contain temperature-sensitive matrix with conductive carbon spherules. It's got better end-to-end sealing, better tissue compression, less thermal spread. It can seal up to 7 millimeters of vessels. So advanced electrical current and combining mechanical pressure, I would say high current and low voltage are delivered to the targeted tissues and denature the collagen and elastin in the vessel wall, while the mechanical pressure from the instrument allows the denatured protein to form a good coagulum. And this is the way it works, and we are using it every day. It's a very, very good way of handling large vessels, especially the uterines. Coming on to ultrasonic energy, how does it work? It's got 2 ways of working. It's got cavitational effect and the mechanical to heat energy conversion effect. Cavitational effect, the tip vibrates, produces large transient pressure changes. There is a cavitational effect. It gives you very precise cutting and dissection, because dissection, it just, for example, if you're working on the UV fold and you're using the ultrasonic energy, it automatically just, the carbon dioxide goes inside, lifts away the loose areolar tissue and gives you a very beautiful plane of dissection. So it can be used in the pelvic walls, etc., anywhere wherein you have a good dissection. So the other method is mechanical to heat energy, wherein one large blade is vibrating at 55,500 times per second, wherein it's creating heat energy. Now the other blade is the tissue pad, which protects the tissues around it. So this is the generators is almost like typically about 80 degrees. It's excellent for your tissue dissection. Charring is very, very minimal. It's beautiful for your previously scarred abdomens, etc. So this is the way it works. So no problem of the current spread, approximately hardly 1 millimeter of spread. We've already talked of the cavitation, and also it is safe in patients who have got pacemakers. Simultaneously, coagulation and dissection is very helpful. Now, to do away, because the earlier harmonic was being, was professed at tackling up to 5 millimeters of vessels. Now,
2 minutes to go, ma'am.
1000 harmonic is available, which can tackle up to 7 millimeters of vessels, available as 20 and 36. Sonicization is cordless. Earlier sonicization had a battery problems. Now this is by the Vectronics. It's portable, free from cord, tapered, excellent. Now the present sonicization, which is the new one, has got it's got a better battery. It can have battery life almost 200 procedures, and also the generator life is much better. Olympus, the Thunderbeat is excellent because the change of vessel is very minimal. It's a single multifunctional instrument. Integrating ultrasonic and advanced bipolar has allowed simultaneous sealing and cutting up to about 7 millimeters of vessel. So if you were to compare, the LigaSure has the highest burst pressure and fastest sealing time and was the highest rated overall. Harmonic scalpel produces the lowest thermal spread and smoke, but has the lowest mean burst pressure. Gynae, I will not talk much about, and seal device has the slowest and has a very variable burst. Now, this is a chart which I really want to share, because before I picked up my vessel sealer, let me share with you that I definitely tried all of these instruments. And I would like to share my own experience, wherein harmonic I use for dissection purpose. Whenever there is previous scars, adhesiolysis is excellent. Myomectomies, it's excellent because with minimal charring, wherein also, but the one thing important is it's independent of users. The consistency, like you have to develop, you have to command the skill of harmonic scalpel, wherein LigaSure is excellent vessel sealer, and it can take up to 7 millimeters. It's independent of user. It's got its own way that it just, N-Seal has got, I tried N-Seal actually. It's got ergonomic issues, but you all have to make your own decisions. But I personally found it a little cumbersome for my ergonomic use. I will not go into these details. We already know. So what is it that we would like to use? Anything that is used prudently is what is the best. So you must know what you're using. Recommendations are that grounding pad should be used in a well-vascularized muscle close to surgical field. Inspect the insulation repeatedly and carefully. Lowest power setting is what we recommend. Lower voltage waveform while using cutting current. Contact mode for desiccation. Brief intermittent activation is what we are looking at. Terminating flow current at the end of any visible vapor phase is what should be done. Maintain full contact. Use bipolar electrosurgery whenever appropriate. Source of bleeding should be isolated using tamponade and hydrolavage. Also, only then tackle it. Any stuck pedicles, this is very important advice. Any stuck pedicles can be usually unglued by energizing the open device while immersed in conductive irrigating solution such as saline. Never use
15 minutes over.
All right. So never use any hybrid port systems. Utilize the available technology to eliminate concerns about insulation failure and capacitive coupling. Update yourself. It saves a lot of extra effort. Thank you so very much.
Thank you.
Thank you, Dr. Malvika. That was indeed very interesting. And actually, without the energy sources, I think it's very difficult to manage endoscopically. That's the basic. So you've really elaborated very well. We would now move on to the next speaker. And the next speaker for the day is Dr. Arvind Kumar. Dr. Arvind Kumar is a laparoscopic oncosurgeon, Kurti consultant at Sir Gangaram Hospital, and he's been operating faculty at various laparoscopic conferences. So we welcome you, sir. He would be talking on the tips and tricks how to make laparoscopy easier. Is the screen visible?
Yes, ma'am. You just have to do a screen share.
Yeah, I've done that. Can you see the screen?
Yes, we can see the screen, Dr. Kanika.
How do I get to slide?
We can see the screen.
Okay. So, Dr. Arvind, over to you. Is Dr. Arvind there?
Dr. Arvind, request you to please unmute yourself.
Sorry. Hello.
Thank you.
It's okay.
Yeah, you are audible.
So my topic is tips and tricks for doing safe laparoscopic surgery in gynecology. Right. So here, if you see laparoscopically, this is a picture you saw after you finish a radical hysterectomy. And I am showing just few pictures before I start. So this is after a radical hysterectomy in pelvis. Next. This is what you start and seeing the spaces, various spaces in the left side of the pelvis. This is the uterine veins and artery in the left side of the pelvis. So I don't know why it is. Yes, and these are the nerves, pelvic splanchnic nerves, S2, S3, S4. So getting all these kind of surgeries in a nicer way, you have to follow certain rules for laparoscopic surgeries. So this is what you get, what you see after para-aortic nodal dissection. This is the bifurcation. So, but while doing these surgeries, the difficult situations are encountered, like when the uterus is very big in size, endometriosis or chronic infection in the abdomen, like tuberculosis, or when you have there's a previous abdominal surgery, scar, or lots of adhesions, and the obese patients. So, what you should do, you should be knowing how to overcome them. It is not like you just bang and do the surgeries. That is a wrong way of taking care of those difficult situations. So, like when you insert the varicinoidal, you saw this injury to the bowel, small bowel. So you should be knowing the endosuturing. This is the trocar injury to the bowel. So when you are inserting the trocar, you should be knowing that if the previous scar is there, you should be at least 5 to 7 centimeter away from that scar when you put your trocar or varicinoidal. So this is thermal injury to the large bowel. So you would be checking the instrumentations, insulations and all. So all these things, this expertise comes with the experience. Not all wisdom comes from books. So you have to be seeing your seniors, you're seeing good laparoscopic surgeons to follow what they're following in the laparoscopic OT. So there are certain rules for laparoscopy in gynecology, like masterly inactivity. See, when I started my practice, I very late understood the meaning of this masterly inactivity. Masterly inactivity is when you are you are doing surgery and you are assisting by younger generation, young doctors. So you have to tell them that you have to do whatever been asked to do. Like if you are dissecting, you are controlling the uterine artery and your assistant is lifting the bladder up. So in case of bleeding, your assistant is seeing the bleeder is there and he should not jump and drop the bladder and catch hold the uterine artery near the bladder. So that is a wrong way of assisting the surgery in laparoscopy. So that is masterly inactivity. Whatever happens, unless until the assistant has been asked to do certain things, he should not be doing. Second thing is teamwork. Without teamwork, without having confidence among the team members, you cannot perform a good surgery, good laparoscopic surgery. Never hesitate to call for the help, be in any senior gynecologist or be in any surgeon or cancer surgeon. Good understanding of energy sources, like Dr. Malvika ma'am has told already. Knowledge of pelvic spaces. Dissect in the correct plane. Here comes the importance of the fat. And you should be knowing the importance of fat. Why? Because if you are dissecting anteriorly, hello,
Yeah,
Hello? Yeah, okay. If you're dissecting anteriorly, then you have to be remain below the fat. You should not be seeing any fat during surgery on the uterus, because there is no fat which belongs to the uterus. So if your anterior dissection is there, then you have to remain below the fat. And if you are dissecting posteriorly, that means you have to dissect anterior to the fat. You should not be seeing any fat during dissection. If it is there, then it is a wrong plane. You should not be doing that. And endosuturing is must. Dr. Bhatia has said that there is no future without suture. Here it is not an option, but it is a necessity to know the endosuturing. Minimal distraction from the monitor. I always said, ask my assistant, please don't distract away from the monitor, neither the main surgeon nor the assistants. Because if some bleeding is there, for example, and you take out your eyes off the monitor, by the time you again see the monitor, all you have, your mind has to reorient yourself, reorient about the surgery. It takes time, and it is not good if you are doing all these major complicated surgeries. And always think of structure you want to save. If you are, like surgery in ureter, you have to save. You should be thinking all the time of the ureter. If you are saving the ureter, then there is no problem. If some bleeding is there, you can take control of that. And always dissect parallel to all the tubular structure in the body. The no movements of your instrument should be perpendicular to the tubular structure. Next slide. There's some important point like safe entry of variginital or first trocar, position of the patients and ports, how to prevent entangling of tubing and wires. Like I always place this energy sources and the suction which a surgeon using through his right hand, they should travel a shortest distance from the source. So I stand on the right side of the patient, so I tag them those tubing on the right hip, right thigh, because they should travel the lesser distance. Then it will be you can prevent the entangling of these tubings. And similarly for camera and the camera and the tubings of CO2 tubings and light source cable through the opposite side, so that they travel a lesser distance for the assistance. Now the how to get a good abdominal or pelvic cavity space, I'll tell you later. When to use which energy sources, when not to use energy sources, like when the additions are there, you are dissecting very near the ureter, you should be using Caesar only. Next slide. So there are certain tests for vaginal safety tests like 3-click sound, irrigation, everybody knows, aspiration test, hanging drop test, insufflation of gas. If it is less than mmHg, then it is fine that you are inside the abdomen. And the last and needle movement test also. There are certain points where you can enter this umbilicus or Palmer points or Li Huang point. I personally believe that one should not be using umbilicus as the first port of entry for even varies or trocar, because it can injure aorta or IVC if suddenly it goes into that direction. So I always prefer using a Palmer's point for even for varicose needle, unless until it is contraindicated to that place. Like if the previous gastric or splenic surgery is there, or splenomegaly is there, or portal hypertension is there, then you should not be using this Palmer's point. Next slide, please. So I also want to tell you how to hold a trocar or trocar during insertion. The first picture is showing the wrong way of holding the trocar for insertion. And the second picture is showing the correct way of holding the trocar, because this index fingers will act as a guard so that your trocar will not introduce in a jerk way so that it can injure in the underlying organs. Next slide, please. So their patient and port position, the patient position is modified Lloyd-Davis position, bolstered below the sacral promontory, and Trendelenburg position. Why this position? I tell you, when we are doing the surgery in pelvis, you cannot increase the space of the increase the space of the pelvis by reducing the content of the abdomen or pelvis. So for that matter, the maximum peritoneal cavity space is when the patient is lying supine. But in pelvic surgery, we have to have access through a perineal region also. So that's why this modified Lloyd-Davis position is the ideal for this. What does this bolster do with when we put below the sacral promontory? Because it lifts the sacral promontory up and it breaks the pelvis, so that when you put all those small bowel, which is mainly the ileum, out of the pelvis in the right iliac fossa, because the normal lie of ileum is the right iliac fossa and normal lie of the jejunum in the left hypochondrium. So in the pelvis, it is mainly the ileum. So if you take out the ileum and place above the sacral promontory on the right side of the abdomen, then it will not come again and again unless until आपकी anesthetic से दुश्मनी नहीं हो. Because if anesthetist pushes more of nitrous oxide gas, it causes the dilatation of the small bowel. If the dilatation of small bowel is there, it will occupy more and more space. If they occupy more space, you will be having lesser space in the pelvis and the abdomen for surgery. So to be very friendly with the anesthetist. Next slide, please. So how to get a good working space in the abdomen and pelvis? Avoid pre-operative PC enema or rectal suppository. Please don't give these causes by local factors, dilatation of the rectum and the sigmoid colon, which is a problematic during the surgery. Modified Lloyd, as already have explained. Avoid nitrous gas, and instead of nitrous, use air. Ask anesthetist, please use air, because it will not cause dilatation of the small bowel. Use the combination of anesthesia like general anesthesia plus epidural. Why? Because epidural causes sympathetic blockade, and because of sympathetic blockade, it will lead to small bowel smooth muscle contraction. And if small bowel is contracted, they will occupy a lesser space. So you will be having a good space in the pelvis and the abdomen for the surgeries. And the effective head low position. Next, please. Here, the retraction of the bowel is very, very important in these surgeries. Take at times the previous surgery or some because of some chronic infection, you have to see whether there are some omental or mesenteric adhesions between small bowel and the colon is there or not. If they are there, then you have to cut those adhesions first, because unless until you cut these adhesions, your small bowel and omentum will not go in the upper abdomen of the upper abdomen. Then it will be difficult for you to retract all those bowel. Taking down of falciparum ligament helps when you are pushing the bowel out of the pelvis. Mobilization of sigmoid colon, in the maximum number of cases, you will see there's normal congenital adhesion of the sigmoid colon to the lateral pelvic wall. If you take down those adhesions, that sigmoid colon you can pull out of the pelvis and it will lie down in the upper part of the pelvis, so that it will not come again. So you will be having more space in the pelvis. Use of gauze piece at times helps. You can even retract suture with the help of suture. You can apply suture on the tinea, especially in the obese patient, and take that suture outside of the lateral abdominal wall on the left side. That helps also in the retraction of the bowel. And next is, I'm not seeing it. So here, this is one retractor which we have designed and which made. See how it. This is absolutely non-traumatic. Please play video. This is absolutely non-traumatic instrument. It is like a finger retractor, but is a curved. The jaws are thick. They will not injure anything, and you can retract this small bowel like this way. I'll show in the next video how it helps in your retraction. This is a very, very fatty patient, very, very obese patient. I could not remove this bowel out of the pelvis. So here, with the help of gauze and this instrument, see how wonderful you can retract all these small bowel and see the picture, see the pelvis. You can do wonderful bowel retraction with this instrument. And again, these are congenital sigmoid colon mobilization. Adhesions are there in the little pelvic wall, which you have to cut. Then it will help you in a great like this. These are the congenital adhesions. If you cut these adhesions, the sigmoid colon will come out of the pelvis, and you will have a. You don't have to retract or use any instrument to continuously retraction of this small sigmoid colon. And when doing dialysis, I always use a cold scissor. And then the energy sources, bipolar is the mother of all energy sources. You should not be doing surgery without having bipolar on the OT table. You can use LigaSure,
Dr.
harmonic.
Arvind, 2 minutes to go.
Okay. I'm just about to finish. So even if you are everything when fails, bipolar works. Personally, I am not in favor of using monopolar cautery in pelvic organ surgeries. And one important point I want to tell you is harmonic scalpel, if you are using for more than 10 seconds of continuous use, will have a equal lateral thermal damage as a monopolar current if you are using that monopolar current for more than 3 seconds. Next. So by doing sharp dissection, the right plane, like whether you're doing dialysis or dissecting bladder out of the cervix, lateral to or medial to lateral bladder dissection. In the previous cesarean section, you have to do lateral to medial bladder dissection. Pad belongs to bladder and rectum. Do not go lateral to the uterosacral during colpotomy. Avoid excessive use of energy at the angle. At times, there is a oozing at the angles of the colpotomy. You should not be using a cautery inadvertently without seeing actual bleeder or ooze. You just place a gauze piece, give a pressure for a minute. You will see 99% of time that bleeding ooze stops. So don't do excessive use of energy at the angles, because where there you can injure the ureter. Proper traction and counter traction during colpotomy. Use of blunt dissection with suction cannula in case of endometriosis. Avoid using monopolar current. Movement of instrument should always be parallel to all the tubular structure in the body. Next. And if you teach your youngster or your colleagues, ultimately you learn also. Thank you, madam. Thank you very much. I am open to take any questions right now.
Thank you, Dr. Arvind.
Thank you very well.
Thank you, Dr. Arvind.
Thank you,
I think after listening to all the 3 lectures on pelvic floor spaces, the energy sources, and the tips and the tricks Dr. Arvind has said, I think all of us are ready to go to the OT. One question to Dr. Arvind, this putting a bolster under the sacrum, a question has come in the chat box. Won't it alter your anatomy and tilt the pelvis? Can you just elaborate on your trick of putting a bolster under the sacrum, please?
It has to be put at the level of anteriorly, if you see it is anterior superior iliac supine, and the posteriorly it is at the level of sacral promontory. You have to put, you break the pelvis into 2, and once you place that, the sacral promontory lifts up, and if you place the ball out of the pelvis outside and in the right iliac fossa, then those ball will not come again and again into the pelvis. You don't have to use your assistant instrument to continuously retracting that ball.
Exactly. So the
Number
point
two,
to remember, yes.
Number two is you don't have to give too much of tenderloin position into this after using bolster. By giving only 15 to 20 degree of head down position will be suffice.
Yes, so that is the very important point as asked in the chat box, that it is just the lifting up of the promontory. It acts like a bridge, and beyond the bridge you park your gut.
Small bowel. Yes.
Yes, small bowel. And Dr. Malvika, there was one thing about the energy sources which you have very nicely highlighted. I would like just you to summarize in your case. In which case would you like to use the HD 1000i and the fusion energy sources?
1000i is a wonderful instrument, and it should be using in all the cancer surgeries, especially when you're dissecting around the vessels, lymph node dissections around the ureter. In normal cases, it doesn't, I mean, I don't see the advantage of that as compared to what you get advantage in the cancer surgeries, be in Gynae or other GI or all those advanced surgeries. Second thing is, when you're doing this thing, endometriosis cases, you should not be using harmonic or ligation. The best instrument for that time is bipolar or Caesar and suction. You should not be using any this harmonic or ligation. They will not be of much use. Okay.
Right. Thank you.
Yes.
Thank you, sir. Any questions, Jyotsna, in the chat box? Dr. Jyotsna, any questions?
I think we can just wind up. One thing was Dr. Sandesh Kare has very nicely commented on the dissection of the spaces, and also he's given emphasis on the nerves, because as more and more complicated surgeries are being taken up, one needs to train our eyes to see the nerves, because damage to that is going to cause devastating effect on the bowel function, the micturition, and sexual activity. So he's very nicely pointed out. The other thing that I would like to ask Dr. Malvika Sabharwal would be the mechanism of this bipolar shears, which are much cheaper, and many of us are using it now.
Dr. Malvika, are you there?
Anne has left.
Dr. Malvika, are you there?
Since she is not there, can I comment on that?
Please.
Yeah, please.
Dr. Rajesh Modi here.
Hello, Dr. Modi. How are you? Welcome.
I am fine. We're talking about the bipolar shears. I personally do not recommend the use of bipolar shears much because the current settings required for the bipolar shears is very high. Normally, if you're using bipolar at a lower setting of 18, 20, 25, when you're using the bipolar shear, you need the wattage at 60, 65, even 70, which I believe is an extremely high wattage to be used. So if you have a choice between an ultrasonic and the bipolar shear, the ultrasonic is way ahead. But there is nothing against using the bipolar shears. You can use it, but if there is a choice, like I said, there is a significant difference in the output because ultrasonic will not have any lateral spread, while as the bipolar shear, because of the high wattage being used, may still cause lateral wall damage.
Thank you, sir. Well taken. Well taken.
Hello. 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 Any more questions for the first session, Dr. Geeta and Dr. Jyotsna?
I don't think there is any. No.
No, I would just like to make a comment. Can you hear me? This is Dr. Chandan here.
Yes, Dr. Chandan.
Yeah, I just wanted it. All three lectures were really very well presented, and just a comment on Dr. Malvika's lecture. She and that point in her lecture about the bipolar getting stuck in the tissues and the main disadvantage being S-char formation. So a very nice tip for that is that if you keep stepping on the pedal while you're activating the bipolar and open the jaws before you step off the pedal. Then this is for all who are practicing a lot with bipolar forceps. The bipolar doesn't get charred and there's no S-char on it, plus there's no blackening of the tissue also. So the small tip I've learned, you just step off the pedal, keep stepping on the pedal, open the jaws and then step off the pedal. Because you know what, if you step off the pedal and then open the jaws, the cooling which happens causes it to get stuck there. So that's a very easy tip. You don't have to clean your bipolar again and again. Thank you.
Chandan, thank you.
Excellent.
For that.
Very nice.
Thank you, Chandan.
Thank you. Thank you, Dr. Chandan Dubey. Thank you.
Welcome. So, any more questions, Dr. Geeta? No. So, I thank all the chairpersons and the wonderful speakers for this session on basics of endoscopy and laparoscopy. And having learned this, after this, we move on to the next session, which is session 2. And I'm happy to take this opportunity to introduce my co-chairpersons. Dr. Kaval Gujral, Madam is the head of the Department, Institute of Obstetrics and Gynecology at Sir Gangaram Hospital and scientific advisor of this conference. Dr. S.S. Trivedi, Dr. Indu Bala Khatri, she is senior consultant obstetrician and gynecologist, gynae laparoscopy surgeon at Moolchand Women's Hospital, Delhi. And Dr. Professor S.S. Trivedi, she is the former director and professor and head of the department at Lady Hardinge Medical College and my teacher at LHMC. She is currently director at SGT Medical College, Gurgaon. And for this session, I take, in fact, it's my honor to invite the first speaker of this session, Dr. Rajesh Modi. Dr. Rajesh Modi is known to this August gathering. He is a gynae endoscopic surgeon from Akola, Maharashtra, and he is the pioneer in daycare laparoscopic hysterectomy and aqua dissection for bloodless myomectomy. And Dr. Modi's tubal recanalization technique. And he's a very good mentor for budding endoscopists. We are all waiting to hear from you, Dr. Rajesh Modi. Over to you.
Thank you very much for the kind introduction. I'm going to be talking on my favorite topic, which is laparoscopic hysterectomy, and more precisely because there is a time specific allotment. I'm going to focus on only one carry-home point, which is important regarding the daycare hysterectomy part. So it's almost 15 years now that all my hysterectomy patients are admitted in the morning. They get operated in the morning hours, and in the evening, post-operative 5 to 6 hours, they are ready and comfortable enough to want to go home. That is exactly what is daycare hysterectomy. Morning admission, surgery, and evening the patient can actually be comfortable enough and patient can be relaxed enough to want to go home. It's not about sending the patient home in the evening or pushing the patient out of your hospital. It's more about making the patient comfortable, pain-free, no nausea, no vomiting, with a clear-headed recovery within your own center. Whether the patient actually goes home on the same evening or the patient is going to go after a couple of days does not really make much of a difference. You need to be able to actually see the recovery. What we use is the laryngeal mask airway, which you can see over here. So there are a lot of small changes which happen. This is 3 hours post-op. Within 3 hours of the surgery, the patient is comfortable enough, alert, pain-free, awake. We do not use nitrous oxide, so the patient is allowed to have solids as well as liquids immediately in the post-op period. There is no IV fluid which goes on. 1 liter of saline I leave in the peritoneal cavity, so the patient is not going to have any IV in the post-op ward. We do maintain the IV line for the duration that the patient is in the hospital. There is no catheterization required post-hysterectomy. On table, I would pass a simple catheter, but we encourage the patient to get up and go to the bathroom to pass urine so that they get mobilized faster. So this you can see is almost 4 hours post-op. So within 4 hours, the patient does not exhibit any symptom that she has been operated or a major surgery has been done in the morning. You actually have to see this yourself to believe in it to this extent. 6 hours post-hysterectomy, my patients are comfortable enough. Like I said, it is not about pushing the patient home. It's about allowing the patient to be relaxed and comfortable, pain-free, nausea, vomiting free, so that they might want to go home in the evening. Because it has been 15 years that I am doing this, today when our patients come to the consulting for the purpose of surgery, they come mentally prepared that evening they are going to go home. This is 10 years back. This was a workshop which I did in Nagpur, and the patient was operated in the morning. Around 11 o'clock we finished the surgery, and 5:30 p.m. for the lamp lighting of that same workshop, the patient came to the auditorium to talk to the audience. So she even went home, got changed and came. So you can see from the expression on her face, you can understand from the appearance of the patient that she is genuinely relaxed and comfortable. So what exactly is it that makes this possible? So there are a lot of changes. There are probably 100 small changes which come together to give this particular impact. But what is relevant is to be able to do surgery with minimal tissue trauma, with minimal blood loss, and minimal tissue handling even. So like I said, there will be probably 100 small things which come together to give the impact. Today, what I am going to focus on is one single carry-home point, which allows you to understand what makes it different. And the single most important factor is the uterine artery dissection. Now, a hysterectomy is very routinely done by almost every gynecologist. A laparoscopic hysterectomy is being done by at least half the gynec population. The important point is to prevent bleeding from the uterine bundle. Once you understand how the blood flows in that area, once you understand how to dissect the uterine, then every single hysterectomy becomes very comfortable, very easy for you to perform. So if you look at this, the carry-home point which I want to highlight on. So the UA fold has been separated, the bladder has been pushed down. Important point, the difference what I feel is this: you should dissect the bladder pillar down. So here what I am doing is I am separating the bladder pillar area. The yellow part is the bladder pillar part. So there will be some amount of fat, there might be some small vessels. There is no hesitation in using cautery to a certain extent in this region. Do not push the foot switch for an extended period of time. Give short bursts of the current. So anteriorly, the bladder pillar has to go down. This is the ascending part of the uterine. This is the UV fold. Where the UV fold has been cut, below that level, you have to dissect the transverse part of the uterine. So from the perspective of a routine hysterectomy, the dissection which you are seeing on the screen now is already completed. Anteriorly, the bladder pillar has gone down. Posteriorly, the broad ligament fold has gone down. The difference which comes is to be able to dissect the bladder pillar down a little more. So here what I am dissecting is pushing the bladder pillar down. The moment you lift the bladder pillar away, the transverse part of the uterine says hello to you. So here you can see that the bladder pillar is being dissected. Some amount of current has to be used, but do not push the foot switch continuously for an extended period of time. Give short bursts and low current settings. I have an Allen cautery which I keep at 1/818. So this is a bladder pillar being pushed down. The moment I push the bladder pillar further down, the entire transverse part of the uterine identifies itself, and this is what is called a skeletonization of the uterine. Once you learn this one step of skeletonizing the uterine, every single hysterectomy becomes comfortable and convenient. Pushing some part of the posterior leaf of the broad ligament down. I have a habit of separating the uterosacral in the beginning. When I dissect the posterior leaf of the broad ligament, I separate the uterosacral. Once you separate the uterosacral, the ureter gets pulled laterally away from your field of surgery. So anteriorly, that is the ascending part of the vessel. That is the transverse part of the vessel which is dissected. A nice 3 to 4 centimeter segment of the uterine has been dissected, and you do not need to dissect any further. What I am doing now is separating the artery from the vein. This is just trying to make you understand the blood vessel and the supply. This is not essential for dissection in every hysterectomy. This is to make you understand, and you should be able to do this to become comfortable and friendly with the uterine vessels. So this is a uterine artery, totally skeletonized. You can see the descending branch also coming out of the uterine. Where the UV fold has been cut is the level where I am going to coagulate and cut off the uterine. So the dissection goes significantly lower down. Simple trick is push the bladder pillar down significantly more than what you have been doing till now. The entire transverse part of the uterine pops out of its own location. You do not have to coagulate the transverse part, but having dissected the transverse part gives you a nice 2 to 3 centimeter segment of the uterine which can be then coagulated and cut off. Your safety margin increases significantly and your hysterectomy becomes foolproof. I would never worry about having a reactionary bleed in any of my patients. The same step is now being repeated from the other side. This is the transverse, this is the bladder pillar area. Lifting the bladder pillar area. See, already the dissection is completed. Normally what you would do, that anteriorly pillar is down, posteriorly broad ligament is down, but this extra step of pushing the bladder pillar down slightly more, gently tease the tissues, the yellow part, the fat part has to be lifted up and pushed down. So it's not very difficult. Push the yellow part down. The yellow part is fat. It is a bad conductor of current as well as a bad conductor of heat. So do not be scared of using current in this area. I have already mentioned, don't push the foot switch for a long time, but you can use cautery because the yellow part, the fat part, which belongs to the bladder pillar, does not easily allow the heat and the current to go towards the bladder. So this is the transverse part of the uterine, which is now skeletonized. Once you start doing this, within 10 to 15 cases, you will realize that you can do it in almost every case. You become much more confident in your hysterectomy. And then when you add on the other parameters which allow your patient to recover faster, you can actually develop the daycare hysterectomy concept at your own place. the level which I'm coagulating is significantly higher up compared to the level which I have dissected on the lower down area. The transverse part of the uterine is not to be coagulated, but we prefer to separate or to dissect it because it allows us to have a better control of the same. I'm going to forward this because I think you might tell me that we are running short of time. So I'm dissecting the transverse part of the uterine a little bit more. Now this is something which takes about 15 cases on an average. My experience is that most of my students have a learning curve of 15, maximum 20 surgeries. Once you are able to dissect the uterine in these 15-20 surgeries, in every single hysterectomy, it becomes the same. Do not try to do that in a bulky uterus or a chronic cervicitis patient because there is hardly any uterine to dissect. The bigger the uterus, the bigger the fibroid, the more prominent the uterine, the more prominent the areolar tissue, and the more surgeon-friendly atmosphere there is. Now, this is an important same technique, but with the ureter glow catheter being put inside. This is a Stryker AIM system. The infrared glow of the catheter shows that the moment we have separated the uterosacral, the ureter has fallen back. If I have not separated the uterosacral is towards the uterus, the ureter is also slightly pulled up. So here again, understand that this is an extra dissection of the bladder pillar being done. Normally, simple guiding principle is anteriorly the bladder pillar should be below the level where you are going to coagulate. Posteriorly, the broad ligament should be below the level which you are going to coagulate. This is a little extra dissection which I am doing for the transverse part. Uterine is a tough muscular organ or a structure. Don't be scared of the uterine. Become comfortable, become friendly with the uterine. You should be able to hold and manipulate. It becomes easy in every case. Now here, this is the transverse part sitting on the ureter, water flowing under the bridge. So here you can see that I am allowing the uterus to fall back in the pelvis. Important point is traction. Single important point throughout the surgery is traction. When you lift, the transverse part is lifted up. The ureter does not get lifted up. Ureter stays on the lateral pelvic wall. The transverse part we dissect in every hysterectomy, but we do not coagulate it. Ureter is still far, far, far away. Don't be scared of the ureter in all your cases. And it actually becomes convenient enough for you to be able to do a hysterectomy without any bleeding. If you can prevent bleeding, that is the best way to achieve the outcome that you wish to have in your surgeries. Daycare has got a lot of concepts. There is a lot of changes which we have made in the surgical steps, in the post-op care, as well as in the anesthesia protocol. For example, like I said, that we do not use nitrous oxide as a part of the anesthetic gas because the nitrous oxide will cause bowel movement inhibition. Recovery is slightly delayed. The patient may not tolerate liquids and solid as early as what we do. Apart from that, the simple concepts like only on table, we pass a simple catheter in the bladder. The bladder, I prefer to have it empty when I am dissecting the bladder or when I am suturing the wall so that it does not come close to my field of surgery. But in the post-op period, we do not prefer to keep any catheter in the bladder. There is no harm in keeping it, but it is just a routine practice which we have set. I leave 1 liter of saline in the peritoneal cavity. There are multiple advantages to it. It allows removal of the gas completely. When we deflate the abdomen, whatever gas is there in the paracolic area, whatever gas is there in the bony pelvic area, because the saline fills up those spaces, the gas is lifted up, gets removed completely. None of my patients will complain of shoulder pain. A very small concept, but it matters. The moment there is pain, the moment there is difficulty in breathing, the patient is going to panic and they are going to become a little scared. That in itself will cause more of muscle rigidity as a spontaneous reaction. So all these things matter to a certain extent in giving a collective result of a comfortable, pain-free recovery to the patient. I would like to invite any questions rather than just giving a talk, if that is okay with the moderators.
Yeah, that is there. If in case there are any questions, they can ask you right now. Otherwise, yes, Dr. Indu. Thank you, Dr. Rajesh Modi, for such a nice presentation. It's always a treat to hear from you. We should also take away the fear of premature post-surgical discharge of our patients. Instead, we should also start discharging the patients and make it a habit to send the same day. After hearing this lecture, we are really enlightened. In the literature also, I found many of your publications which were showing that discharge should be the same day. Let's go to the questions.
Dr. Mamta, can you hear me?
Yes, Dr. Gujral.
There's a question from Dr. Manju Kimani for Dr. Modi. What post-op analgesia he uses? Post-op analgesia.
As far as analgesia or pain relief is concerned, what I personally prefer is we give 1 gram of paracetamol intravenously. The 100 ml bottle of paracetamol is given intravenously on the table during surgery. We use ropivacaine 0.75% 20 ml. Earlier I was using sensorcaine 0.5% 20 ml, but we have shifted to ropivacaine, which is 0.75%. 10 ml is injected into the peritoneal cavity. It gets diluted with that 1 liter of saline. 10 ml we inject into the port site. So this gives a fantastic amount of peritoneal analgesia, because the peritoneum which has been cut or has been injured causes pain sensation, which is taken care of by this. 1 liter of saline will be absorbed over a period of 10 to 12 hours, so that ropivacaine acts for 10 to 12 hours. And we give diclofenac suppository at the end of the procedure. So these 3 things, 1 gram of paracetamol IV, ropivacaine and diclofenac suppository is sufficient for the first 24 hours. From second day, we give a tablet paracetamol diclofenac combo morning, evening, twice a day.
Also, Dr. Manju Khimani has written, bowel sounds are usually not there. How do you allow eating 4 hours after surgery?
Using atmospheric air, we have air compressors now available. So we use atmospheric air and oxygen as a mixture for the anesthesia part. Do not use pure oxygen, do not use oxygen with nitrous, because that causes small bowel movement hampering. But if you use normal air for the ventilation, compressed air, it does not cause any small bowel movement hampering. So there is absolutely no interaction between the bowel movement and the anesthesia or the surgery. If there has been not much of bowel handling which has been done, the bowel movement does not go away at all. So within 2 hours of the post-op period, patient can be made to have solids. Bowel movement is not affected at all.
Thank you. In the chat box, I cannot see any more questions.
No question from my side also.
No, there is one more. Dr. Sanjeevni Khanna, she's asked, do you like to recommend transversus abdominis block?
Blocks are very good, but I personally am not using it because I find it requires some amount of expertise to give a particular block, and it's a little, it requires some skill, so which I am not patient enough to develop that. My anesthetist had recommended a couple of times that we can give blocks, but not been used as a routine at my procedure. We just simply inject in the port sites. Block would be better.
Okay, thank you.
Thank you.
After this, there is none.
Thank you, Dr. Modi. Thank you for the wonderful video presentation and session and resolving to the queries and taking questions here only. And now we move on to the next speaker. And it is my honor to introduce the next speaker, who is none other than Dr. Vivek Marwa, who is the Director of Division of Minimal Invasive Gynecology at Max Super Speciality Hospital, Saket, New Delhi. And I must share here that I had the opportunity to assist with him when he was at Gangaram Hospital. And I know how easy for him to make a difficult TLH easy. And this is the topic for his presentation today, difficult TLH made easy. And we would like to hear from you, sir. Let all the viewers also get benefited from your surgical skills. Over to you, Dr. Marwa.
Dr. Marwa, are you there?
Dr. Marwa is there.
So I would request you unmute, please.
Yeah. Can you hear me?
Yes, sir, we can.
Okay. I've shared the screen. Okay. So you have the picture?
Yes, yes, we can see.
Okay. Very good afternoon to all of you, and it's been always a pleasure to be back on the podium of the parent Gynae and Endoscopy Institute, and it's really nice to see all of you again. Now, the topic for today is difficult TLH, how to manage, and my predecessors have done a very good job. From the morning, they've been feeding you about energy sources and all, and let us see how to manage TLH and how far we can go with it. It's like a theory of relativity, you know, managing time, space, and energy. So in that way, we can manage the difficult TLH, and it is basically a combination of evaluation of the patient and the pathology. A proper evaluation will go a long way in managing a difficult TLH. And yes, not to mention the experience and expertise of the surgeon is equally important, which will obviously increase over a period of time if they persist over it. And yes, equipment, a good equipment with a very good optics is also a must. And yes, we've been from the morning listening about the energy sources. So we will say how we can use the energy sources and even get away with that. So to start with, a proper patient positioning is very important, which we all know. You can use an Allen stirrups with the Trendelenburg position, or we have modified, you know, this is our version, which is not that very costly, but it works equally well. And then you need a proper, good, adequate hand instrument with very good optics. And then, yes, the energy sources, I won't go much in detail. There are various armamentarium available for the gynecologist today. But can we do up with these? Can we manage it just with the simple sutures? And we have on the horizon more suturing devices coming up, making things easier, like Overstitch and ProxySure, which are going to be released in the international market soon. And we feel a good uterine manipulator will go a long way in making a difficult TLH easy. And you can see it's the time I said 1989 when first TLH was done by Harry Reich. At that time, you know, the basic TLH was very difficult for him. So it is for anybody who's going to start a TLH, the first thing which they're going to do is going to be a difficult TLH for him. But if they are in the right plane of dissection, the right, you know, the steps which are taken, like here we are just mimicking the abdominal hysterectomy. So most of the steps can be, if they can be mimicked and properly done, you can easily proceed with. So it was about the time also is important as far as the difficult TLH is concerned. But as time goes by, things become easier and more difficult, challenging cases can be taken up. This is just to show you how a uterine manipulator virtually lifts up the uterus, highlights your uterovesical fold of peritoneum, making your bladder dissection easier and also the dissection of the rectosigmoid easier. Now you can see we are just going, lifting up the anterior leaf of broad ligament, creating a window in the posterior leaf of broad ligament, skeletonizing the uterines here. Now this is the uterine cup which is virtually lifting up the, you know, vaginal wall, and this is the uterovesical fold of peritoneum which is being easily dissected over, and you don't, you know, most of the time you can do away with the energy sources if you are in the right plane of dissection. The posterior window created, the uterine bundle has been skeletonized, and you can see the uterus which is lifted up, the uterines have been taken care of both the sides. Now we follow up uterine first approach. The reason is, like, if you have big myomas, you know, that is also make things very difficult. But when the size of the fibroid and the uterus increases, the idea is then your port placement has to be much higher up. And you can see here, that's the cervical cup lifting up the uterus. The idea is to cut off the blood supply to the uterus first. And you can see, again, we have gone through the anterior leaf of broad ligament with the Metzenbaum scissors, dissecting over the UV fold, and the bladder is shifted down over the cervical cup. That is the uterine bundle, which is on the left side, a big thick uterine, and the posterior leaf of broad ligament has been opened. The uterines have been skeletonized and a good suture placed there. So the idea is, if you can cut off the blood supply to the uterus first, then the dissection becomes much easier. And you can see we have taken the tubo-ovarian ligament also along with the round ligament. This just needs a little skill and a good endosuturing, which most of our Indians who are doing advanced laparoscopic surgery are very good, in suturing. And you can see on the right side also, we have cut off the blood supply with the uterine bundle is being taken care of. And so the size does not matter if you have a proper access to the vessels. You can see the uterus was nearly 34-week size uterus, and with the tenaculum will pulling the uterus on the other side. Now this ovary was endometriotic and adherent to the uterus, so we've just taken the infundibulopelvic ligament there, and the round ligament also has been taken care of. And once the vascular supply to the uterus is cut off, you can just, with the hook scissor, cut them off, and we are just giving hybrid loop. This is a hybrid loop which we formed sutures to support the initial sutures so that they don't, leak or become loose. And this is again the cardinal ligament has been taken here, and that is a uterine bundle which is being again supported by another suture because the thickness of the blood vessels was too much. So as a safety mechanism, routinely we don't do it, but unusual circumstances require unusual approach. So that is why we are doubly suturing them so that they don't fold. And this is the cardinal ligament being dissected with the hook scissors over the cervical cup, and again a suture applied over the uterine bundle. Now once the whole blood supply is taken care of, the uterus is cut off from the pedicles, that's the colpotomy being done over the cervical cup, and then the uterus was morcellated and retrieved, and the vault was sutured. So you can see that most of the procedure can be carried out without using any thermal energy. Sometimes you don't have an anterior access to the uterine, then you can go posteriorly. Now this is just to show you, this is the uterine artery over the cervical cup, a case of previous to LSCS where the bladder was anteriorly adherent. And this is the uterine bundle which is being dissected over the cervical cup. The cervical cup gives you a tactile sensation feeling and makes things much easier and helps you to skeletonize the uterine vessels here. Now you can see the yellow fat belongs to the bladder, and we are slowly, steadily shifting it away from the uterine. And once the uterines have been isolated, skeletonized, you can take the uterines with a standard 1-0 Weichel suture, and you can see the uterine on the left side has been taken care of. Similarly, on the right side, now we are starting the skeleton. The uterine is being skeletonized, and you can see the bladder is shifted anteriorly. Now, without dissecting the bladder completely, we have taken the uterine on both the sides, and then we can easily proceed with the dissection. And you can see that's a suture which has been taken on the right uterine bundle, and both the uterines have been taken care of. That's the ureter to show you how much difference is there between the ureter and the uterine vessels. Now that is the anterior leaf of broad ligament being dissected. Once the uterus is devascularized, mostly because once the perfusion pressure of the uterine goes off, the amount of bleeding from the uterus will be very minimal. And you can see the infundibulopelvic and the round ligament taken care of on the right and the left side now. And the whole blood supply is being cut off. The bladder is yet to be dissected because we need a better, it was very badly stuck there. So we need a better, view. And once the uterus is totally devascularized, so the dissection of bladder becomes very easy. The uterus is retroverted now, and with the bowel grasper or atraumatic grasper, we are holding the bladder and dissected over the cervical cup. So the bladder is also well dissected, again followed by the transection of the cardinal ligaments and the colpotomy being carried out. And you can see slowly, steadily, the whole uterus is virtually, the colpotomy is being carried out, the whole uterus is dissected out. And once that is done, we secure the uterus being removed to the vagina, we secure the uterine pedicles with hybrid sutures. This is just a safety, double back safety mechanism. And in interrupted sutures, we are closing the vault. And the vault is with the uterosacral, the posterior and anterior vaginal wall, and the cardinal ligament. That is the angles which we take. So the anchoring of the vault is also equally good. The same steps which you do in abdominal hysterectomy are being repeated in the laparoscopically. And this is the pedicles which again are being closed down with the hybrid loops. So that was the end result for that. And then you have cases, difficult, severe, and case of severe endometriosis, a frozen pelvis. You don't know where the uterus is because the bladder is stuck to the rectum there. She had an endometriotic cyst here. And so slow and steady dissection, we tend to deflate the ovarian cyst so that we'll get some more space to dissect. And now you can see the rectosigmoid is being held with a 10 millimeter bowel grasper, and with a soft traction, I am cutting towards the bladder. Always, and you can see the fundus of uterus coming up now here. Always the tip of the medicine bomb scissors should be towards the structure which is less, harmful, amenable to harm. And you can see we've gone through the superior leaf of broad ligament. That was the external iliac. You have the obliterated umbilical vessel coming up here. And we've gone retroperitoneally. And you can see this is the ureter being dissected because this is the area where we'll have better access. And you can see this is the uterine vessel, obliterated umbilical vessel, and that's the ureter. And the uterine is being taken care of at the source. And you can see with the suture without needle, that is 10 vital suture, we are just taking the uterine at the origin. And once that is done, we proceed on the right side. The basic format remains the same, cutting off the blood supply to the uterus. Once you achieve that, you can see this is the right uterine here, obliterated umbilical vessel, that's the internal iliac, and the uterine has been taken care of. And once that uterines have been taken care of, we proceed, come out toward the pelvic brim. And this is the deflated ovarian cyst, which is being lifted up. Now the traction is over the ovarian cyst, so the dissection from the rectosigmoid becomes easier. And my tip of the scissor is facing toward the sigmoid, toward the ovarian cyst and the uterus at the back of the uterus. And the sigmoid is being dissected totally free, and the pouch of Douglas is being cleared off. Now that's the infundibulopelvic ligament, which has been isolated. Again, suture applied there. The bladder was still stuck to the uterus anteriorly to the fundus. Slow, steady dissection. The idea is to go into the right plane of dissection. So once you are in the right plane of dissection and you have cut off the blood supply to the uterus, chances are less the bleeding will be very less. And even if you have some bleeding, usually the oozing would stop in say 4 to 5 minutes of time, and that is fair enough. And you don't need to cauterize it. But it is not, we always keep a bipolar ready on our table. So you never know when you have a good spurter coming out somewhere, you can always use it, but most of the time you will not. And you can see here at the pelvic brim, again we are proceeding. It's always better, that's the ureter there. It's always better to proceed from the normal to the abnormal anatomy and then come down. You can see this is the rectovaginal septum which has been cleared. The pouch of Douglas is totally cleared off. And that was the uterosacral, and we are just cutting the scissors with the scissors over the cardinals, and that's the uterine which has been sutured there. The rectovaginal septum, the pouch of Douglas is cleared, the rectosigmoid has been shifted virtually down, and once that is done, you can see the whole uterus is devascularized, and you can see with the cardinal ligament cutting up again, and the colpotomy being carried out. So the idea is to always proceed from the normal anatomy. If the whole frozen pelvis is there, go to the pelvic brim, get a point there and start and delineate the normal anatomy, and then you can start. Now again, hybrid sutures being applied over the infundibulopelvic. The whole pouch of Douglas is cleared. The rectosigmoid has been well dissected away, and this has been taken care of well. Then obviously things become more difficult. This was a case of previous LSCS with severe endometriosis, with multiple myomas and a cervical fibroid. So making things much more messier and difficult. You can see the bladder virtually stretched over the cervical fibroid, and you have the endometriotic cyst on the right side. You have an endometriotic cyst on the left side. To start from the pelvic brim, because that is the place usually where you don't have those adhesions there. The whole pelvis is frozen. And now we have started, you can see the idea is to delineate the infundibulopelvic and to shift up the rectosigmoid a little away, with the scissor tip being towards the ovarian cyst or the uterus. So you can see the sigmoid is now being shifted away. That's a tube coming up, and this is the posterior leaf of broad ligament which is being dissected so that the ureter, does not get trapped in those adhesions, and we want it to be shifted away. And you can see this is the ureter. Now I am putting my irrigation suction cannula away from the ureter, and this is all cicatrized fibrotic tissue with which I am lifting up the infundibulopelvic, and the ureter is dissected. Now this is the internal iliac and the uterine there, obliterated umbilical vessel. The uterine is being taken care of. This is the infundibulopelvic. You can see the ureter down below there. So the idea is to skeletonize well and go into the right plane of dissections. You can see the bladder being shifted here over the cervical fibroid. Now you can see with the gliding movement, bladder can be easily, once dissected in the right plane, can be shifted down. This is on the right side again. The ovary is lifted up. This is all cicatrized tissue. Go higher up at the pelvic brim where you have a normal tissue. Try to find your ureter there and then go along with the ureter. Now you can see I am not lifting up the ureter, but I am lifting up the tissue just behind it. And even my movement of the instrument is just above or by the side of the ureter. Now you can see the infundibulopelvic ligament has been isolated here on the right side. Again, that's the uterine being dissected and uterine being taken care of. And once that is done, the round ligament is being taken care of on the left side. Still now, the lower dissection, the areas are still frozen, pelvis is still there. So that also will be taken care of. And then we need to proceed slowly and steadily, isolating the normal anatomy, proceeding towards the abnormal anatomy and dissecting it out, further. So you can see the vascular supply, once it is cut off, the dissection of the tissues over the uterus becomes much easier and the oozing is hardly any there. So as I said, the basic format is that take the uterine first and take the vessels first. Now you can see at the posterior surface, you have the rectosigmoid stuck there. At the back of the uterus, that is the cervical cup there. This is the cervical fibroid. Though it's a slow, steady dissection over the cervical fibroid, a combination of blunt and sharp dissection. And you can see the cervical fibroid is coming up and the colpotomy coming out here. And you can see the whole cervix being there. That's the lip of the cervix, and that's the cervical myoma which has been removed. Again, removed vaginally. Hybrid loops taken, applied to take the infundibulopelvic ligament. So you can see, and now the vault is being sutured back. So the idea is that you need to achieve complete hemostasis, and most of the time, believe me, you will be able to do it as your expertise improves. And you want to, if it's entirely up to you. If you want to do it, you can do it over a couple of months and years, and try to go away from the energy to no energy, and with plenty of energy in the sutures. That helps a lot. So it is all about patience and perseverance, which can make a difficult TLH, it can be managed. Thank you very much all. It was a pleasure to be there.
Thank you, Dr. Marwa. As usual, it was a wonderful presentation, and it's always a pleasure to watch you present your difficult case. You have made it look so easy.
Thank you.
So it was really, really nice. So I don't see any questions here. So Dr. Mamta?
Yes, yes, sir. We can take the questions at the end in case there are any. And thank you, Dr. Vivek, for an excellent presentation. And it's my privilege now to introduce the last speaker of this session, who is known to all here, Dr. Hafiz Rahman, an excellent gynae laparoscopic surgeon from Koshi. He's the chairperson, Sunrise Group of Hospitals, and he's the pioneer in improving the laparoscopic skills of all endoscopic surgeons. And he will be showing us the laparoscopic radical hysterectomy, a step-by-step guide. So over to you, Dr. Hafiz. We would like to hear from you.
Can you give me the option to share the screen?
You can share, sir. You can share, sir. You can share, sir.
Okay. Yeah, fine. Okay, can you see my screen?
Yes, please go ahead.
We can
And
see.
you can hear me well, clear?
Yes.
Perfect.
Okay, first of all, thanks a lot to all of you for giving me this opportunity to see you once again this nice day. When this topic was given to me, I was just thinking, see, I know most of the audience, they are not oncosurgeons. So I thought I'll just make it a little simple or simplified so that they can understand what exactly the radical surgery is, which people feel it is very complicated. Actually, radical surgery for cervix, because only the early stages of CS cervix are surgically treated. It's not really that complicated as what Vivek Marwa has shown, where he has shown very complicated with
Sir,
bowel.
sorry, sir. Can I intervene, sir? Can you just do a speaker view on your screen?
Huh?
Can you just do speaker view on your screen?
Speaker view?
Yeah, on the right-hand side, you must be seeing the 4 images, 4 videos on the panelist. Can you just do a speaker view?
That is speaker view, huh?
We can
now,
see.
what should I do with that?
Yeah, that's fine, sir. Thank you so much. You can continue.
Now, so I thought I'll just make it a bit simplified so that those who are not practicing oncology also would understand. So as in any malignancy, the basic principle is to when you do a surgery, take out the local spread, and local spread is taken by a wide excision, and then take out the distant spread. And this is here by lymphadenectomy and taking out the tissues wherever there can be a distant spread. So if you look at the local spread, see, one of the biggest problem in local spread in to excise the local spread or do a wide excision in CS cervix is, number one, placement of the ureter very close to the cervix, which is embedded in the Meckenrod's ligament and between the uterine artery and the vein. See, this is very, very important because you need to take out the uterine artery as well as the vein out with a good distance. So ureter is actually, you can see, going in between the uterine artery and vein. When I show the videos, you will understand it much better. And another issue which you should address is the presence of the inferior hypogastric plexus, which Sandesh has shown very nicely. The inferior hypogastric plexus near the uterosacral ligament. Sorry, this is uterosacral ligament, just lateral to the uterosacral ligament, where you make the Okabayashi space. You will see the inferior hypogastric plexus. If it is damaged, you can have urinary as well as bowel problems if it is damaged. So these are the two challenges which you face when you do a radical hysterectomy. And another thing which you have to understand is, see, there are only just 3 dissections in a radical hysterectomy. Number one, creating these 2 spaces. If you see this one here, creating those 2 spaces, pararectal and paravesical, which is actually very easy to create these spaces. And understand, you don't have to really create these spaces right up to the pelvic floor, because you're not using it. And if you create these spaces right up to the pelvic floor, as we all used to do before, I feel that we create a lot of damage to the nerve tissues, because nowadays we have to focus a lot on neuronal damage when you do this pelvic sidewall and pelvic dissection, which becomes very, very important. Now, taking the uterine artery at the origin, uterine artery as well as the vein laterally has to be taken, because this is the pathway in which the spread occurs into the lymph node. And the third one in a lateral dissection is the dissection of the ureter, dissection of the ureteric tunnel, because mostly it is at the level of the tunnel which is difficult to dissect and lateralize the ureter, because only if you lateralize the ureter, then only you will be able to take a large chunk of the paracervical tissue. See, most of us, we used to say parametrium. It's not parametrium actually what we are bothered. We are more bothered about the paracervical tissue. It's not on the body. Metrium is basically the body. Actually, it's a misnomer which we all started learning during our PG days, the parametrium. So paracervical tissue is what you have to do, especially when you do a radical trachelectomy, you call it as paracervical. and otherwise you call it as parametrial. Now the anterior and posterior dissection, which is again very important. You need to dissect the anterior and posterior utrovesical fold as well as the uterorectal space. These are very loose planes. The importance of utrovesical is that is one of the first thing which you do in a radical hysterectomy, because if you are not able to dissect the utrovesical fold and if you see the tumor invading into the utrovesical space, then you stop the surgery at that point, because these are non-operable cases and it can go into a radiotherapy. And also posteriorly, you will see a clear space. You will see a very clear space between the vagina and the rectum, and you have to dissect into that denovelous fascia, which is a very clear fascia. Understand one thing, unlike endometriosis, in radical surgery, we are dissecting only through normal tissue. And it's very easy to dissect and it's very, very bloodless. As you will see in the surgery, if you dissect in the correct plane, it will be very bloodless. Now, the second thing in the anterior and posterior dissection is the creation of the parauterocecal space. That is the space lateral to the parauterocecal, and the creation of the space just below the anterior part of ureter, which is known as the Lutsko space, which Sandesh again has described this space. So anteriorly the anterolateral space and posteriorly the posterolateral space is created, so that you will have much lesser nerve damage. This anterolateral and posterolateral space is created well because the nerve damage can be avoided. Rest is the dissection of the inferior dissection, which dissects the vagina at least up to 2 centimeters and take out the vaginal cuff. So if you do this dissection, basically you have done with the radical hysterectomy. Basically, you have to create the lateral spaces, you have to create the anterior and posterior spaces, you have to release the ureter from the Meckendott's ligament, keep it lateral, then just chop off the whole thing. So that is what is radical hysterectomy. Doesn't it look very simple? Because it's just a few steps in this so-called complicated surgery. And I think it makes it very simple, and it's actually very simple if you understand the concept and the spaces in which you are really dissecting. So these are the spaces which you actually dissect and create, and the ureteric tunnel to shift the ureter laterally. Now we'll just go to the video, because I was told this is basically a video workshop. So we'll just go on to the video. This is a radical hysterectomy which is done. Now look at this here. Sorry, just a moment. Just starting with this insertion, this is the way which I do. It's not that everybody has to do like this. I usually put the primary trocar much higher up, and the secondary trocars, only 3 secondary trocars are put, and this is mostly the operating port. Most of the surgeries are done in this port. This is the assistant port, and this is my other port. So I have 2 hands, so left hand on this port and right hand on this, and the entire surgery is usually done from this port in a radical procedure. And here you can see that, as I used to say, laparoscopy is definitely a much better method of doing a radical hysterectomy, no doubt about it. All those studies are actually gone out, those studies which have come, that there are a lot of controversy in the study. Here you can see the external iliac. We're just first opening the space between the round ligament and the infundibulopelvic ligament, just dissecting it slowly. You can see how avascular it is, and you can see the ureter here. And just go lateral to the ureter, you will see the internal iliac. So first thing is you create the pararectal and paravesical space here. So you dissect the internal iliac and see the uterine artery. Once you see the uterine artery, you should understand above the uterine artery, that is inferior to the uterine artery, here is the paravesical space, and below the uterine artery here is the pararectal space. So what I'm telling is, you don't have to dissect it completely down till the pelvic floor, these spaces, and you can see here the ureter going up and down. And one of the anatomy which everybody who does a radical surgery should understand is that the uterine artery goes above the ureter and uterine vein goes below the ureter. So that is why you need to cut the uterine artery, pull it above, and then take out the ureter to lateralize the ureter. I'll show you that on the other side. So here you can see the ureter is taken actually from the origin, and once you clip this on both sides, then you go anteriorly. There are some people who go anteriorly and take the utrovesical space first, so that you can decide whether it is operable or not, because if the utrovesical space cannot be created, you can see this uterine artery going anterior to the ureter. So if this utrovesical space cannot be created, you can say it is non-operable. See, here you can see that you are always operating through a normal space. It's not like an adherent space or anything. So you have a normal uterus. If you don't have an abnormal utrovesical space, this may be classified for radiotherapy actually. Only if you have a normal, non-infiltrated utrovesical space, it is classified for a surgery. As all of you know, surgery is basically for early stages of CS cervix. Otherwise, it should go for a radiotherapy, or maybe a post-radiotherapy surgery can be done. Now here you can see that it's like a U-shaped incision, which usually Pundambekar used to say. There is little difference in how I do and how Pundambekar does. He does a posterior dissection and I do an anterior dissection. Now here you can see here, see, this is the ureteric tunnel. So you can see here, this is the uterine artery going above the ureteric tunnel on the left, and this is the ureter going inside the ureteric tunnel, and it enters into the bladder. Ureter has a course on the uterosacral ligament. It has a course here. Ureter has a course lateral to the uterosacral ligament. Then it enters into the ureteric tunnel. You can see the ureter nicely moving below the fascia. And you can see clearly, in radical hysterectomy, as we are dissecting into the normal space, we always understand. See here, can you see this is the uterine vein? Can you see this uterine vein? So if you do not identify this uterine vein, you can cause bleeding here. Not only that, you can cause bleeding here. This vein has to be taken from lateral here without nerve damage. The ureter has to be isolated laterally, and then this vein also has to be taken, and then the artery also comes out. Then only you will get the proper paracervical region, and this has to be done as a nerve sparing procedure. That is a catch in doing this procedure. See, that is the uterine vein. You can see that very clearly. The uterine vein goes below the ureter and the artery goes above the ureter. So you can see this picture very, very clearly, and you can see that since we are dissecting in the normal tissues, there is absolutely no blood loss in the normal radical hysterectomy. It's not like in an open surgery where you arrange 3-4 pints of blood. We do not even arrange blood for this, and you can see that the fascia on the ureter is actually very well preserved, and there is a normal plane. Can you see that? There is a proper normal plane between the ureter and when it enters into the Meckenroth's ligament, as you can see, and you can just take the uterine artery out so that you can lateralize the ureter very nicely. This is one area where you will have some blood vessels coming in. As you can see here, a half-cut blood vessel can bleed. And this is here. Here you have the Lutsko space, which has to be separated so that you can avoid a lot of nerve damage. So here you can see how the ureter is getting separated slowly. You can see the space there. Can you see that? You can see the space. You can lift up the ureter with the fascia, which is very, very important, which will avoid a lot of ureteric damage. Harmonic here has created a lot of wonders, as you can see. And you can see when the ureter is lifted, you can see the fascia is lifted. You don't hold on the ureter, and you can see the nice space between the fascia and the tissue which you want to remove. So that is how the dissection goes. And that is the uterine vein, which you can see. Once the ureter is a bit lateralized, you can go into the uterine vein and take the uterine vein 1 to 2 centimeters lateral to the cervix. And that is the paracervical region which can be dissected, and the ureter can be lateralized. Once you lateralize the ureter, you have to see whether there is a vaginal invasion. In case of vaginal invasion, you go vaginally and mark the level of invasion and take the vaginal cuff. And if there is no vaginal invasion, you take 1 to 2 centimeters of the vaginal cuff, and this also can be marked vaginally. So this is very, very important to take the paracervical region, and you can see how the rectum can be dissected down. As much as you want the vagina, you can dissect the rectum and then you can take the uterosacral 1 or 2 centimeters here. We don't go into the sacrum, you just take it 1 or 2 centimeters, and it is important to dissect lateral to the uterosacral so that the nerves gets preserved in that area. And once the uterosacral is dissected, you can see here, this is the cervix. You can see the amount of paracervical tissue which can be taken. The ureter, this ureter was actually here. So it can be lateralized and you can take the large amount of paracervical tissue and then you can complete. So actually it becomes quite easy when you do like this. When you do like this, it becomes quite easy because it's unlike endometriosis surgery. Here we are dissecting through the normal planes. So after doing this procedure, most of the cases are all cases, we go ahead with the pelvic lymphadenectomy also. You can tell me when my time is over. Can you hear me?
Yes, Dr. Hafiz, we can hear you. You can continue. You can finish this.
So here you can see we start just lateral to the lateral to the external iliac. We do not take the lymph nodes completely lateral to external iliac, which can create a lot of lymphedema of the leg. So you just strip the external iliac, as you can see here. We take the external iliac here, and you can below you can see the external iliac vein over here. So you strip very close to the external iliac vein and this complete fibrofatty tissues. So lymphadenectomy means you need not see the lymph node as such unless it is enlarged. You need not see the lymph nodes. So basically what you take is the fibrofatty tissue around these vessels. What you basically do is the external iliac group of nodes, the inter-iliac group of nodes, which is between the internal and external iliac, and you go right up to the corona mortis above and take it from here where it becomes the femoral artery. The external iliac becomes the femoral artery, and here you go right up to the bifurcation and strip along the internal iliac vein. So here you can see that, you can see we are going upwards. You can see the vein very clearly. You just dissect the vein laterally and enter into this space here between the vein and the nodes, which is the obturator space here. So these are all very loose planes, which does not bleed usually if you are in the right plane. Can you see that loose plane here? So this is the loose plane here, which actually doesn't bleed. Don't think that it all bleeds and make a mess out of it. If it is bleeding and you are making a mess out of it, don't go ahead, proceed, stop the bleeding, because we have important structures here which can be damaged. That is a bone which you can see, and you can see the bladder here. That's a part of the bladder here which you have to be careful. And this is the obturator muscle here. You can see the obturator muscle and the fascia of the obturator muscle. So going down, you go down up to the bifurcation. Here you can see the bifurcation. This is the internal iliac. You go down up to the bifurcation and strip it with the internal iliac vein. See, below this is the internal iliac vein, and from here the obturator nerve will come. And as you can see here, you can strip it from the internal iliac artery and below the internal iliac vein. And enter into the obturator space, and you can easily see the obturator vessels as well as the obturator nerve. See, that is the obturator space. You can see the obturator muscle there. So keep the muscle away, as you can see very clearly the borders, and take it out completely. This is the internal iliac vein. You can see the bifurcation of the internal iliac vein. You have to be very careful with that internal iliac vein, because that is something which can get damaged. You can see the bifurcation here. Can you see that? See, that's the internal iliac vein bifurcation. And in between this fascia, you will find, here you can see the internal iliac vein. In between this fascia, you will find the obturator nerve. And you can pull up this entire tissue. That is the internal iliac vein dissected. See, this is the vein which goes down, and you can dissect into this space and take this entire tissue completely without leaving a bit. and that is operator nerve, which you can see. This is operator nerve, and you can reflect it en masse upwards. And you can see that completely being stripped out, and you can see till the origin of the operator nerve, we can take it out completely. And this is the internal iliac going into the obliterated umbilical. Do not go medial to the internal iliac going into obliterated umbilical. Keep lateral to it, because medial to it you find the bladder, and lateral to it you have the lymph nodes, and the operator nerve has to be saved. And this is the operator nerve going upwards, and it will go into the operator canal here. You can see that the space is quite avascular. You can see the nerve there. That is the operator nerve going into the canal. So you can see that entire tissue. See, even this is an enlarged lymph node. Usually you find this lymph node enlarged. So you can take it right till the femoral artery, and that is operator nerve. And you can take it out completely, completing the pelvic lymphadenectomy. In cases where you have enlarged nodes, you can go ahead with the aortic also. And here you can see the aortic bifurcation, and you can see the inferior vena cava. You have two methods. One is you put the primary port high up, or you can put the primary port just suprapubic and do a reverse aortic lymphadenectomy. And mostly when you want to do it up to the renal vein, we do a reverse method where you put the port in the suprapubic area. Here we are having it at the level of the epigastrium, and you can see the bifurcation of the aorta, and you can see that entire fibrofatty tissues are taken. As you know, the lateral boundaries are the ureter and the psoas muscle here on both sides. So you take it completely down, stripping it, and you can see that it has actually become very easy with once a harmonic has come, and you can strip it completely as such, and you can strip it right to the lumbar region. You can strip this whole area. Here the ureter comes, this entire nodes. This is the common iliac, and going up you can go up to the renal vein. See, this is taking out this entire nodes is very, very important if at all you are doing an aortic dissection. As you can see here on the right side also, here this is the ureter. You can take out this fatty areas and go up to the psoas muscle. You can see the ureter here crossing the common iliac at the bifurcation. This is the aortic bifurcation. Here you can see this is the ureter here. Can you see that? That's the ureter. Ureter and the psoas forms the lateral boundary of the dissection. And that is a renal vein. You can see the renal vein going above, and you go up to this renal vein and you take out this fibrofatty tissues also here, safeguarding the inferior mesentery, the superior to inferior mesenteric vessel also you can take. You can go here. The entire lymph nodes are taken in that. So this is how a radical surgery is usually done. So this is how basically a radical surgery is done, and you can see that it's not that difficult to do a radical procedure. As I repeatedly say, see, like the case which Vivek Marwa was showing, I find that endometriosis patient, it's much more difficult than this. The basic concept in this is that we are operating through normal anatomy. The anatomy is completely normal. We are not going anywhere near the lesion. We are just going around the lesion. You don't go anywhere 1 to 2 centimeters around the lesion and taking out completely. And that entire area is a normal anatomy, normal planes, and understand anywhere in the body, in a normal anatomy, normal plane, it is much more easier to do the surgery. It's not that difficult. It's just about knowledge of anatomy and knowing the correct planes. And then anybody who is a good or average laparoscopic surgeon can go ahead and do it. But I would not recommend all gynecologists to do a radical surgery like this, not because technically you cannot do it. Unless and until you are practicing regularly oncosurgery, don't go and do it, because it's not only the technical feasibility of doing a radical procedure, it's the entire spectrum of treatment for oncology, and which is much more important, because it's not only technical feasibility, it's just it has the oncological safety which has to be taken care of. It's the results which has to be taken care of ultimately after doing this procedure. It's not that because I know to do, I do it. What I'm telling, it's easy to do, but if you are into oncology, you don't have to be worried about doing it laparoscopically. This is what exactly I want to convey. So thank you so much.
Thank you, Dr. Hafiz Rahman. It was a very nice dissection which we could see. So in expert hands, laparoscopic radical hysterectomy can be considered safe and effective alternative to the conventional open surgery.
Thank you, Dr. Hafiz, and all the speakers.
There is a comment from Dr. Manju Khemani. She's written, "You are a great teacher, Dr. Hafiz."
Thank you.
That's there we are all saying.
Thank you, Manju.
And I think the last point which you made, that oncology principles have to be kept in mind before you do the surgery. Surgery you can do, but what is to be done and how.
This is actually very important, because when I give these talks, I think Pundambekar also knows and Rajesh also understands. See, when we give these talks and make it easy, it's not just the technique of doing it. It's basically you're treating an oncology patient. It's a whole spectrum altogether. It's not that I can just do it and then the rest of the things I don't know. No, it's not like that. You need to select the right patient, very important. You need to know what has to be done. It's not that whether you can do it or not. You need to really know what has to be done. You have to be updated, and you need to know what post-operatively or what other treatment has to be given. And you should have a proper onco board. You should have a proper oncology board where you have the surgeon, you have the radiotherapist, you have the onco medicine specialist. So all these people have to decide, including the pathologist has to decide what has to be the treatment. So it's not just one surgeon technically doing something. It's not a technician's job. It's a proper clinician's job.
Right.
Thank you, everybody.
It was wonderful watching you. Thank you.
Yeah, true, absolutely. Visual treat for all of us. Thank you. And hi, Dr. Trivedi, how are you?
Nice seeing you after a long time, Vivek.
Yeah, we only see on the Zooms now.
but it has advantages, lots of advantages. So thank you very much to the organizers for giving us this opportunity to listen to the experts here, stalwarts in endoscopy. And
thank you. Great pleasure to watch.
Thank you.
From faculty also, we like to thank Dr. Kanika and the AOGD for this opportunity to be a part of your annual program.
Thank you, Dr. Modi. It's amazing.
Yes, Dr. Modi, it was wonderful watching you, making it look so simple. Thank you.
Yeah.
And
it was an honor to be there and a pleasure, and watching you all again after a long time. And
right. It was wonderful. And your suture technique, that's a real good thing.
Thank you.
Thank you.
Just to please stay logged in, and the chairpersons too, so that we can have their expert comments as and when required. And they can join us in the other sessions also, please.
Thank you.
From here, we move on to the next session. And I would like to invite the chairpersons, Dr. Tripti Saran. She is the, just a second. Yeah, Dr. Tripti is a senior consultant gynecologist and obstetricians at Dr. BLK Hospital, very close friend of mine. And she is a writer par excellence, and she's got many novels to her credit, and becoming very famous as a non-obstetrician. So the next chairperson for the day is Dr. Ritu Rana. She is a senior consultant in obstetrician at Darren Valley Hospital, UK. And it was nice of her to have logged in for this session. The next chairperson is Dr. Jyoti Bhaskar. She's a principal consultant, Apollo Cradle Hospital, Indrapuram, Delhi NCR, and my teacher and senior at Lady Harding. The next chairperson for the day is Dr. Nandini Bhattacharya. She's a senior gynecologist at Srirampur Girls Government Hospital, West Bengal. So we welcome you, and I would request Dr. Ritu Rana to introduce the speaker for the day.
Good morning, Kanika. Good morning, Kanika. Thanks for inviting us, and thanks. Can you hear me clearly? Yeah.
It's morning there, but we've got afternoon.
Oh, sorry, sorry. Yeah, it's afternoon there. it's 8:30 here. I think it's nice to hear from the esteemed speakers, and it's really wonderful knowing the great work that's being done. And my greetings to all the co-chairpersons and the panelists. I'm introducing next speaker who will be talking about the laparoscopic myomectomy, Mr. Tom Holland. He is a consultant gynecologist at the Tertiary Hospital Guy's and St. Thomas's in London. He specializes in minimal access surgery, especially for the complex benign conditions, and also gynecology ultrasound. He had his undergraduate training at Cambridge University and has had his clinical training and postgrad training and research in the various tertiary hospitals in London. He has got numerous publications in national and international journals, and he is also regularly invited as a speaker in this field at national and international conferences. So over to Dr. Tom Holland.
Good morning, everybody, or good afternoon, if you're in India. I'm going to be talking about laparoscopic myomectomy, and hopefully you'll allow me to share my screen. And I'm hoping that my PowerPoint presentation will work, because I recorded it last night. Ladies and gentlemen, thank you for giving me the opportunity to discuss laparoscopic myomectomy, case selection technique and controversies. My name is Tom Holland. I'm a gynecology consultant at Guy's and St. Thomas's Hospital in London. No conflict of interest to declare. I'd first of all like to discuss the benefits of a minimal access approach to myomectomy. There's evidence from a meta-analysis of randomized controlled trials that there are significant benefits to patients, including less blood loss, both at surgery and documented on each quicker recovery, less post-operative pain, fewer complications, and this study found no differences in major complications, with fertility outcomes and recurrence similar. Separately, there have also been reported reductions in DVT and PE risk, and so we published our results in 2017. This was a single center study from University College Hospital in London, and we had 514 consecutive laparoscopic myomectomies reviewed, of which only 2 were opened during the procedure. 1 was for suspected malignancy and 1 was for bowel injury at the time of entry. None of the cases were opened halfway through laparoscopic myomectomy because of difficulty. Mean number of fibroids was 1 with a maximum of 12, and the average diameter was 70 millimeters, not centimeters. The mean EBL was 73 mils, and there was a 3.5% complication rate, of which 15 out of these 18 were an EBL of greater than 1 litre. So in terms of case selection, this is the single most important thing when planning for successful laparoscopic myomectomy, is to choose the right patients. And when I choose patients, I look at the location, the number, the size of the fibroids, previous surgical risks, such as previous myomectomy or uterine artery embolization would make it quite difficult. And also think about, always in the back of my mind, could this be a sarcoma? So for patients over the age of 45, the correct operation for symptomatic fibroids, in my opinion, is a hysterectomy, because myomectomy is for fertility sparing surgery. Women over 45 don't tend to get pregnant naturally, and I would only make an exception to this rule for women planning egg donation IVF treatment. So in terms of the location, the easier laparoscopic myomectomies are anterior fundal, preferably pedunculated, if not then subserous, and uterine rather than broad ligament. The more difficult ones are posterior and cervical, and the deeper they are into the muscle, the more difficult it will be. But thinking about diagnostics, diagnostic imaging preoperatively, this was a very interesting paper published last year from a European group, including my mentor, Davor Jurkovic, and they looked at sarcomas and the imaging for these, and they found that the most common feature of sarcomas was a cooked appearance, so a lack of normal architecture in the fibroids. Fibroids tend to be more common, sarcomas are rare, so fibroids have less vascularity, sarcomas tend to have moderate to high vascularity in approximately 75% of cases, and normal fibroids have a world appearance where sarcomas have that cooked appearance, which means that you can't easily tell what the tissue architecture looks like. Fibroids are normally well circumscribed, with sarcomas being poorly circumscribed in general, and sarcomas tend to be singular in about 50% of cases, where fibroids are often multiple, and quite often you have a loss of the endometrial cavity with a sarcoma. So in terms of the vascularity, these uteri do not look normal. They do not look like they have well circumscribed discrete fibroids. On B mode and on color Doppler, you can see large amounts of vascularity in these two cases. However, the final case, F, doesn't have as much vascularity. So it is possible for sarcomas to appear as less vascular, but this still looks abnormal. There's still lack of normal architecture. So it's very important in operating on these patients to think about your consent process and your discussion around especially power morcellation, because heaven forbid that you should have a patient that has an undiagnosed malignancy, your discussion will come up medical legally down the line. And so a lot of effort has been put into thinking about preoperative counselling, and the RCOG recently published consent advice for professionals and also for patients, which I was involved in the drafting of. And in this, it details all of the risk factors, all the things you should be discussing with your patients, and all the things to be aware of. And I strongly recommend that people read that. In bag morcellation, although it makes sense in theory, there's no evidence that it reduces harm, and so it should be thought of as experimental in terms of preventing dissemination of undiagnosed malignancy. Effectively, if you cut into a uterus to remove what you think is a benign fibroid, but it turns out to be cancer, that's the wrong operation, and you probably upstaged the malignancy by cutting into the uterus. Whether or not power morcellation at that point makes a difference to prognosis is difficult to say, and there's no clear evidence either way on that aspect. So the correct operation for cancer is a hysterectomy without opening the uterus. So that can either be an open hysterectomy for large uteruses, which in this case would be appropriate, or for smaller uteri, a total laparoscopic hysterectomy is appropriate, but as long as the uterus can be removed whole out of the vagina. And with this in mind, you have to discuss to your patients the benefits and the risks of laparoscopic surgery versus open. we have to remind ourselves what the benefit of doing the surgery in the first place is. And for myomectomy, that to be that it's fertility sparing surgery, i.e. you are helping the patient's symptoms, but making sure that you do not detriment their fertility. And so when you're selecting patients, it may be possible to do the operation laparoscopically, but it may not be sensible, in the sense that if you have a deeply embedded posterior fibroid, it may be possible to remove it. And I'm sure there are many very skilled surgeons here who are more skilled than myself who would be able to remove that fibroid. But hand on heart, could you genuinely say that the repair of the uterus would be as good as if it was done open? And if you can't, then are you jeopardizing their future fertility and future childbearing by your wall of the uterus laparoscopically, when you know that you would probably do a better job open? So the benefits and the risks of the surgery have to be weighed up and discussed with the patient. In terms of technique, I think it's important to think about how we reduce blood loss both intraoperatively and preoperatively. Personally, I'm not a big fan of GnRH analogues for laparoscopic myomectomy. I think they do have a role, but quite a limited role. And we don't use Esmia in this country anymore, or ulipristal, due to liver concerns, but that would also be an option. However, I think that both of these treatments distort the planes, and therefore, personally, I wouldn't use them. But intraoperatively, there are many different techniques in terms of tourniquets and artery ligation or clipping. Personally, I prefer intramuscular artery pressing into the myometrium, and I use 20 units in 20 mils of saline for a not huge uterus, and 40 mils of saline to dilute it a bit more for the larger uteri. In terms of suturing the myometrium, barbed sutures have made a huge difference, and closure with these has made it much quicker, I think a much better closure, and there are many different types of barbed suture on the market. Covidian make V-Lock, which I use regularly, Ethicon make Stratifix, which is also good, but it's important to remember that these are very sticky and the bowel can get stuck to them. So I would recommend cutting these sutures flush and also covering with an adhesion barrier layer such as Interseed. And when you're making your incision, it's important to plan how you're going to actually close the uterus. And an oblique fundal incision is normally the easiest, almost pointing to your right hand is port, because that's where you're going to be suturing from. But obviously, there are many different techniques for closing the uterus, and individual surgeon preference is important. So when extracting the specimen, I would now recommend morcellation in a bag. This is partly because we think that it will reduce the chance of dissemination of undiagnosed malignancy, but mainly is to stop the risk of peritoneal leiomyomatosis, which is where small seedlings of fibroids can be spread throughout the abdomen and grow in places where you don't want them to. So there are two different types of bags commonly used in the UK. I use the more safe bag, which is the top one, but the Espina bag is also a good bag, and it's probably stronger but more difficult to insert into the abdomen. So I've talked for long enough about the theory. Now I'm sure you want to see exactly how it's done in practice. So this is spinal needle giving the putrescin or the argipressin into the muscle of the uterus. It's also possible to put this into the UV fold, into a bleb, either medial or lateral to the uterine arteries, and that gives good uterine artery spasm and good hemostasis for at least 2 hours. So we're making the incision normally using an oblique or a transverse incision across the fundus. And you have to remember that this is an operation for 2 people. The assistant does an awful lot of work in this operation, and it's important to have a skilled assistant because they will be doing significant amount of work. You can see this is actually the assistant here doing quite a lot of work. So it's important to find the plane and to make a big enough incision that you're not fighting against the incision the whole time. And the plane should be developed. This is using a blunt probe to develop the plane. And in the same way as it's developed an open myomectomy, find the plane, work it around, but be mindful of where the cavity is. So we know that the cavity is at the front of this fibroid, because you can see the tubes. And there are various instruments that make this easier. The screw, the myomectomy screw, is obviously very useful. I also use a 10mm grasper with either a single tooth or multi-tooth to actually get a good purchase on the fibroid. And it's actually physically quite a taxing operation. It's not a particularly delicate operation to actually remove the fibroid from the uterus. You can see just cutting the final fibers there of the myometrium holding fibroid in. So once the fibroid is removed, we have to then close up the uterus, and it's important to plan your incision and plan the closure. So this is V-lock, and you can see that it has a loop on the end. We have to be careful about the endometrial cavity, but also get a good closure of the defect left by the fibroid, because if you don't close the defect properly, then it will fill with blood and become a source of infection. So that's the loop. So that means with V-lock, there's no need to tie any knots. It's all done by using the barbs on the suture material to provide constant tension within the length of suture, and therefore it's more hemostatic than interrupted would be. And I also think that you get better tissue apposition than you would do with interrupted sutures. Although I have seen videos of people using interrupted sutures, and that is also reasonable, especially if you're good at knot tying, but it certainly takes longer and is more laborious. So the idea, just as with open myomectomy, is to close all the layers and obliterate the dead space as much as possible, and bring the myometrium as much as possible together before getting to the serosal layer. And I use a 2O, this is an OV lock. I use a 2O V-lock for the serosal layer. So this is just using a little bit more 0 for the remaining area of myometrium which hasn't been opposed clearly. Now using the 2O for closing the serosa. So you can see that the myometrium is brought together pretty well by this point, and this layer really is only for hemostasis, only to make the serosa watertight again so that it doesn't bleed when the putrescine wears off. And by the time you've morcellated, you've got a pretty good idea of whether there's any hemostasis problems. You can see the uterus is coming together pretty well there. And with any barbed suture, it's important to go beyond where you need it, to go beyond and then come back on yourself.
Thanks, Tom, for covering the presentation and actually all the aspects of laparoscopic myomectomy rather than just the surgical aspect. I'm sure there would be questions around. I think I just wanted to ask one very quick question. If the cavity is breached, which suture do you use? And is there any post-operative precautions that you would take after the breach in the cavity?
Thank you for asking that question. So I would use a monofilament, which I believe to be less reactive. So I'd use a monocryl. And I'd use something like a 2.0 or a 3.0 monocryl. Some people would then, if they were concerned about intra-cavity adhesions, they would use a copper coil. I've also used the hyalobarrier in open myomectomy into the cavity where there have been large breaches, and that would be an option. You could put that in vaginally. And I know some people hysteroscope at the end of the procedure to see how much suture material is in the cavity and assess the level of cavity opening, and then put a coil in or put a hyalobarrier in. So it's important to be mindful of where the cavity is at all times.
Thank you, Tom. Yes, hi, Dr. Tom. It was an excellent lecture, as Ritu said, something which is very practical for all clinicians also to take away. So I would just like to ask you one particular question, is that in which conditions would you like to do an MRI before taking the patient up for a myomectomy?
So obviously, MRI gives you very clear images of where the fibroids are in relation to the cavity. And if MRI is easily accessible in your hospital, then obviously that's very helpful. Personally, I use ultrasound on a daily basis and therefore don't tend to use MRI. MRI is much more expensive and less accessible for our patients. And so I don't use it either to assess for malignancy or to assess the cavity and location of fibroids. But I don't have a problem with MRI. I just don't feel the need to use it myself.
That means if we have a 2D ultrasound, I think if we have a good ultrasound with the doctor, then MRI may not be needed at all.
Exactly.
I think
I would just want to ask, Tom, we have been using MRI quite sort of regularly because we don't have that level of expertise in the ultrasound, or there's too much of heterogeneity in the people who are doing the ultrasounds. You can't so quite rely on them. We were using for more than 10 centimeters, any fibroid more than 10 centimeter, we were using MRIs. But I think from the talk that you have given, it's quite clear that the sarcoma can be between less than that size. So something to sort of reflect on. And would you, for the units who are not having that sort of expertise, would you have any comments on the MRI, use of MRI?
So MRI and ultrasound are both user dependent, and if you know what to look for in ultrasound, then in the majority of cases you can detect sarcoma preoperatively. But also you need to be sensible around which patients you're operating on, that if you have a fibroid which is causing a problem in a postmenopausal woman, then certainly myomectomy is not sensible. And many of the problems that happened in America were people doing laparoscopic myomectomies on women who are 55, 60, 70. And you think, well, fibroids don't tend to cause a problem in 70-year-olds, so you're asking for trouble by doing conservative surgery in those patients. So first of all, taking a history and thinking about why the patient has the problem in the first place is very important. And then applying imaging to try and assess the difficult patients, the ones who are 45 with irregular bleeding, and worrying about could they be, because they're the ones that are truly difficult. The ones that are postmenopausal, I don't think it's difficult, because if in doubt, you just do an open total hysterectomy and then you've covered yourself.
Thanks a lot, Tom. Any other questions?
And I'd like to say that the videos that we've seen this morning from your colleagues have been excellent. I'm really very impressed by the quality of the surgery in India. And I'm sure at some point I should come to India and take some lessons from you guys, because the quality of the surgery is fantastic.
Hello, Dr. Tom. This is Dr. Tripti. Kanika, you were saying something? No, I just wanted to congratulate. Hello?
We can hear you.
You're audible, Dr. Tripti.
Yeah. Thank you for the lovely presentation. I really liked the way you had recorded everything and it was going very smoothly. I guess you were a little apprehensive about the presentation working or not, but it was going very smoothly and we could really understand it in a very concise manner. I just wanted to ask you one thing. What dilution did you use of vasopressin here?
So for smaller uteruses, I use 20 units in 20 mils of saline. For larger,
Okay.
I use 20 units in 40 mils of saline. I know
Oh.
I've heard of people using higher volumes of saline, and I don't have a problem with that. And you get more hydrodissection, but I find that 20 or 40 mils of saline.
Yeah. Even we use a higher dilution because our anesthetists don't allow us.
Yeah, so in that study that I showed you of 500 cases, we didn't have a single case of a cardiac arrhythmia, but I
Okay.
have heard of hospitals in the UK having patients with cardiac arrhythmias. But I think that must be intravenous, accidental intravenous dosing causing a large bolus going to the heart. And so I think you have to be careful. And when I said about using in the UV fold, I'm talking about putting it very superficially and assessing for swelling of the UV fold, so you can be confident you're not in a vein. I do think you have to be careful, but I've never had a problem with it, nor seen a problem with it.
Lucky you.
So there are one or two questions, I think, in the chat box.
Okay, yeah, Dr. Jyoti.
Taken. Yeah, are you using power modulation in UK, and are you measuring the LDH before doing a myomectomy?
So I don't measure LDH. As I said before, I don't necessarily think that's helpful. And yes, we do use power modulation. I know that in America there are problems. Unfortunately, my video cut out before I got to the morcellation bit, so I apologize for that. But yes, I do use power morcellation. Now I use it in bag, and I believe that in bag reduces the risk of fibroid seedlings. I don't know if in bag morcellation makes any difference to survival of inadvertent cancer morcellation. As I said in the talk, I believe that if you cut into the uterus with a sarcoma, then you've probably upstaged it right there. And whatever you then do with the tissue is probably too late. And so the correct treatment for sarcoma is a total hysterectomy en bloc. And that I believe that the debate around power morcellation is actually nonsensical. I believe that by the time you've opened the uterus and dissected out the problematic tissue, then you probably already upstaged the tumor, and then whatever you do with the tumor at that point is probably inappropriate, but unlikely to make a huge difference to survival. So I don't think that the power morcellation bit is the problem.
And the second thing they want to know is, what about doing LDH before doing a myomectomy, I think, to find out the risk of malignancy?
I don't know of any evidence that LDA is a good of assessing difference between a sarcoma and a normal fibroid. So if the images myself, and preferably scan the patients myself, and if I was confident that the fibroid architecture was normal, I would proceed. And if I was not confident, then I would recommend hysterectomy, probably by an oncologist.
Thank you so much, Dr. Tom. And I think the main takeaway is the right selection of the patient. So if we do make a right selection of the patient, I think the surgery is going to be good, and the long-term outcome also of the surgery is going to be really good. So thank you so much, Dr. Tom.
Thank you very much.
Thank you. I thank the chairpersons and Mr. Tom for an excellent presentation. We now move on to the next session. And I would like to invite the Master of Ceremonies for this session, Dr. Madhu Goel and Dr. Richa Sharma. So over to you, Dr. Madhu and Dr. Richa. Dr. Madhu, Dr. Richa, are you there?
Yeah, Dr. Madhu and Dr. Richa have already been introduced to you in the morning. They are the co-conveners of this workshop. And
the master of ceremonies for this.
Yes.
So, thank you, Dr. Kanika and Dr. Mamta. We now move on to session 4, which deals with hysteroscopic surgeries, which is another important tool in the armamentarium of any gynecologist. And it is my privilege to welcome the chairpersons for the next session, Dr. Chandra Mansukhani. Dr. Chandra Mansukhani is a senior gynecologist at Sri Gangaram Institute of Obs and Gynae. She has been a treasurer at NACHI and treasured IMS Delhi chapter. Dr. Himani Agarwal, who is a fertility consultant at Indra IVF Meerut, and Dr. Sharmishta Garg, who is associate consultant, Institute of Obstetrics and Gynecology, Gangaram Hospital. And it is my proud privilege to welcome the next speaker, Dr. Narendra Malhotra. I'm sure every gynecologist in India is familiar with his name. Dr. Narendra Malhotra is the managing director of Rainbow Hospital. He is a director ART Rainbow IVF, and he is a past president ISAR, ISPAT, and FOXY. Welcome, sir. Dr. Narendra Malhotra.
It's indeed a pleasure. Thank you for inviting me for this great workshop. I'm right here, and in a second I'll get my slides on. Just putting it on. So very good afternoon to all of you. It's indeed a pleasure to be always associated with the AOGD and their excellent work which they do. Today I've been given to speak on the diagnosis and correction of uterine cavity disorder. It's a huge topic, and I'll try to summarize it as fast as I can because the videos do take some time. So we all know that we have the first thing which we deal with the uterine cavity is the anatomic factor, which is responsible for recurrent spontaneous abortion. And here we have TVS and 3D as the best tools for diagnosis, and the best tool, of course, is hysteroscopy for management. And very rarely we are doing MRI because of good ultrasound. So you need to evaluate the cavity, and you see in my list, MRI is last, and HSG, which used to be first, has also gone out of my list, and I'm straight away to sonohistography with color, with 3D contrast, and putting some Shillot imaging and getting some lovely pictures and videos out of it. This was the older classification ASRM of all the anomalies, and we now follow the newer ESHRE, ESG, UC, V classifications, and you see how beautifully you can correlate the 3D with the UC. So here normal uterus, here U1 anomaly, U1 anomaly, U2, U2, U3, U3, and U4. So absolutely there is no problem. This is without contrast, this is simple. It takes 5 minutes, only the analysis and the reconstruction of the images take some time. The patient goes home, the sweep is taken and the patient goes home, and later on you play with the computer to get the best image. So in my hands, there is there is a TVS probe and there is a hysteroscopy for all the female pelvic disorders. And there is, of course, in all my operation theaters, an ultrasound machine is always there. Even for an MTP, I would rescan whether I've done a complete job or not. Even after 35 years of experience, I would still do that and want to be 100% sure. It just takes 1 extra second. So so with the ultrasound, today we are going to talk only of the uterus. We can evaluate everything, which could be some other day. And this is how, for me, if you're going to do HSG, I would do myself. And I would do under fluoroscopic guidance like this, where I can highlight the cavity and then go ahead for the tube if I'm going to do. But because I've given up doing HSGs, so for me, an ultrasound and with contrast, so I put some fluid in. And when I put some fluid in, I can see the cavity very nicely, and I can see the pathologies inside the cavity very nicely. So you can put the fluid in by just a Foley's catheter or even a nasal feeding tube. A gastric tube is what we do in our OPD. We have a machine in the OPD. After doing a per speculum examination, we do a TVS, and if we suspect some endometrial problem, We put in, the patient just lies there, we put in a feeding tube and inject saline and do the scan, and that's it. Your diagnosis is 100% longitude. So my diagnosis would be made on the OPD like this, and then I'll go ahead and plan my hysteroscopic surgery. So that is how, whether it's a polyp or whether it's an Asherman syndrome like this, and see how beautifully we have correlated both of them. Here you could see the band by ultrasound, the same band by hysteroscopy, same case, just done at the same time, here right now. So that is how good you can be, and it does not require extra skill. It has this learning phase, ultrasound, but we are gynecologists, we're used to the pelvis, we're used to doing PV, we're used to doing PS. So we will be very, very easily learn how to do TVS. Now 3D has an advantage. This may have a little bit of learning curve, especially to reconstruct the image. The scanning is same. Scanning is even easier by 3D. So with 3D, I would like to see the uterine contours, the uterine length, and then I can electronically erase all the things which I don't want to see and highlight only the cavity, and I can rotate the cavity on X, Y, and Z axis also. So to have a look at the cavity from all the angles. So that's how the 3D, and with the newer machines, we get pictures as good as this. A little bit of fluid inside this is saline, and high definition transvaginal 3D image, and you can construct the image of the uterus like that. So let's see what we can do. The unicornate uterus, suspect on 2D, confirm by 3D, either right and left, both of them, and then do a hysteroscopy to confirm one side only ostia you're seeing, and you can put in a laparoscope, and if it's a complete infertility evaluation, if it is pre-IVF, we would leave it at hysteroscopy because this cavity is adequate. If the cavity was not adequate, I would go ahead and do a little bit of metroplasty and increase the size of this cavity. So that's how we do. We know duplication anomalies. The diagnosis now with volume imaging goes up to almost 100% specific, and with contrast 100% specific and 98% sensitive. So septas, we do vaginoscopy. So here's a vaginoscopy. We saw a lesion in the vagina, an old lesion here, which could have been a vaginal, and I'm just having a close look because we don't hold the cervix at all, and then we will go towards the cervix, enter the cavity, and when we enter the cavity, the water pressure will, because we enter with a higher pressure, so that will take care of my entry through even stenosed osses, and then of course we see the huge big septum in this case, and go ahead and cut it with either scissors or current. Because this was a very wide and very thick septum, so I used the bipolar Collins knife. Now we also use only bipolar cutting and no glycine and no unipolar cuttings inside the uterus if we have to use current. Otherwise we do it with scissors. So septums you can see by 2D, and put the color on to see the vascularity of the septum. Because the vascularity will tell you there will be poor estrogenic maturation at the septum area, poor decentralization, and these cases will land up into recurrent pregnancy losses. And also the septum now is believed to be confirmed to have muscular tissue. So that increases contractility, and that will also cause recurrent pregnancy losses. And how do we evaluate the septum? We see the outer contour, we see the inner contour, we measure the depth. If the outer is convex, and if the outer is concave, it's biconvate and septate. That is how we differentiate. Very important to differentiate, because I was taught to repair a biconvate as a Strassman's openly. But today, once you're confirmed, then you can go ahead, confirm with 3D, then you can go ahead and do a laparoscopic Strassman's and unify the two different uterus. Now there is nothing as arcuate now in the newer classification, so it's all septate, which should be said partial or complete. So subseptate, the arcuate is gone, and you can, if it is very wide and convex, and if it is V and convex 90 degrees, this is septate, this is partial septate or arcuate. And if the cavity volume is okay, we are not going to touch this, we are not going to cut this one. This one we are definitely going to cut by whatever, scissors, Collins knife, depending on how thick it is. So you're going to use energy or scissors, that will depend on that. So my biconvate and septate, going into the cervix, follow the longitudinal line, enter it, and you see the septum starts right from here. So from the end, it's a huge big one right up. So it's a good, nice, juicy septum, and because it's thick, so initially it was, the thin part was cut by scissors, so we could get good space for the resectoscope to go in. And then we switched over to the resectoscope bipolar Collins knife and just went ahead and cut it. And you see, I'm turning it both the sides to keep the ostia in place. So always the ostia, so I'm not worried about any perforation. So you need the right equipment. For ultrasound, you need the right equipment and the best equipment if you want to make good diagnosis. For hysteroscopy, you need the right equipment. They had a talk before me in equipment, but I'm not going to touch that. And you need the right instruments, absolutely instrument-dependent surgery. So it is very, very important. Then we individualize the treatment according to pathology. So if it's Asherman's, then we go ahead and cut the Asherman's. First, make a sure shot diagnosis by ultrasound. So there is no role of any diagnostic hysteroscopy in my unit. They're all diagnosed by ultrasound and they will be all subjected to an operative hysteroscopy. So here is what we have diagnosed by ultrasound, and then we go ahead and cut it by scissors or current, whatever we feel is required on the adhesion. You see how similar the pictures are in both of them. So we're very, very sure of our diagnosis. We can classify them, and you can classify them as mild, moderate, severe, so you are ready for operating time. And then, of course, there is a little bit of complications which you have to be very careful about. So this is how we see the uterine synecdoche on 3D, all of them, and this is how they correlate with my hysteroscopy. And when they correlate with the hysteroscopy, single band, multiple band, narrow cavity, I can use the scissors, or I can use the monopolar, or I can use the bipolar, or I can even use the Versa point to cut these adhesions. Somehow my slides get stuck here. Anyway, so I'll just go. Last two slides are left. This one just gets stuck all the. So that is how we handle Asherman's and septum, and then we come to what is polyps, endometrial polyps or fibroids. Now for this, again, for me, 3D is much better than any MRI. And you have the 3D in 3 planes. You can see the polyp or the fibroid. You can see the sessile or this, and then we use this niche mode to cut the angle from the all side. And then, of course, we plan our surgery and see how accurately we can fix the polyp. This is a 3D picture, and this is what I took out. Absolutely matches. So that is how good we are. Fibroids we need to classify, because hysteroscopically we are going to deal only with the fibroids which are jutting into the cavity. And this image is the Shillute imaging with contrast. Contrast used here is saline or gel. And we classify the ESG fibroid 012 or 012 like that. And then we score them, and depending on the score, we plan the surgery. This is all theoretical, and you can read it. So 0 to 4 score, you do a hysteroscopy. If the score is high, then hysteroscopic myomectomy is not indicated. We have to remember. And accordingly, you can make your own flowchart. These flowcharts are there, but you can plan your own flowcharts. So submucous fibroid grading and deciding the route of surgery is very, 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 very important. And then, of course, once you've done it, hysteroscopic myomectomy, you have to be very good. Today, we find a lot of narrow uterus, T-shaped uterus. Again, 3D ultrasound, and then you take the Collins knife, and you can go ahead and cut it on the sides and increase the cavity on the sides if HSG was showing like that, and then do a little bit of fundal metroplasty also. So you increase the cavity size, and then of course we put an IUCD in these patients and put them on high dose of estradiol and progesterone to cause good healing. So T-shaped uterus, we are going to increase to metroplasty like that. Carefully, slowly. We have also done this under ultrasound guidance with scissors. I've demonstrated this in many workshops, but then we are not very sure, because we need to look inside the cavity. So with ultrasound, you will not get as good as picture like this, but you can do it. Then today, it is unfortunate that we still run into bony metaplasias and mid-trimester abortions and bony pieces. And you see the bony pieces, trabecular bone, long bones, all have been removed. Unfortunately, this is still rampant, and we run into a case every week now at our place, and this is the tragedy of our country. So we see a graveyard in the uterus, and they come to us as infertile, and when you take a detailed history, it's a mid-trimester female fetus abortion, which is there. And these bony pieces, see, again, you can't do a suction here or you can't do a curettage. You have to remove carefully, slowly, each and every piece by the hysteroscopic grasper. Because if they are left here, you see the long bones, the trabecular, the skull bones, everything was there in this full graveyard. And this is unfortunately being seen every week. One case a week I see of these. So we do a lot of these removal also. Now, lastly, even these two magic sticks can go wrong. You can have equipment failure, you can have procedure failure, and you can of course have complications. So you should be ready to handle complications like injuries, fluid overloads, infections and bleeding, and should be knowing it. And your anesthetist should be well trained to handle all the fluid overloads and everything. And your OT should be equipped. These surgeries cannot be done in makeshift OTs. They have to be a dedicated OT for it. So ladies and gentlemen, to conclude, hysteroscopy is a look into the uterus. And we must now give up doing blind DNCs. We don't do DNC at all now. And no DNC biopsies are done. If biopsy is required in OPD, it is either taken by people or taken by a outpatient hysteroscopic guided biopsy. And we must know that all cervix can be. See, the last slide is this injection of PRP in thin endometrium. So we use the ovum pickup needle and we inject PRP subendometrially in 4 places. And just yesterday, I learned from Dr. Alka Kriplani that the rest of the PRP she injects, deflates, puts in a Foley's, and injects through the Foley's and locks the Foley's. So some stays in the cavity also. Otherwise, most of us were doing in the cavity, and that used to come out. But this works well. And we have now almost 40 cases, which is now accepted for publication. It will be soon coming out. So all hysteroscopy should be done vaginally. Vaginoscopy, don't hold the cervix. You can negotiate almost 99% of the cervix. And you use a little bit higher pressure on negotiating the cervix and reduce the pressure later on when you're in the cavity. So that and of course, be careful of the fluid overload. Thank you very much for inviting me here. I bring you greetings again from my city, Agra, the Taj Mahal. Thank you, AOGD, for inviting me to share my views on hysteroscopic, operative hysteroscopy.
Hello. Hello, Narendra sir. It's always a pleasure. It's always a delight for the AOGDians to have you in all the conferences. Sir, we like to have a few questions with you. So first of all, you mentioned what kind of contrast are we using in ultrasound, sir?
Plain saline.
SIS, which were
Saline is the best contrast for ultrasound, or you can use lignocaine gel. And lignocaine gel you can inject with a feeding tube inside the uterus, and you can mix it. We have a mixture. For positive contrast for tubal evaluation, we use Ecovyst. But Ecovyst we don't use in the cavity because it got air bubbles and then the cavity will be distorted. So for cavity, plain saline or lignocaine gel inside the cavity of the uterus. And also in the vagina.
Endoscope embolism.
Embolism for what? Fluid. Saline will not cause embolism. Lignocaine gel will also not cause embolism because you are not cutting anything. It's just a little bit of lignocaine gel while you are scanning.
And for the beginner, sir, which would you suggest?
Which what I suggest?
Beginners who are doing hysteroscopic surgeries now, which hysteroscope would you suggest, sir?
See, hysteroscope is your eye. If you cannot see, you cannot do the surgery. So, and the camera. So the camera and the scope and your light source should be the best. The high definition camera, I know it will cost a little bit in the beginning, but then you will not change it for next 5 years. If you buy a poor camera and a poor light source and a poor hysteroscope, you cannot see. And if you cannot see, then you cannot do anything. And then for the hysteroscope, the pump is the most important. So no pumping with the BP bulb and with the pressure. Absolutely no. Throw them out if you're using it. And I would suggest a high pressure pump which can go up to 200 also. So initially to negotiate the cervix, you use the high pressure and then lower it down the cavity. So these 3 equipments are, you cannot do surgery without them. So they have to be the best.
Because these days promoting this Bitochi integrated office hysteroscopes and all, because they're quite costly. So for the beginners like us, so I think a simple basic hysteroscope with an operating channel
Yes.
that.
See, Bitochi will be, we are not going to, Indian women cannot tolerate any pain in the vagina. So anything you put in the vagina, they want an anesthesia. So we are not like European, where I've seen when I was trained that even the ovum pickup was done only without anesthesia, talking to the patient. So that is not possible with Indian women. And they feel pain very, and if they move when you are actually doing with the Bitochi and coagulating or using current, then that's everything. So it's better to do with mild anesthesia, better to do with a good scope and a good 4 millimeter, or even when you resectoscope, it's going to be a little bigger. So that does not matter. Don't use the mini scope Bitochi right in the beginning.
And sir, vagina postmenopausal females also?
Pardon?
In the postmenopausal females, when they're entering, so like it's very difficult, sir, because of the stenoid cervix. So vaginoscopy will do in those cases also?
Absolutely, 99% you can. Now in last 5 years, only yesterday I could not negotiate a cervix, and I just beat my head up, and then what? I even cut open the, see, you can go, if it is stenosed, use your scissors, put your scissors and just open it like this. So go a little bit more, open the scissors. Don't cut it, just put the scissors and keep on opening. And if you are sure, you follow those longitudinal lines in the cervix, the glands, and if you follow them, you're not going to perforate. But we did have, you can occasionally have problems, but then see, the dilator, Hager's dilator number 8, your hysteroscope is smaller in diameter than that. So where is it? So it is always better to do with the scope and the pressure rather than the dilator.
Message well taken. And sir, you take for this hysteroscopic myomectomy, sir.
So hysteroscopic myomectomy, you have to be very sure if it is 0, 1 or 2. If it is 0, it is very simple. Now these people, everyone is saying, you go ahead and cut the pedicle and leave the fibroid inside only, and let it degenerate and come out. Now I don't believe in that. If it is a fibroid which is more than 1 centimeter, then we have to resectoscopically shave it, because if we cut it 1 centimeter, that means you have to dilate the os to 10. And if it is 1.5, you have to dilate the os to 15 to take it out. So you will cause injury to the cervix and you cause incompetence. So it is better to hysteroscopically resect out, shave out easily. You can also use the scissors, and you can cut the scissors and enucleate the fibroid if they are small. And if they are more deeper, then by the side of the hysteroscope, you can also use the myoma screw, which you use in laparoscopy. Please, everyone, don't use it unless you're very, very experienced. And screw that cervix and keep pulling, and with the hysteroscopic sheet, the scissors, keep on cutting. So bigger fibroids, which are almost 50% intramural, also can be done hysteroscopically, but only by experts, not by the beginners.
Thank you, sir.
I will not.
Any other questions?
Thank you for the really good overview of hysteroscopic procedures, sir. Thank you very much. Pleasure to have you here.
Hello.
Moving on to the next session. Session 5. It is my privilege to welcome the chairpersons, Dr. Reenu Mishra. She is senior consultant and head IVF, senior consultant at at Sitaram Bhartiya Institute, and head IVF at Miracles IVF Center. Dr. Ruma Satvik. She is senior consultant at Sir Gangaram Hospital, IVF. Dr. Surveen Gumas. She is director and head IVF and reproductive medicine at Max Multispeciality Hospitals. And Dr. Seema Gupta. She is director at Dr. R.B. Gupta Medical Center and clinical secretary, East Delhi Gynae Forum. And let me welcome the next speaker, Dr. Richa Sharma, my co-convener for this conference. Dr. Richa, over to you.
Thank you, Dr. Madhu. My topic for today is uterine septum resection. When and how far? Can you please put up the slide?
Just a second.
Uterine septum resection, it is an initial term actually, which was being used when the metroplasty like Jones metroplasty was being done, which involved a resection and removal of septum and then followed by the uterine closure. Now with the use of hysteroscopy, am I audible? Dr. Madhu, am I audible?
Yeah, Dr.
Yeah, madam, you are audible. Go ahead.
Next slide. Next slide. Next.
Sumit, there is a rebound of the sound.
Next slide. So I'll repeat again. I'm supposed to speak on uterine septum resection, when and how far. Now, uterine septum resection, actually, it is an initial term which was used when the metroplasty, like Jones metroplasty was being done, which involved the resection and then the removal of septum followed by the uterine closure. Now, the hysteroscopic techniques, we do incision rather than excision. So the most appropriate term now will be the septum incision. Now, coming to the prevalence of uterine septum is nearly 1 to 15 per 1,000 in the general population. Next slide. There is insufficient evidence which can correlate that uterine septum is associated with infertility. But there are several observational studies which has been done, and they have concluded that hysteroscopic septum incision is associated with increased clinical pregnancy rate in women with infertility. Next slide. The association between uterine septum and miscarriage, preterm birth, malpresentation, intrauterine growth restriction, placental abruption, and perinatal mortality has been well established. Next. So the question is when to do the uterine septum incision. Now, in a patient with infertility or a prior pregnancy loss or a poor obstetric outcome, it is reasonable to consider septum incision. This is grade C recommendation. Then in a patient without infertility or prior pregnancy loss, it may also be reasonable to consider septum incision following counseling regarding the potential risk and benefit of the procedure. This again is the grade C recommendation. Next. So this is a patient, 25 years old lady who presented with stop the sound. Can you mute the sound? Done using 5 mm Bitochi and we use 5 French scissors. Diagnostic laparoscopy was also done previously, and I usually prefer using scissors because the plane of dissection is better. Because the bleeders, they can guide us whenever we are in wrong place as compared to using here we can see that septoplasty is being done, and also the tissue retrieval, very important. Now this patient after doing the septoplasty had a body sensitive for 1 week, and we used the 22 months, and this patient then had a natural conception at 5th month post surgery, and she delivered vaginally. Now we can see the end point of septoplasty. Next slide.
We turn off the music, Sumit, on the slide, on the videos. Thank you.
Thank you. Now these are the another 2 patients who presented with recurrent abortions, and investigation had shown the partial septum. And here we had done the septoplasty using 26 French bipolar resectoscope and Autocon 2 400 high frequency unit. We had kept the effect of 4 for coagulation and cutting both. So this first patient we used Collins knife, and the second patient we used the loop. Now, this is very important that there is no sufficient evidence which can support or refuse that one method is superior to other method, whether you are using scissor or you are using laser or current. Next slide, please. Now, this is another patient who presented with infertility. And here we had done the diagnostic laparoscopy. And on hysteroscopy, we found a short and a broad septum, as we can see. And there was a good amount of endometrium also. So here again, the septoplasty we did using scissors. And while doing septoplasty, now it is very important to leave the myometrial thickness of at least 1.5 centimeters. Now here we can see a very broad septum and scissor cutting the septum. And I usually prefer mechanical barriers and hormone post-operatively in a patient who have a complete septum or they have a broad septum. But if we talk about the recommendations, there is no sufficient guideline which say like after septoplasty, which mechanical barrier or hormone is recommended. So here, as we can see the video, the broad septum, it is almost incised. And now this is the end view. Next slide. So there is insufficient evidence which can conclude that obstetric outcomes are different when comparing the size of the septum defined by length or the width of the septa. Next. So the next question is how far we should go. Now, most crucial part of hysteroscopic metroplasty is the complete uterine septum incision and without causing any perforation or leaving any residual symptom. Next. So generally at the end of the septoplasty, the criteria which is followed is that at the level of internal os, we should be simultaneously seeing both the ostia, or we can move the hysteroscope from one cornu to another cornu. Next slide. Next slide. So the two novel methods that has been described in the literature, previous slide. So in one, go back to the previous slide. So the people, they have now started using this novel instrument called Di-Spizio 5 French. This is a graduated intrauterine palpator. So you can measure the part of the remaining septum and guide the septoplasty on hysteroscopy. Next, then there's another method which is described in the literature is that ultrasonographically we measure the length and the width of the septum preoperatively. And we also measure the distance between the two open blades of the scissor. So, and then can guide us about the number of cuts we have to give. Go back to the previous slide, please. So the number of cuts will be equal to length of the septum, which we have diagnosed on ultrasound, and divided by the distance of open blades of the scissors. For example, if the length of the septum is 1.5 centimeters, so seeing that 5 mm is the distance of the open blade, so we'll give the 3 cuts. So this is approximately how we can do the septoplasty. Next. So the incision should always be towards the under correction rather than over correction, which means that whenever we cut a septum, we should always leave behind a convex septum, not the concave. So the risk of subsequent pregnancy related rupture, it is associated if we have an excessive septal incision, or we penetrate too deep into the myometrium, or if there is an inadvertent perforation, or if we have used excessive cautery or laser. Next slide. So the studies have proved that the residual septum, even if it is 0.5 centimeters or if it is 1 centimeters, it does not actually affect the reproductive potential as compared to residual septum of 0.5 centimeters. So it is always better doing the under correction rather than over correction. Next. Now, post-op considerations. Now, evidence have suggested that the uterine cavity, it heals by 2 months post-operatively, but there is insufficient evidence regarding when the patient should be allowed to conceive. So this is grade C recommendation. And similarly, there is insufficient evidence regarding the use of adhesion prevention treatment. Next slide. So I would conclude with this, I would conclude that patient selection and treatment by a multidisciplinary team, it is very important. And we should deal the patient with a specialist in reproductive medicine, radiologist, and the expert hysteroscopic surgeon. Then counseling is very important regarding the efficacy and the risk of the procedure. And we should always provide them with a clear and written information. Thank you.
Thank you, Dr. Richa. First of all, to finish in time and also beautifully explaining which patient we should be doing a septum incision and how far should we go. because if we are too aggressive, if you're using too much of energy source, then there is a risk of uterine perforation, which increases during pregnancy. Like she said, we still don't have level A evidence to actually say whether we should be incising the septum in infertility or not. There are currently two large randomized trials going on, the TRUST trial in Netherlands. So let us see, we may be getting answers. But as of now, we are doing septum incision in infertility patients, as the observational studies show that it may lead to better live birth rate, although we're not very, very sure about this. Thank you, Dr. Richa.
Thank you, ma'am.
Any questions? Maybe we'll take the question in the end. So please stay on, Dr. Richa,
Yes,
till the end of the session.
So I thank you, Richa. I take great pleasure in inviting the next speaker, Dr. Prajnesh Shah. He's a known endoscopic surgeon, organizing secretary AICOG 2017, executive board member of ICOG with multiple publications to his credit. Dr. Prajnesh, sir. He's going to speak on Asherman syndrome, current treatment plan and follow-up. Dr. Prajnesh.
You need to unmute yourself, sir.
Yeah, I'll unmute this. Okay. So, good afternoon. Welcome to this wonderful workshop by AOCD. At outset, I thank you for giving this wonderful opportunity. And topic given to me is Asherman syndrome, or I would say severe Asherman syndrome, current treatment plan and follow-up, because this is one of the things that is being a lot of times. I at outset thank all IVF people who are referring me a patient. They have tried to do hysteroscopy, and with persistent poor non-material thickness, they have referred cases to us and given us the opportunity of doing a surgery of this all different varieties of Asherman syndrome cases. Now, basically, Asherman means we all know that this is a classical intrauterine adhesion, been a word being coined many years back, and then with advent of amenorrhea, infertility, and pregnancy loss, it has become very popular because of subfertility and issues of amenorrhea. Now, whenever you are managing cases of Asherman syndrome, it's very important that you should have certain things preoperatively properly assessed. When you do hysteroscopy, uterine cavity is normal, means it is a hormonal cause of amenorrhea. So this should not happen. This is something which warns us that we should be very careful before taking a case for hysteroscopy. Number two, very common cause of Asherman is post-abortal or post-MTP. With advent of medical abortions, and abortions, when they've been carried out with a curette, a sharp curette, means even the basal layer has been stripped off, that leads to Asherman syndrome, which is one of the very common reason of Asherman syndrome, correctable Asherman syndrome by hysteroscopic adhesiolysis. And of course, the third common cause is postpartum sepsis or post-surgical causes of cesarean matroplasty, mammectomy, or irradiation. And one of the very common reason we should not forget in our country is tuberculosis. So we'll just go step by step, a preoperative assessment, which is very important. In preoperative physical examination, see why I'm saying this, a lot of time we do sonography, but we don't think of doing PSNPV examination. It's very important. Look at the cervix, look at the pinpoint cervix, anticipate that this is a service where I may have a difficulty in negotiation. So today for Asherman syndrome, if you are doing sounding or just DNC or HSG or SSG is not enough. For accurate diagnosis and addressing the issue, you have to do hysteroscopy. This is something which is very important. Which are the important diagnostic clues? A case of secondary amenorrhea where you're tried estrogen, progesterone, OCP. When you do sonography in an age around 25, 30, it shows a cyclical changes in the ovary, but endometrium is silent. It's persistently showing poor endometrial thickness, and it doesn't have a vitreal bleeding. Think of a intrauterine adhesions, and if you do a proper a classically called a thin endometrium with a good TVS sonography, you can make out the blood flow, and you can, of course, make out a possibility of genital tuberculosis also because of causation and calcification. Why I'm saying this, if you are suspecting tuberculosis, I think it's important that you do due care of recognizing genital tuberculosis and address them with maybe TB-PCR or maybe a gene expert, and give AKT for enough time, and then take a case for adhesiolysis. Because sometimes with AKT only, she starts having a period and have a pregnancy. Now, if you look at a classification is very important. Why you want to do a classification? Now, see, you might be seeing the in the slide level B, level C. Now, what is this? These are the classification, and these are the scientific review of literature tells you the evidences. If you are doing adhesiolysis for mild adhesions, then you are likely to get 80-90% result. But with a severe adhesion, the results beyond 60%, 50% is extremely difficult. I think this is where it is your classification gives you assessment of your treatment, how correctly you have done it. For a mild, moderate, or a severe, it's very important. So there are various classification. Classification may be because based on a symptoms, based on an indication, based on sonographic finding. So there are not many SSC findings, sonographic findings. In terms of a spontaneous pregnant delivery or IVF failure or a persistent IVF failure or poor endometrial thickness. So there are so many parameters. Can you see my slide now? Okay, so there are varieties of classification available. Yeah, I don't want to go in detail of this, but the important point is we may feel that there's no need of classification, but when you are saying that I am 100% result, 90% result, 50% result, it is based on your classification. That is very important, how you are getting a results. Now, which are the challenges in severe Asherman syndrome? Starting from preoperative challenge, poor assessment. If you don't realize, the moment you put a scope, then you realize, my gosh, this is severe Asherman. This should not happen. You should have anticipated, because you need a smaller size of scope. You need a different challenges, expertise, and skills to tackle this. Same way, if somebody has done hysteroscopy and failed, then anticipate that, yes, in this case, I might have an issue. So there's something like a range of, somebody was asking a question, which should be the scope when I'm starting my career, 1.9, 2.9, or 4 mm 30 degree. So it's very important that 2.9 hysteroscope is one that helps you in both operative also, diagnostic also, may not require dilatation, but at the same time understand, if you want to use your scope for resectoscopy, the larger the size of the scope, 4 mm 30 degree, your resectoscope with 19 mm will do your resectoscopy fast. It will reduce the absorption of fluid less and surgery in a quicker way. So your purpose behind doing which kind of procedure will tell you which kind of scope you should be purchased. False facet, perforation, that can be anticipated from a good preoperative assessment and understanding and learning a previous hysteroscopy which has failed. Why? Takes little pains to find out why this has happened. Same way, techniques, a post-operative protocol, a persistent amenorrhea, what should be thought, and less than 4 mm and tuberculosis, and sometimes don't give 100%. You may have to recommend advice surrogate pregnancy. So now let's start with a couple of videos I just want to show you. See, this is one case which is very common in our country, that you may find a calcification. Can you see the causation here? This is one of the commonest kind of finding you find in a hysteroscopy when there is a tuberculous endometritis. Now, why I'm saying this, if you find a slightest doubt in a sonography of causation, calcification, give AKT and then try to do a hysteroscopy. See, this is something which is very important. Now, what we generally do is, now look at this hysteroscopy. See, what we do is, see, can you see the cervical stenosis here? This is the canal. This is the canal or a cavity through which you are supposed to go. So what you have to do is you move your cable in such a way that it finds out that where is the cavity where you want to push the tip of the scope, which is 30 degree, right? Which is beveled. Now, see, if you push here, there will be a false passage. But if you push it here, it will go inside the cavity. So it's very important when you are putting your scope here, moving your cable here, find out that yes, this is how I'm under vision inside the uterine cavity. This is the cervical canal. If you have a doubt, withdraw the scope. You can see the cervical creeps. Make sure that this is.
Sir, sorry to interrupt you, sir. We can't see the, your slide is not moving, sir.
Means you can't see the video now?
No, video is not seen. It is only on the classification of intrauterine adhesions, sir.
Why video is not seen?
Sumit, are you there?
Sir, can you just move your slides, please? Sir, can you move your slides?
In my laptop, it is showing it has moved.
Can you stop share and share again, please?
Resume share or stop share?
Now.
Now can you play?
So we are into 9 minutes of your presentation, and
yes, we can see now. We can see now.
Can you see video now?
Yes, please.
Only the
okay,
video.
madam. I'll finish in 9 minutes. Don't worry. Okay, madam.
No, 9 minutes are over, sir.
Yeah. So this is the video. You can see the tuberculosization I wanted to show you. This is the video I wanted to show you. That see, this is the cervical canal. Now this is the opening, cervical opening. Okay. Now this is cervical stenosis. But what you have to do is withdraw your scope. Okay, when you withdraw your scope, then you can realize this is the cavity and this is the false passage here. So your prevail part of the scope, you have to push it here. This is very important. I think you can appreciate. And when you push your tip of the scope and fluid flow is dilating the cervix and you are undervision inside the uterine cavity. This is what undervision. You withdraw your scope, see the cervical crypts, make sure that this is cervical crypt, cervical canal, and now you are inside this. This is what called undervision, entering inside the uterine cavity, and you can do the adhesiolysis. So anyway, because of the constraint of time, I think it's very important. There are 4 important landmarks, both tubal ostium, cervical crypts at the proximal to the internal os, that you have to constantly withdraw the scope and you have to confirm that you are in the right cavity or not, and then only you have to do adhesiolysis. How much lateral adhesiolysis you will do till you can see the tubal ostium on left side here. You can see that. So you have to go and do your adhesiolysis. You can see this adenomatic adhesiolysis done on left side. Okay, and same way you have to turn your cable on another side, and you have to see that you are doing exactly in the fundus, in the midline, not anteriorly, not posteriorly, so you may not produce perforation. But as I've said, preoperatively, I should know what is the endometrial thickness, myometrial thickness, and it is distant from the serosa. So you should be knowing that how much you are cutting, because when you are cutting, you are likely to go beyond the endometrium. Going beyond the myometrium may produce perforation. These are the few videos I want to show you here. Is the slide has changed or not?
We can see it, sir. Please go ahead.
Now just look at this. This is again a total Asherman syndrome in all the 4 cases. I just want to see, this is what Dr. Malhotra was saying. You introduce the tip of the cervix and open it like this. Create a space. Go inside this with smallest size of the scope called 1.9, and then you enter inside this. In couple of times, you may have a difficulty. What you can do is you can do simultaneous sonography from above, okay, with little full bladder, so you can make out where your fluid is, where your scissor is, and then you can do adhesiolysis called sonographic guided adhesiolysis. Can you appreciate this? So you can do a sonographic adhesiolysis sometimes, because it's absolutely nowhere. You cannot make out where I'm going. So you can make out myometrial thickness anteriorly, myometrial thickness posteriorly, myometrial thickness laterally, myometrial thickness laterally. And then you can, your fluid tells you that where exactly your fluid and your scissor is. And that is how you can go ahead like this. And very same way, of course, undervision is always better, but sometimes undervision you cannot make out anything. Then this is the way I think you have to go ahead and you have to do adhesiolysis. As I have previously told you, that till you have to go on doing it, till you can do both the ostia. When you see then there is a bleeding, or when you see that there is a pink part, myometrium, you have to stop. Otherwise, it will produce a perforation. And you should have anticipation in sonographic finding that how much thickness you are cutting. So I will not go in detail in showing these videos because, of this reason, because I need to complete in next 2 minutes. Now, palliative tuberculosis is one thing that is very ignored. Even taking the case, we are interested in doing a hysteroscopy, but not, interested in making sure that in this case of investigating myometrial means tuberculosis. This is very important, and you should not doing it in deep. Caesar is very important for adhesiolysis as versus energy source. 1.9 hysteroscopy is very important in previously failed cases, and of course in repeated persistent endometrial, poor endometrial thickness, less than 4 millimeter. I think gene expert HP and gene tuberculosis by expert pathologists who know what you mean by tuberculous endometritis. I think that is very important. It's unfortunate in our country that we have very poor pathologists. So I think what about post-operative recommendation? Now, in a post-operative recommendation, if you look at scientific review of literature, evidence Gretzi says nothing helps. In fact, there leads to inflammation and re-addition. So I think police or anything is not recommended. But what we do is we remove the copper part, we put a T part at least for 3-4 days for prevention of adhesions. But people says doing a adhesiolysis by office hysteroscopy is better after 7 days or after period rather than putting a copper T. This is what most of the people say in the world, and lot of literature says. Same way, there are many agents being put in, amnion, hyaluronic acid, being tried, but nothing has helped. But yes, high dose of estrogen premier in 10 tablets, 3 tablets per day for a 21 days, and from 15 to 21 days you give progesterone and see the sonography, follicular study, and endometrial thickness. And if endometrial thickness says good, yes, you can go ahead with your IVF protocol. If it's still poor, I think you can go for repeating the same estrogen progesterone. This is one thing which has rapidly helped in a scientific review of literature. Sildenafil and many agents have been tried for improving the vascularity, but I think it is poor evidence. So I don't want to go in detail about this, but this is one thing that, as I've said, estrogen and progesterone has definitely helped, and one should be given. And in the persistent cases of a poor endometrial thickness, I think tuberculosis is one thing that should be thought of in trying for getting a result before trying IVF. So this is one thing that must be said with the patient. Patient had a poor arsenic outcome. Okay, she can have a ruptured uterus, she can have a placenta creta, even in a bladder percreta, and must be shared with the patient that she can have a PPH and disaster. This should be shared when you are done adhesiolysis. So I don't want to go into detail of this, but you can see from this is a poor live birth following cases of severe Asperger's syndrome, not with mild and moderate. So don't compare with your mild and moderate cases. It is a severe Asperger's syndrome, which is so don't give much hope. That is what, again, a very busy slide, and trying to show you that a cesarean or spontaneous delivery after how many cases, and that has been mentioned in this scientific review of literature. But I think it's a poor result following severe Asperger's syndrome. Just, madam, I will not take more than 1 minute. Just let me summarize guidelines, because this is very important. If patient is not having any symptom and doesn't want a child, assure her that if she doesn't have period, it's not going to harm. There's no need to do any treatment. Number one. Number two, blind probing with a sound or DNC is not recommended. Hysteroscopic guidance is best. Hysteroscopy by expert person with severe Asperger's syndrome is very, very important. And if somebody is trying to justify that external sonography will help in preventing perforation, no, it is not preventing perforation. It helps in going into the correct cavity if you are taken a help of sonography. Okay. Take home message. Last line, madam. Hysteroscopy permits best kind of diagnosis, treatment, and as I've said, if you do a adhesiolysis, a office hysteroscopy after 1 month, pre-adhesiolysis of cleansy adhesion gives the best result as far as severe Asperger's syndrome treatment is concerned. Should replace all other different treatment of for Asperger's syndrome. Video should be given to the patient. So unfortunate, madam, that we are not giving video to the patient, and patient has to go for second, third, fourth, fifth hysteroscopy. What is going on in this country? We must give hysteroscopy. You should have confidence in your hysteroscopy and sharing your expertise and your skills. So she may not have second, third hysteroscopy. Thank you very much for patient hearing and taking little more time. Thank you, madam.
Yeah, that's excellent rounding up, Dr. Pragnesh, of your talk of how Asherman affects women, how to diagnose, how to classify, and how important it is to know what you're dealing with before you enter with a hysteroscope. And finally, of course, those beautiful videos that tell us how to enter the cavity, how to actually perform the procedure. And you also tell us that there is no role of performing any adhesiolysis if the woman has no symptoms. If she's not asking for children, that you could just let her be. There will be just two questions, sir, from my side before I open it to the gathering here. One is in your guidelines, you do mention that there is a very little role of guidance, external guidance, either with use of ultrasound or with use of laparoscopy. I wanted to know what, and eventually you do say that in selected cases, this might help. Could you elaborate on that? Where would you want to use ultrasound? Where would you want to use laparoscopy?
Madam, see, what I'm trying to tell you is, I've clearly shown you in one of my video when you're trying to do hysteroscopy. And case of severe Asherman syndrome, where you don't find any landmark. Now, in such cases, what you should do is use a 1.9 hysteroscope. Then you feel that you are producing a false passage because of the, something cogue appearance of the cavity false passage that you have formed. Madam, people have done a false passage and put in copper in it and referred the patient to us. So imagine they feel that this is the correct. No. So what I'm trying to tell you is, the moment you put a probe, you can make out this is the endometrium and this is the false cavity that you have created. Now I'll confirm this. So for confirming this, so it will not help you in preventing perforation, but what it will help you in going into the correct passage while you are doing a hysteroscopy, simultaneous sonography from above. This is what my, recommendation for difficult cases where you feel that there is a false passage and you have to withdraw doing hysteroscopy.
Right. Thank you, Dr. Pragnesh. Thank you so much for that talk.
So much.
We'll move on to the next talk now.
It is a proud privilege to welcome our next speaker, Professor Sergio Hemovic, Chair and Founder of the Global Congress on Hysteroscopy, Head of the Hysteroscopy Unit, Del Mar University Hospital, Barcelona, Spain, Director of Gynecology, Ambulatory Surgery Unit at Israel Technology Institute, Director and Founder of the International School of Laser in Gynecology. Welcome, Professor Sergio.
Thank you very much. It's a pleasure for me to be here. First of all, I want to thank the OAGD for the kind invitation to be part of this event. I hope you are all safe there. And I was asked to talk about hysteroscopy, of course, but hysteroscopy, myomectomy, and a little bit also about morcellation. So first, I want to state that I do not have any conflict of interest regarding this talk. And, I believe that there is no future without the past. So I want to go to see what happened in the past and how everything was developed until now. So starting with the first endoscope ever. The first endoscope was developed by Bozzini in 1807. Since then, during the 19th century, where many new devices were developed until the first hysteroscopy was performed in 1869 by Pantaloni. It was a device with a candle and mirrors, and he even performed the first surgical hysteroscopy it was a woman pig with postmenopausal bleeding, and she had a big polyp with that was bleeding, and he used silver nitrate to cauterize that bleeding. So he was the first one to perform a surgical hysteroscopy. But what happened since then? I'm going to jump now to the 1960. 1960, the first camera for endoscopy arrived, and it was 13 kilograms of weight. It was a huge camera, of course, black and white. And this is the first camera ever for endoscopy. 2 years later, a smaller one arrived. Just this is the first small compact camera for endoscopy, still black and white in 1962. And we know that a lot of things develop until the very high resolution, high quality we have today in 3D. What about the approach to the submucosal myoma? What about surgical techniques? So, you know, one of my hobbies is old books, antiques. So I have a book from 1894, so 126 years ago, about surgical gynecology. And I went to the submucosal myoma, and what they did, they cut around the myoma after performing a dilation with some sponges, and with the fingernail, they just enucleate the myoma from the cavity, from the uterine cavity. And doing that, they saw that they could find 3 different results. One was the total enucleation of the myoma. Second, they saw that deep intramural myoma that only has a small portion in the cavity was migrating into the cavity, and it was a failure. So this thing is very important for me because I thought I was very original, very different by doing the enucleation technique until I found this book. Then I have another one in 1921 in which the technique changed. They performed all vaginal myomectomy. If they couldn't do that, directed to hysterectomy. There weren't any more surgeries for submucosal myomas. Until 1976, when the resectoscope, the one we use today, came to gynecology from urology. And the only change, the only develop since 1976, it was going from monopolar to bipolar. That's all. It's still the same old tool that arrived to us from urology in 1976, that instead of taking out a whole tumor, a whole myoma, it makes a distraction bit by taking out small chips. What's the approach? So before we understand the approach of the myoma today, I want to go and understand the anatomy of the myoma. There's around the myoma what we call the pseudocapsule. The pseudocapsule is an area that it's between the myometrium and the myoma. And there are a lot of small, very lax connective tissue bridges that all together anchor the myoma into the myometrium. And there's a lot of small blood vessels around it that they supply all the blood the myoma needs. There is not a pedicle, only the pedunculated myoma, there's a pedicle. If we perform a Doppler color of a myoma, we see what we call the ring of fire, very small vessels around the myoma, surrounding it, because they are all inside the cytocapsule. During the hysteroscopy, we can also see the cytocapsule. In this case, in this picture, you can see between the mucosa, the endometrial mucosa, and the myoma, this area in the small picture, you see a lot of small connective tissue bridges, very lax, very easy to dissect. So I want to show you what we perform in open myomectomy or even in laparoscopy myomectomy. What we perform is we look for that plane, the cleavage plane, the pseudocapsule, to enucleate. In this case, in laparoscopy, the same. We enucleate a myoma. We look for this plane, and through this plane, easily we can take the myoma out as a whole, not pieces, but the whole myoma. In hysteroscopy, we can see also this plane, and you're going to see it in a moment. This is, you see the myoma in the lower part. You see the myoma here on the right and the myometrium on the left. And with a small grafter, you can perform the dissection of this area. Just going around, you make a dissection, the same like during laparoscopy. In a moment, you're going to see how lax, look, this tissue, connective tissue bridges are very lax, and you see the small blood vessel that I'm cutting, and I'm compromising vascularity of the myoma. And at the end, you see in the lower part of the picture, you see the myoma, and then the myometrium behind. So you can do an enucleation like in laparoscopy, also during hysteroscopy. Which are the myomas that we treat by hysteroscopy? Those that affect the cavity. and they are between they represent between 5 and 10% of all the myomas, but they are the most symptomatic one. They are responsible for bleeding, responsible for infertility. That's why we need to perform surgery for them and to take them out. We have, in the last 10 years or so, we have been using also this tissue removal system. They are different. You see them here in different pictures. There is the True Clear from Medtronic. There is the MyoSure, the most used in the United States, from Ologic. And you have one from Storz, the shaver, the Gatti shaver. They all do the same. You're going to see it in a small video. It's a video that we performed here for a 2-centimeter myoma. She was awake. This is the shaver. And the shaver, you can put inside the shaver this, inside the scope, the shaver, it's special, you see the myoma. And the shaver, what it has is a small window, and there's suction. And when you put it near the myoma, it goes, there's suction force, and then there is a rotating tool inside that they cut small pieces of the myoma, and it goes all together out, and you have enough tissue also for histology. And it eats slowly the myoma. That's how it works. It works for myoma, for polyp, for retained products of conception. It's an excellent tool. And there are different diameters, so you can do some in office, others for OR. And you see how it eats slowly the myoma. That's the idea about tissue removal system. But are they perfect? This is a big question. No, they have some limitations. This is the brochure of the MyoSure. And they state, and you can see it in the lower right corner, that for myomas type 0, type 1, you can extract 100% of the tissue. But for myomas type 2, you can remove only 50% of the tissue. So I bring you all for a paper published some years ago, 4 years ago, in which you can see that this tissue removal system can remove only 60% of the myoma. And there is an inverse relation between the myoma size and how deep they are with the percentage of tissue removal. The deeper and bigger they are, less tissue we can remove. So it's very good for myomas that they are almost completely inside the cavity or completely inside the cavity, but not so good for myomas that they are still inside the wall. And then we have the technique that was developed by Ivan Mazzone in Italy, the cold loop. What Ivan Mazzone developed is is a technique that's very interesting. The first step is performed by resectoscope. And what he did, he performed a resectoscopy of the endocavitarian part of the myoma. Only the part that was inside the cavity, not the part that was inside the wall. What he did for the intramural part, he developed these tools, no energy, they're very strong, robust tools, and he used them to enucleate the intramural part as a whole piece. Indeed, by doing this, he preserved the myometrium, no myometrium injuries, no myometrium scars. And his series published series of almost 1,500 myomas. So he has a lot of experience with that. In 2009, Stefano Betocchi, he published this technique, opium technique, the office preparation for partially intramural myomas. And what he did in office, first step of 2 steps, in office, he cut with the Versa point, bipolar twizzle, a crown around the myoma. And he saw that at that moment, the natural behavior of the myoma was to migrate into the cavity. So a G2 myoma became a G1. He did it, he performed this technique on myoma with a mean size of 29 millimeters, they are big. And he sent them in the second step, because they were inside the cavity, for a resectoscopy in OR. So first step in office, preparing, second step in OR, and he achieved a 93% of success rate by doing this technique. This paper inspired me 11 years ago, and I thought, why do we need to send them to OR? Why not to finish the enucleation in office? And we published it in 2013, 8 years ago. And we did the 2 steps without anesthesia in office. First step, we cut a crown around the myoma, reaching for the pseudo capsule, and then we started to enucleate the myoma. And we saw, like Betoki, that the myoma started to migrate into the cavity. And sometimes we needed 2 steps to finish the enucleations if there were G2 myomas. And many times, if there were G1, we finished with 1 step. And we saw that our success rate was of 100% for myomas until 18 millimeters. Myoma of 19 until 3 centimeters, a success rate of 85%. But the curious data is that for fibroids of more than 3 centimeters, our success rate was of 0. And it has an explanation. If the table that we want to put into the room is bigger than the room, you cannot put it inside the room. If the myoma is bigger than the cavity, you cannot enucleate it and bring it inside the cavity. That's why with myoma with 3 or more centimeters, we couldn't do this enucleation. And I want to show you something. This is the step W classification developed by Ricardo Lasbar in Brazil. And all the classifications of the myoma are based on characteristics of the myoma. Size, how deep they are in the wall, which wall they are. All the characteristics belong and are related to the myoma. And we introduced some years ago, 5 years ago, actually, this new factor, the ratio factor. In this picture, you see the same myoma, the same size, both in both uterus, the same size. But of course, in a multiparous uterus in which the cavity is bigger, it's much easier to perform surgery than do it in a nulliparous small cavity. So you have to take into account not only characteristics based on the myoma in order to see how difficult the surgery is going to be. You have to take also into account the size of the cavity, and it's an important factor that will limit your surgery. So we can increase the success rate by increasing or this factor in a way. So we cannot reduce or increase the cavity of the uterine cavity, but we can reduce the myoma. As the idea was to reduce the myoma. It's important to reduce the myoma. Look at this graph. It was published 5 years ago by Mark Hans Emanuel in Holland. You can see the diameter of the myoma and time of resectoscopy in OR. For a 3 centimeters myoma, you need 30 minutes. But if we go up only 1 centimeter to 4 centimeter myoma, you don't need 30 minutes, you need 70 minutes. You multiply per 2 or more the time you need for a myoma. So if we can reduce only by 1 centimeter the myoma, it will be less operating room time for the patient, less probability of complication, fluid overload. So it's important to try to reduce. The thing is that until some months ago, we had the ulipristat acetate, but we don't have it anymore. So we're waiting for a new drug to come in that will be selective of the myoma, that will be able to reduce the myoma and make easier our life in OR. What about G0? Because we talk about G1, G2. What about G0? What's the surgery of the G0? So for me, it's very easy. I only cut the pedicle and I finish. I take a biopsy because we need this tissue for histology, but you finish by cutting the pedicle. So imagine a 3 centimeters, 4 centimeters myoma that instead of taking everything out that will take you in OR 40, 50, 60 minutes, you just cut the pedicle. It will take you only a few minutes and you finish. And what happened with the myoma? We leave it inside freely, inside the cavity. And we published this series of 63 myomas left inside the cavity, 61 myomas left inside the cavity, 10 of them more than 3 centimeters of diameter. And in a follow-up ultrasound, 2 months after we enucleated it, we left it inside the cavity, it disappeared in 100% of the patients. This paper was very criticized by the community of my colleagues. So we finished, and it's in review in the European Journal, a multi-center study in 9 countries, 11 centers, with more than 200 myomas left inside the cavity, and the results are the same. They disappeared. How they disappear? There are 2 reasons. If they are small, when the woman, she stands up because of the pressure of the uterus, it falls out. if the myoma is small. But if it's not small, we perform hysteroscopy for follow-up, and we saw that the uterine cavity, it's not dry, it's humid. It's not sterile, there are bacteria, so there's a necrosis and it becomes a very smooth mass, and it comes out without the woman feeling it during the menstruation. So you can leave it inside and don't be afraid. And I know that some of you are afraid. Listen, what if it's a leiomyosarcoma you're living inside freely? So I ask all of you, how many of you perform before a resectoscopy a biopsy of the myoma? None. And during the biopsy of the resectoscopy of the myoma, there is a dispersion of small pieces of tissues from the tubes into the abdominal cavity. Are you worried about that? No. And we don't have more spreading of malignancy because of that. Even in the guidelines of the AAGL regarding submucosal myoma, when you go to submucosal myoma and malignancy, there is a very nice phrase, no data about it, because leiomyosarcoma, it's not in fertile women. We see it in women that they are more than 65 years old. They are bigger myoma, not small submucosal myoma. So don't be worried, it's safe. What are the advantages of preserving the pseudocapsule and doing the enucleation during this kind of surgery of doing hysteroscopy? So from one side, we preserve the myometrium integrity. There are no thermal injuries in the myometrium. There are no scars in the myometrium, and the probability of adhesion is very low. This is something that Ivan Mazon checked in more than 1,400 myomectomies, and he saw that doing this enucleation, there are no adhesions. So it also we have a faster healing of after surgery, and it's especially good for women that want to become pregnant in infertility clinics. So I advise you to try this. I want to show you a small video that will give you some seconds of all the techniques. The first one is the cold loop that they told you that he performed resectoscopy, as you see, of the intracavitarian part of the myoma. And then he brings this tool, this cold loop tool. And what he performs is an enucleation. Look, he goes to the pseudocapsule plane and he performed the enucleation of the myoma, the intramural part of the myoma. All these tools are meant for that. You're going to see in a second another kind. This is doing office hysteroscopy without anesthesia. We're going in and you see this very flat myoma. It was around 1 centimeter or even less, but it's a G2 myoma, almost everything inside the wall. And we cut the mucosa and we look for this plane. Look, we just do the dissection and you see the myometrium, the big myometrium behind the myoma. And this flat becomes a small ball inside the cavity. You're going to see it in it. It's almost free. And you take a grasper and you take it out. This is an enucleation. This is the kind of myoma you should start with when you do want to perform enucleation. This is a bigger one. Again, we go for the mucosa, we go to find the Kleeblatt's plane, and we do the enucleation. Look how nice the myoma is dancing. This is bigger inside the pseudocapsule. You're seeing the myoma, and we do dissection, until we reach a moment that the myoma is coming out. You're going to see it in a second. This is the last time, and the myoma is almost free, and no adhesion. You see, this is where the myoma was, the fovea, where the myoma was a second ago. You see it there, and the myoma is free inside the cavity. This is an enucleation. This one is performed with laser. Laser cuts and coagulates at the same time. A dispersion of the heat is 0.5 to 1 millimeter. Look how it coagulates at the same time it cuts. So the dispersion of the heat is so small, 1/2 to 1 millimeter, so the patient doesn't feel anything. And then we go to do this, find the Kleeblatt's plane, like in laparoscopy, and we perform the enucleation of the myoma easily. This is an enucleation with a cold loop performed by the mini resectoscope. The mini resectoscope was developed by Gubini. There's another one now by Storrs also, and they have the cold loop tool, and you can do without the enucleation the same you saw before. So this is what's going on now with hysteroscopy and myomectomy. By this way, we preserve the myometrium. It's very good for our patients. So I want to finish with these sentences. One, you stop learning, you start dying. So please, please, please never stop learning. Thank you very much for your attention.
Thank you, Dr. Sergio. I think it was an excellent lecture and many learning points in your lecture, unique techniques. I had one question. I do mainly fertility work. When you leave a myoma in a woman who would later want to become pregnant, have you done a hysteroscopy subsequently to see whether there are any adhesions or some kind of infection or fibrosis that myoma has caused?
At the beginning, we did that, but we saw that there weren't any, and it was very, the healing is very fast because the moment you preserve the pseudocapsule, what happened with the myometrium fibers, there is a phobia because there is the pressure of the myoma elongated the fibers, the myometrium fibers. The moment you take out the myoma without damaging the fibers, they come up again. You know, they stretch themselves and they come up again, and you have a perfect cavity after 1 month. You have a perfect cavity. We do, after 2 months, the follow-up ultrasound to be sure that the myoma is, because 100% disappear. If they are small, they disappear before. But during the hysteroscopy, the beginning we used to do 1 month after, everything was perfect.
Any patient with post-op fever?
With what?
Post-operative fever.
No, there weren't any infections. That's one of the things that I was criticized for. I told you by my colleagues because they thought we might find more infections or secretions with, but nothing. In the last one with more than 200 myomas, not even one fever.
And you, what antibiotic cover do you give, or do you give an antibiotic cover?
No, we don't give.
No.
Even we don't give antibiotic in any hysteroscopy surgery. There are not more infections. There is a Cochrane review very nice about it. There is no need to during hysteroscopy to give antibiotics. There is no more risk of endometritis, giving or not giving. You don't see differences.
Yeah, but I just felt that leaving the myoma, one would give one antibiotic just for being
I
safe.
know, because you are worried, not because there are problems. It's a iatrogenic treatment.
And the enucleation of the myoma was an excellent technique. I think that's something which should be done for all infertile patients because it would really preserve the cavity.
You know,
Thank
when
you
we
so
started
much.
to preserve the pseudocapsule, we started to talk about it, and it was something new. It was 8 years ago. Right now, every hysteroscopist that is performing surgery of the intrauterine cavity and he performs myomectomy, he always will talk about the importance of the pseudocapsule. It's something you have to take into account seriously.
Thank you so much. I think there's going to be a question answer session after this.
There was a question in the chat box. What is the size of myoma with respect to myometrial thickness that you are comfortable excising, Dr. Sergio?
Oh, it's a good question. In order to avoid complications, if you are not skilled in myomectomy, I advise you not to go over 4 centimeters during resectoscopy. The limit today that it's advised, it's in the classification of plasma I showed before, it's 5 centimeters. It's very difficult to do. They're very big. And if you go into a myoma that it's big and you see that the hydric balance, the fluid balance, it's not so good, it's better to do more than one step than to go on and to go into complications.
So much, thank you. Thank you all the speakers, Dr. Richard, Dr. Pragnesh, and Dr. Sergio for the excellent talks. Thank you all.
Thank you, Dr. Sergio. It was a wonderful talk, and you really made hysteroscopic myomectomy very, very easy for us. And thank you all the chairpersons and speaker for session 5. Now, can we move on to session 6?
Thank you. Thank you.
Thank you. So
Thank
the
you,
next
Risha.
session
Thank
is.
you.
Thank you, sir. So the next session will be on complications of hysteroscopy, tips and tricks. For that, I would like to invite our esteemed chairpersons.
Ma'am, you can continue.
Change the slide, please. So the chairpersons are Dr. Subohi Qureshi. Can you put her CV? Dr. Subohi Qureshi, she is the professor and head of the Department of Gynae Oncology. She is the dean at Super Speciality Cancer Institute, Lucknow, UP. Welcome, Dr. Subohi. Next chairperson is Dr. Neeti Agarwal. She is the senior consultant at Sir Gangaram Hospital, and she is also the joint secretary of AOGD 2020.
She is Dr. Neeti Tiwari.
Next slide. Next chairperson is Dr. Anupma Bahadur. She is the additional professor and unit head in the Department of Obs and Gynae at AIIMS Rishikesh. Welcome, Dr. Anupma. So our first speaker is Dr. K.K. Roy, and he'll be talking about the complications of hysteroscopy, how to avoid.
Good evening, ma'am. Ma'am, am I audible?
Yes, you're audible. Dr. K.K. Roy, he is the unit head and chief of minimally invasive gynae surgery division at AIIMS Delhi. Welcome, sir.
Good evening, ma'am. Ma'am, unfortunately, sir is stuck up in an emergency case, so I'll be speaking on his behalf. Ma'am, I'm Dr. Shikha. I'm his fellow, ma'am. And
yes,
it is an honor
yes,
for me to be speaking in front of stalwarts like all of you, ma'am.
Welcome, Shikha.
Thank you, ma'am. Ma'am, sir will take questions. Sir will take questions towards the end of the session.
Okay, that's fine, Shikha. You carry on.
Yes, ma'am. Ma'am, I'm going to speak on hysteroscopy complications, tips and tricks to avoid them. So I'll be taking on the complication scenario wise, one by one. First, a few words about introduction. Complications during hysteroscopy can arise right from patient positioning to even post-op complications. We'll be limiting our talk to intraoperative complications during hysteroscopy. During diagnostic, the rate of complication obviously is less than operative. In operative, it can amount to up to 4% of all hysteroscopies, and in advanced hysteroscopy procedures, they may be around 3%. Highest rate is seen with adhesive procedures, which may be up to 4.5%. So the first scenario is, there was a patient posted for diagnostic hysteroscopy under paracervical block and sedation. And while we were passing the dilator through the cervix, the patient suddenly collapsed, became pulseless, and even BP was not recordable. So we cannot be lax during diagnostic hysteroscopy. Vasovagal can occur during diagnostic also. This has happened in our institute. Could it be air embolism? Even air embolisms can occur. Vasovagal usually is a response to intense pain stimulus, and mostly it is seen in women with nulliparous cervices, with stenosis cervices, and usually in women with cardiovascular abnormalities. The tips and tricks, most important is to thoroughly work up the patient. A patient who is not worked up well, if we miss cardiovascular problems, we miss other medical comorbidities, that patient is prone to suffer vasovagal more than others. Very important to talk to the patients, to counsel them well, because a patient who is well counseled, who has been explained the procedure well, would understand it better, would be less anxious, and less anxiety means less pain and hence less vasovagal. There has to be continuous monitoring, whether it is operative or diagnostic. There has to be a person, a dedicated staff member with eyes on the monitor all the time. The patient has to have an IV cannula. We cannot be casual about it. And air has to be flushed from all the instruments. Cervical preparation can be done in select cases with misoprostol, that is proven, and most in cases, especially in cases where we anticipate that we could have a difficult entry. Coming to the second scenario, there was a 29-year-old woman with the normal menstruation who was diagnosed with grade 4 adhesions on diagnostic hysteroscopy at an outside center. And we repeated the hysteroscopy at our center, and it revealed normal findings. So these are access-related troubles where there can be trauma to the cervix, or there can be formation of a false passage, usually seen while either sounding the uterus pre-procedure or dilating the cervix, or even at the time of hysteroscope insertion. And we diagnose it when the muscle fibers are visible, but we do not see the ostia, or we do not see the uterine cavity. What we reach is a blind end with muscle fibers visible. So then that is when there is a false passage. We must never attempt more than 2 times without anesthesia. It's better to plan it in OT under anesthesia if 2 attempts have failed. So the tips and tricks would be, it's always the best is, again, it cannot be reiterated enough that the patient has to be worked up well. We must be able to anticipate the problem. We must be able to anticipate who are the patients who are likely to have difficult services that we might face a problem dealing with. And also important is, whenever there is a cervical trauma false passage that has happened, it is all very, very important to rule out perforation also. And vaginoscopy, which is a method where we do not use instruments, we follow the principle of hydrodistension. We let the distension medium dilate the vagina, dilate the external os, and then follow the dark circle, keeping it in the center of the view. Compact hysteroscopes are preferable. It has been proven in studies that compact hysteroscopes and even flexible hysteroscope, less injuries, less vasovagal also. So they are preferable. The next scenario, during diagnostic hysteroscopy after cervical dilatation, when hysteroscope was introduced under vision, the field was obscured by blood and the cavity failed to distend even after waiting for a few minutes. There's another scenario with the same problem. A 26-year-old presented to the casualty with high-grade fever, abdominal distension for 2 days with not having passed flatus or stools since having undergone hysteroscopic septal resection 5 days ago for recurrent abortions. So what do we suspect in this? In the first case, we see that the cavity was failing to distend. We were going on pushing fluid, but the field was obscured by blood and the cavity did not distend. In the second one, though we managed to complete the procedure, but the patient came back to the hospital with an emergency. So this is the case of uterine perforation. When there is a cavity that was initially well distended, we were going on well, suddenly there is a loss of distension. And with the loss of distension, though we keep pushing in fluid, there is a rapid rise in fluid deficit. And also there can be sudden bleeding, the field gets obscured by blood. So very important that pre-operatively, we do a good examination. Again and again, we pressing on this point that a good workup can solve 50% of our problems. Pre-operative cervical preparation can also be done in cases where we anticipate difficult cervix. Because when we wrestle with the cervix, there are more chances of uterine perforation. So if the cervix is soft, if the cervix gives way to an instrument, it is easier, the perforation chances are much reduced. And it's very, very important to know when to stop. Suppose whenever we are either doing a myomectomy or septal resection, we must know that we have to stop when both the ostia are visible in one plane. We should be able to move the tip of the hysteroscope from one ostia to the other in one plane without needing to take out the hysteroscope. So it should be freely movable from one ostia to the other. Energy devices, if we are using, we must activate the energy devices only when under vision, only when they are in vision, and we should avoid continuously keeping the instruments continuously in an activated state. That also leads to injuries. And young surgeons who are new in the field of hysteroscopy can always do these procedures under laparoscope guidance. The next scenario, during hysteroscopic endometrial resection, the field kept getting obscured by bleeding. This is commonly seen in transcervical resection of endometrium or transcervical resection of fibroid, where the surgeon is disturbed by the field getting obscured by bleeding. So it's important that we build up our patients well. The basic principles of surgery apply to the principles of hysteroscopy also. So good examination, good history, and patients to be built up well, because anemic patients will tend to bleed more intraoperatively. So if patients are built up well, they'll bleed less. And if the field is obscured by blood, we can open the outflow, shut the inflow and open the outflow so that the blood is cleared in order for us to clear the bleeding. We can also increase the distension pressure a little within safe limits, so that the distension fluid acts as, it has a tamponade effect on the point of bleeding. We can coagulate at the bleeding site, taking care that the instrument or the electrosurgical equipment is used judiciously. And pre-treatment with GnRH analogs, especially when we are going to deal with larger fibroids, is a good idea. Dilute vasopressin solution has also been used. It can be injected into the cervix. It has been seen to reduce the bleeding, even has been seen to reduce our difficulties with the manipulation with the cervix. The next scenario is a patient was undergoing transcervical endometrial resection with a resectoscope, which involved multiple removals and reinsertions of the instrument. The surgeon had to suddenly abandon the procedure midway because of a dramatic fall in patient saturation. Now, this is a complication which is not very rare, and it is a catastrophic complication where it may not even give the surgeon time or give the anesthesia team time to react. So air embolism, very, very important to be careful about this. It usually occurs when there is inadequate purging of air from tubings and instruments. It can also occur due to the gas bubbles that can form intraoperatively from tissue vaporization when using radio frequency electrosurgical electrodes. And also high intrauterine pressure. If the intrauterine pressure is beyond the safe limit, it can push these bubbles or this air much faster into the systemic circulation. So it's important, if this occurs, to immediately abandon. That is what it is important to know, that we cannot be very enthusiastic and just carry on it. We have to immediately abandon the procedure. And how to prevent its recurrence in the future, that the cervix, once dilated, it should be kept covered after dilatation. So in case we have to remove a hysteroscope or remove a dilator, the cervix should be kept covered. And we must ensure that all the tubings and instruments have been, the air has been purged from them, because room air can be the most fatal. Even 50 ml of room air can be fatal. And it's very, very important to not repeatedly remove our instrument and reinsert it from the cervical os, because that can have a piston-like effect, and if whatever little gas bubbles are formed intrauterine or little air is there, even if it doesn't intend to go into the systemic circulation, this repetitive movement can push this air into the systemic circulation. It's important to maintain pressure, intrauterine pressure, less than the mean arterial pressure, so around 50 to 80, always under 100 millimeters of mercury. And there has to be in all hysteroscopic procedures, there has to be a dedicated staff member taking care, looking at the monitor, taking care of the changing of bottles also. So even when he's changing the saline bottle from one to the other, the surgeon has to be informed. There has to be caution so that the air bubbles entry into the uterus is prevented. Coming to we've saved the most important for the last. So the last two scenarios are, while undergoing hysteroscopic myomectomy for grade 1 myoma using bipolar electrosurgery, the saturation of a patient fell to under 75%, and frothy fluid started coming out of the laryngeal mask airway. the next scenario was a patient who underwent hysteroscopic myomectomy in the immediate post-operative period became agitated with frequent episodes of vomiting. So these two scenarios reflect a problem which is because of the distension medium. So distension medium troubles usually we face in complex or long surgeries like transcervical resection of endometrium or transcervical resection of fibroid. And though it is more commonly seen in women who are in elderly and women with comorbidities, cardiovascular abnormalities. However, if at all it occurs in premenopausal women, it is much more intense in them because the estrogen inhibits the ATPase pump. And this ATPase pump is the one that controls the movement of air across the blood-brain barrier. So premenopausal women are more prone to having brain damage as a result of distension medium problems if at all it occurs in them. And when using monopolar, there is electrolyte imbalance, and when using bipolar, there is fluid overload. So we cannot relax when using bipolar thinking that, you know, the distension medium troubles will not happen with bipolar, because the problem of fluid overload can occur even when using electrolyte rich medium with bipolar. So there has to be close monitoring throughout the procedure, even when using electrolyte rich medium. So there has to be a staff member whose job is to look at the input output during the procedure. We must consider hidden losses also. So the cervix should be dilated only as much as required. A cervix that is dilated more than the instrument will keep pushing in fluid, and then keep the cavity would not be distended. We'll keep pushing in fluid. So more chances, the more the fluid is pushed in, the more the chances of this problem. And when using gravity bags, we have to adjust the height. That a height of 100 centimeter corresponds to around 70 millimeters of mercury. And better, safer is automated delivery systems. And then we must, if when measuring the output, urological drapes are there. And plus we also have systems where we can measure the outflow also. And we must remember the safe limit for both electrolyte free and electrolyte rich media. Healthy females 1000 ml for electrolyte free, and for electrolyte rich, though this is an expert opinion, they have fixed the limit at 2500. And for elderly it is reduced 750 ml for electrolyte free and 1000 ml for electrolyte rich. And we can consider using preoperative GnRH in surgeries, which mostly for myomectomies, because it has been proven that GnRH enhances the ATPase pump. So it will reduce the flow of fluid across the blood-brain barrier. Thank you, ma'am. Ma'am, questions, ma'am. Sir will take questions.
Wonderful talk, Shikha. You have really summarized everything very nicely, and that also in time. So can we move on to the next speaker, and then we'll do the discussion at the end of this session.
Ma'am, sir will take questions, ma'am, in
the questions
maybe after the session.
in the chat box also.
Okay, we'll discuss the question right now.
I think Dr. Richa, she said that sir will join for question answer around
later. Yes, ma'am. Yes, ma'am.
So we start with Dr. Sandeep.
Okay, so our next speaker is Dr. Sandeep Datta Roy, and he'll be talking about the complications of hysteroscopy, how to tackle. Dr. Sandeep, he is the endoscopic surgeon and IVF specialist at GEM and Raji Nursing Home at Thrissur. Welcome, Dr. Sandeep.
Thank you, madam, for giving me this opportunity to present here. So I'll just share my slides. Okay, can you see my slides?
Yes, we can see.
Yeah, thank you. So I'll be presenting on how to tackle the complications of hysteroscopy. So here I'll be mostly talking about the treatment. We'll not go into details about how to prevent and all, as it has been already discussed. So the usual complications are cervical laceration, uterine perforation, then you have fluid overload, hyponatremia, gas and air embolism, and bleeding. So these are the usual complications that we can encounter during hysteroscopy, and rarely we can have hematometra, especially after TCRE and all. So cervical laceration, it can be exocervical laceration and endocervical laceration. So exocervical laceration, it results when you pull the cervical anterior lip with the tenaculums. It is rarely serious, and if there is bleeding, it can be repaired by
placing a suture, and we can avoid all it by using misoprostol, vasopressin, then small diameter scopes and gynoscopy. And coming to the endocervical laceration, when there is excessive force used for cervical dilatation, or if there is an use of GnRH analog used preoperatively, that can sometimes give rise to severe bleeding or excessive fluid absorption, because inside of the cervical canal can get lacerated. So it can be managed by cervical packing and cervical branch of the uterine artery ligation. Okay, so again, uterine perforation, like if there is a sudden loss of resistance during cervical dilatation, if there is sudden loss of cavity distension, then it denotes uterine perforation. Then sometimes you can see there is a sudden increase in flow rate of the distension media. Then you can see the omentum and the bowel through the uterus. So if these are the scenarios, if you find that indicates that the uterus is perforated. So there can be two types of uterine perforation, sometimes with cold surgical devices like dilator, obturator, resectoscope, etc., or sometimes with electrodes like monopolar or bipolar electrodes. So that is more dangerous because it can give injury to the other surrounding pelvic structure. So what to do when you have a uterine rupture? So if it uterine perforation, so if it perforates before the actual surgical procedure, we have to immediately stop the procedure and observe the patient for 24 hours. Some people do not advocate routine laparoscopy, and some say that it is not very sensitive in detecting early bowel injuries. But we prefer to do laparoscopy in most of the cases, especially when like there is a previous cesarean section, or there are other pelvic surgeries, or if you see active bleeding from the perforation site, it is always better to go for a laparoscopy. So the patient should be hospitalized for 24 hours, and you can discharge them with the advice to come back if there are symptoms of peritonitis. So late bowel injuries can present as peritonitis, so patient has to come with if there is some symptoms like fever, etc., so they can come. So another question is whether to suture or just to coagulate the bleeding area. So if the bleeding area is a very small, if the perforation area is very small, and if there is not much of bleeding, then you need not to do any suturing. You can just apply some pressure and then come. So here you can see we are doing a tubal cannulation, and this uterine corneal area is perforated. So here it is only like minimal bleeding is there, so you can apply some pressure with a atraumatic grasper, and then you can wait for 5 to 10 minutes. If the bleeding stops, it is all right. Otherwise, we can just apply cautery, like bipolar coagulation, like this, just a simple burst of cautery. Then again, if there is bleeding, severe bleeding, and if the defect is quite large, then it is always better to place a suture, because like if the patient wants to become pregnant, there is a chance of rupture if you leave it unsutured. So this is one more case, like you can see here, septal resection is being done with a monopolar. So here one important thing is, like, see, in the corneal area, if your movements are haphazard or if you are careless, like you can have uterine rupture. So immediately the cavity will collapse, and then you have to do a laparoscopy. So in a laparoscopy, you have to identify where it has ruptured, if there is any bowel injury, if there is any blanching of the bowel, etc. So one can try to if it is a very small injury, then you can try to apply pressure and control it. But whenever there is an injury with an electrosurgical device, most of it is always better to place a suture. That is what we practice, because most of these patients will plan for pregnancy, and if you leave a defect in the uterus without suturing, then there is a high chance of pregnancy. This is another case which I did. So there was a uterine septum, and patient had endometriosis also. So after diagnosing the septum, we tried to dilate the cervix, and then we could suddenly feel the dilator gave way. It was an acutely retroflexed uterus. So you can see the omentum and all, and there was bleeding also. So immediately we did a laparoscopy. So in the laparoscopy, there are a lot of adhesions. So we released all the adhesions, and then we tried to identify the place of the site of the perforation. So you can see a lot of bleeding is there. So after, you can see the dilator is coming out through the perforated area. So sometimes, it may be difficult to identify where the actual place of perforation. So you can keep the dilator there, and over that you can take a suture and close the defect. So we took a suture over the perforated area, and this is how it finally looked. So it is always better to place a suture when you have bleeding or it is little bigger. The next complication, which is very dangerous and very common is fluid overload. So it can result from any type of fluid, whether you use glycine, normal saline, or other fluids, and it is most easily avoidable. You can like one can follow strict monitoring of fluid input and output, and use of automated fluid monitoring system to identify fluid overload. It is mostly seen in cases like myomectomy, TCRE, where the surface area is very large and a large number of vessels can be opened. So in those cases, one has to be very, very careful. So you can see like patient can have presence of froth in the ET tube, then crepitation in the lung base, parotid sign. Parotid sign means the parotid area will be swollen up. So if you measure the distance from the philtrum to the mastoid, so you'll find that area is boggy and swollen up. Then again, if there is a glycine or other things are used, like the patient can have nausea, vomiting, headache, visual disturbances, agitation, etc. So glycine is still used in many of the operating theaters. So it can create a lot of problem like hypervolemia, hyponatremia, hypoosmolality, and hyperammonemia. So ammonia is the main culprit that causes the encephalopathic symptoms. So glycine is metabolized by oxidative deamination into ammonia and glyoxylic acid. So ammonia is the one that creates a lot of problem. So from the systemic circulation, glycine will be absorbed intracellularly, leaving behind a lot of fluid in the vascular system. So that will give rise to hypervolemia, and at the same time, after metabolism, all the ammonia will be released in the systemic circulation. So this two combination can give rise to symptoms. So all the systems like CVS, CNS, respiratory system, eyes, everything can be affected when the glycine is like intravasation is more. So what happens when there is hyperammonemia? Normal ammonia level is 11 to 35. So if 1 liter of fluid is absorbed more than, then it can go even more, like more than 150 millimole per liter. So patients can have nausea, vomiting, altered mental status, muscle pain, brain damage, etc. And many a time there will be a reversible and temporary blindness. This is because of secondary inhibitory neurotransmitter effect of glycines on the retina and the horizontal and the ganglion cells. So temporarily they can inhibit these cells and produce temporary blindness. So treatment is you can administer L-arginine to stimulate metabolism of ammonia by the urea cycle in severe ammonia toxicity. And some have also used lactulose as we use in liver failure. So why it is so dangerous, hypervolemic hyponatremia? Because it can cause irreversible brain damage due to hyponatremic encephalopathy. So as I said, rapid increase in intravascular free water navigates through the cellular membrane, then that can cause cerebral edema and brain injury due to compression against the bony skull. So as the intracranial pressure keeps on increasing, the cerebral blood flow will decrease, and this will give rise to hypoxemic brain damage and pressure necrosis. And it has been found that if there is a 5% increase in intracranial volume, then the brainstem can herniate and patient can die of respiratory arrest. So if 1 liter of hypotonic fluid is absorbed, the sodium level will fall by 10 millimole per liter. So a patient will absorb at least 1 liter of fluid before demonstrating symptoms. So it is very important, if before you do any surgery with glycine, always do the preoperative sodium level, because if the sodium level is 30 is the lowest normal limit. So if it falls another 10, then patient will develop severe form of hyponatremia, and they can have a lot of complications. So you can see here, if it is between 125 to 130, the symptoms are usually mild to moderate. But if it is less than 120, patient can have severe hyponatremia, encephalopathy, cardiac failure, lethargic confusion, etc. And if it is more than 115, most of this patient will have can die. So one has to be very, very careful. So what to do in the event of fluid deficit and hyponatremia? So if the deficit is 1 liter, you have to assess the symptoms and electrolyte status. Then if the deficit is 1.5 liter, you should immediately abandon the procedure. And in special circumstances, like if the patient is very elderly with severe cardiovascular disease, liver disease, CNS deficits, etc. So, or those patients who are on diuretics. So in such cases, the limit is around 750 ml. So treatment is like you have to give diuresis and you have to correct the hyponatremia. So how to manage hyponatremia? If it is 130 to 140, you don't need anything. But if it falls between 120 to 130 milli equivalent per liter, so you have to immediately restrict any IV fluid and give diuretics like Lasix and check the sodium level every 4 hourly. If it is below 120, it becomes a very severe kind of hyponatremia and it requires hypertonic saline infusion. So hypertonic saline infusion is also a very tricky thing. So it is always better to involve an intensivist or a physician. So acute hyponatremia, like if it is diagnosed immediately on the theater, then you can promptly correct with diuretics and hypertonic saline. If it is chronic, like that thing that develops over 24 hours, you have to repeat every 4 hourly, and if you see that the sodium level is consistently, it is low, that indicates that patient has developed a chronic kind of hyponatremia, and you have to go for a slow correction to prevent demyelination of the CNS nerves. So treatment of acute hyponatremia, like if it is 1 liter deficit, you can give 10 milligram of furosemide IV and wait for the diuresis. If it is 1.5 liter with moderate to severe hyponatremia, then one has to go for a hypertonic saline infusion with loop diuretics. And one should be careful to raise the level by 1 to 2 milliequivalent per liter to a maximum of 6 to 12 milliequivalent per liter in the first 24 hours. So it should not be in a hurry, you know, like give so much of hypertonic saline. That can always create more trouble. And 20 milligram furosemide is often sufficient to initiate the diuresis. Again, every 4 hours you have to monitor the sodium level during replacement, and the endpoint should be slightly hyponatremic serum levels, then overcorrection, because overcorrection can result in permanent brain injury. So hypertonic saline, it is available as a different strength, like 2, 3, 5, 7 and 23. So usually in gynec, like we use 3% or 5% hypertonic saline. This 7 and 23 is used mainly for brain injury and other situations. So correction of chronic hyponatremia, it should be a slow correction, around 12 milliequivalent per liter over 24 hours, and it should not be more than 25 milliequivalent per liter in a 48-hour period. So if say your patient has a sodium level of 120, so in over 24 hours your target should be to make it 132, like maximum around 12 to 13, not more than that. So it should be a slow process of correction. Again, this is the old AAGL guideline for procedure cessation when there is fluid overload. So when it's an old guideline, so I'm not going to do that. See, this guideline is replaced by a new guideline in 2013. So if it is elderly patient, I have mentioned comorbid conditions, or if there are compromised cardiovascular situations, then 750 ml is the recommended limit. By that time, you should complete your surgery. If you are using glycine or other hypotonic solution, maximum limit now is 1000. Earlier it was 1500 ml. Then isotonic fluid like normal saline, ringer lactate, etc., you can use up to 2500 ml. Now, the most dangerous complication of hysteroscopy is this air and gas embolism. We have encountered one cases in last 8 years, and the patient died within 8 hours, within 24 hours of the event. So we are not using any more CO2, because CO2, like you know, it creates a lot of bubble during surgery, so it is not used anymore. So gas embolism is rare now. What you have is always air embolism. So air embolism means when the room air enters into the venous circulation. So you can have this problem. So repeated introduction and removal of the hysteroscope, as she has already told, it can create some piston-like effect and then suck in a lot of atmospheric air into the uterus. Then use of pressure pumps without air detectors, the cervical trauma with lacerated veins, then sometimes gas generated during the tissue vaporization, etc. And sometimes you will have this smaller centers, you will have this stuff with the BP valve, and also they will be pumping, and suddenly the fluid will be over, and a lot of gas, like air under pressure, can enter into the circulation. And most of these patients will die within 15 to 20 minutes. So how to detect air embolism? The most important thing is the fall in EtCO2 in the expired air. So if suddenly EtCO2 falls from say 20, 30 to 4, 5, you should be very, very careful. And if the patient is in under spinal anesthesia or epidural anesthesia, or like patient is without any anesthesia, so they will have severe chest pain, dyspnea, oxygen saturation will fall, and then you will have this typical mill-wheel kind of murmur, etc. And if you do a precordial Doppler ultrasound, you will find a lot of air in the cardiac chambers with the cardiac chamber dilatation. And then, but unfortunately, this fall in BP, then tachycardia, etc., they develop a little late, and by the time it is already too late. Anyway, so what to do in the event of an
Dr.
air
Roy,
embolism?
you have to wind up in another
Another 2 minutes, I'll finish it off. So as soon as the EtCO2 drops in the expired air, like you have to close the source of airflow, then immediately terminate the procedure, deflate the uterus and the source of gas. Cervical os can be occluded with a gauze piece, but it may not be very useful. Then immediately ventilate the patient, then give Trendelenburg position, Durant position, etc., to keep the air bubble on the right side of the heart so that it doesn't go into the lungs. And you can use a large catheter through the internal jugular vein to aspirate the gas, and transesophageal USG, if it is available, can be done for visualization of the gas. But these things, like most of the time, it is not available in most of the theaters, and if possible, patient can be transferred to a hyperbaric oxygen chamber. But most of the hospitals, they have these facilities are not available. The most important thing here to remember is that the events of venous embolism is so sudden and catastrophic that they are extremely difficult to manage, and most of the time they will result in either death or disability. So you have to go for prevention. So prevention, like you have to monitor the fluid channels, then stop the procedure before the fluid is finished in the bottle, then avoid putting the patient in Trendelenburg position. So all these things, precaution has to be taken. In false tract is one complication that we can encounter when there is a severely retroverted or anteverted uterus, cervical stenosis, adhesions, etc. So you will not find any endometrium and corneal area when you enter into the false tract. And cervical canal, when the scope enters into the cervical musculature instead of the canal, you can have this kind of picture, and there will be crisscross muscle fibers. So what to do? Like you should immediately stop the procedure, and like a patient can be posted after 2 to 3 months for correction of the false passage. The roof or the floor of the false passage can be cut with 5 French scissors, and continuity can be obtained. So here you can see a false passage, and see, like if it is a very thin one, like if there is only endometrium or 1 or 2 muscle fiber layer is there, then you can cut with a scissor, or you can just dilate it with a grasper, and then you can make the cavity continuous with the cervix. Then another thing is severe bleeding. The severe bleeding is rare in hysteroscopy, but sometimes trauma to the myometrial vessels, either with a cold scissor or thermoactive devices, can cause severe bleeding. It can happen in any surgery. It can be septal resection, myoma resection, and endometrial resection, etc. So when the endomyometrial junction is breached, or there is penetration deep into the myometrium, it can cause bleeding. So if there is bleeding, you have to coagulate with a coagulating loop or a ball electrode. Then if there is still uncontrolled bleeding intraoperative or postoperative, then it will require intrauterine tamponade. So one can put a Foley's catheter with 10 ml of liquid in the balloon, and it can be kept for 24 hours. Most of the time the bleeding will stop with that. You can use also cervical vasopressin, prostaglandin F2 alpha, etc. to control intraoperative bleeding. So these are the complications that we can encounter, and this is how we tackle. So I thank you all for giving me the time, and if there is any question, I'll be happy to answer. Thank you. Thank you.
Thank you, Dr. Sandeep Datta Roy. Is Dr. KK Roy there now for answering the questions? He was supposed to join.
I think we can take up the questions in the chat box since we are already running quite late.
Yeah. So there was one question from Dr. KK Roy that, the speaker, Dr. Shikha, she mentioned that, the obliteration of external loss to prevent air embolization after cervical dilatation. So there's some confusion, regarding that how does it help? So if Dr. Shikha is there. Hello?
Yes, sir. I think they can answer in the chat box, Neeti.
Yeah.
We proceed further because we are running late.
Can I hear the question once more? I'm stuck up in an emergency. Please repeat the question. I'll just answer.
Yeah, Dr. Roy, there was a question in chat box, that Dr. Shikha mentioned that obliteration of external loss can be done after dilatation to prevent air embolism, something like that. So
you see, air embolism usually happens if we are not very careful about the channel, and sometimes even we are doing diagnostic hysteroscopy. What happens that if you are taking out the instrument, putting it in number of times, then if there is any trauma previously because of the tip of the telescope, and if some vessel gets open, then the air can go. So it is not the dilatation of the cervix. Dilatation of the cervix, if it is more, particularly in operative hysteroscopy, then in that case the distension will be less because there will be a lot of fluid will be coming out. So what she meant is that somebody should be, in the job, that they should see that the channel is absolutely free of air, and secondly, frequent removing the telescope and putting it in, there can be chances of air embolism. So it can happen even in diagnostic hysteroscopy. So the patient should be always monitored, and there should be a monitor always, that her IV fluid IV should be there, and the saturation probe should be there, so that we can see any even change, a small change. I think she meant that only, that over dilatation can cause the problem of distension, not the embolism, but the distension. And if the
Okay.
distension is not there, yeah.
Okay. Thank you, sir. Thank you. We move. Thank you to both the speakers. And all the questions can be asked in the chat box and the speakers will answer them. Meanwhile, we move on to the next session.
Thank you, Dr. Neeti. Thank you, Dr. Anupma and Dr. Saboi. And thank you, Dr. Sandeep and Dr. KK Roy and Dr. Shikha. Now we move on to the session 7 and I hand over the floor to Dr. Kanika Jain.
Thank you, Richa. That was indeed a very nice interactive session with the chairpersons and the speakers. I thank them all. And since we are running late on time, and I would request the speakers to please answer the questions in the chat box for any further queries. And so we move on to the session 7 now. And I invite the chairpersons for the session, Dr. Harsha Kulla. She is a senior consultant gynecologist and obstetrician at the Institute of Gynae and Obs, Gangaram Hospital, my teacher and guide. Welcome you, ma'am. And Dr. Sanjeevani Khanna, ma'am is ex-Professor Harding, and she is an advanced gynae laparoscopic surgeon at Fortis Shalimar Bagh, New Delhi. Dr. Lakshmi Mantri, a very dear friend of mine, senior consultant gynae ops at BLK Super Speciality Hospital, Delhi. And Dr. Tarun Das, a budding endoscopic, young and energetic at Sir Gangaram Hospital. So we welcome the chairpersons. And now this session basically is about newer innovations and unique surgeries. So I would like to invite the first speaker, Dr. Suyash Naval. He's a young dynamic laparoscopic surgeon who has basically excelled in vaginal laparoscopic surgery, the V-node surgery, and he would be discussing and explaining to you in detail. He is the director of this V-node Surgical Institute at Jalgaon, Maharashtra. Over to you, Dr. Naval.
Yeah, thank you. Let me share my screen. Thank you so much, Association of Gynec and Obstetrics, Delhi. Thank you so much for that kind introduction, Dr. Kanika ma'am.
Yeah, we can see your screen, Dr. Suyash.
Yeah. So my topic today is to introduce about V-nodes, which is a transvaginal scarless endoscopy. Since no abdominal ports are placed during the entire surgery, it is essentially a scarless procedure. I do not have any conflicts of interest. This is what I also thought when I initially heard about this, but this is not a very absolutely new thing. Nodes has been around since 16 years, and the idea was to explore the possibility of total scarless endoscopy in true sense. And since the goal of minimally invasive surgery is to be least invasive, and we all know that it began with vaginal surgery, we went to laparotomy, then to laparoscopy, multiport surgery, and then to single incision laparoscopic surgery, finally coming back to nodes. So it is completing the full circle. This is how it started. The first nodes was described in animals by Dr. Anthony Kalu in Johns Hopkins University. And it's a matter of pride that the first human study of nodes transgastric appendectomy was published by Dr. Rao and Reddy from Hyderabad in India. And then, of course, many other nodes procedures developed in general surgery, and general surgeons also established the transvaginal access. We were always doing the traditional classic vaginal surgery, but the nodes approach evolution has also started in gynecology in about 2012 from Taiwan under the leadership of Professor Shilong Li and Dr. Suan Su, who described the first V-nodes hysterectomy, and then a significant amount of work has also been done by Dr. Jan Bekeland in Belgium. We started V-nodes on 23rd March 2019, and we have experience of 147 cases since that time. We have been doing V-nodes hysterectomies, ovarian cystectomy, myomectomy, adnexectomy, salpingotomy, salpingectomy, para-ovarian cystectomy. We have done a few moderate endometriosis excisions, and high uterosacral ligament suspension for prolapse. So we can see that by V nodes, it is possible to do an entire spectrum of gynecological surgeries, and the vision that is offered transvaginally through the pouch of Douglas is absolutely overwhelming. We have published our technique of doing V nodes hysterectomy, which according to me makes V nodes hysterectomy even simpler. We use something known as aided by transcervical instrumental uterine manipulation technique, which is atrium technique. And this has been published in Journal of Minimally Invasive Gynecology and also on web search. Now, coming back to the past, since we know that the oldest approach has been the vaginal hysterectomy, and earlier the technique was crude and there were no principles of asepsis, and therefore we moved to laparotomy, and all of us know the history of how the laparoscopy developed, and the first laparoscopic hysterectomy was described by Harry Risch. The vaginal hysterectomy all these years has been in the sidelines, although it always existed in pockets in the hands of experts, but it never got that glory. Although all the evidence, whether you look at ACOG or Cochrane database, every evidence suggests that vaginal surgery is the least invasive and should be the most preferred approach over laparoscopy, at least for hysterectomy. Dr. Shiri Sheth has also said that when vaginal hysterectomy appears possible, but surgeon is in doubt, it is desirable to schedule a hysterectomy as a tentative one or for a trial of vaginal route. So the trial of vaginal route is very important, because today the number of vaginal hysterectomies across the globe is less than 20%, and maximum hysterectomies are performed transabdominally. Why we love laparoscopy so much? What are the benefits of laparoscopy? Laparoscopy brings in a great vision with the modern high definition cameras and the space to operate, and therefore the vision is overwhelming. So therefore it would be a great idea to add the advantages of laparoscopy to vaginal surgery, which is nothing but V nodes. And so in this decade, V nodes has developed, and there has been a review of over 33 studies involving 628 cases of entire spectrum of gynecological surgeries, which concluded that advances in technology have improved at this stage so that the feasibility of V nodes as a treatment option for gynecological surgeries exists today. I'll quickly go to the video of V nodes hysterectomy. This is by atrium technique, that is by using an instrument that we have designed transcervically to manipulate the uterus while performing hysterectomy under V nodes vision. This is a case of simple adenomyosis, not very bulky uterus. Therefore, it would be easy to understand for many of the people who are watching this surgery for the first time. So we give a standard lithotomy position, and under 10 to 15 degree Trendelenburg position, the surgeon and the assistant stand in between the legs of the patient, and the screen is placed near the right shoulder of the patient. Apart from standard laparoscopy instruments, we use something known as a wound retractor or wound protector and a surgical glove to form a glove port for V nodes. Initial steps are same as that of classical vaginal hysterectomy, that is, an anterior colpotomy, a posterior colpotomy is made, and the posterior pouch and the anterior pouch are opened if that is possible easily. So therefore, essentially, this is a vaginally assisted nodes hysterectomy and not a total vaginal nodes hysterectomy. That is something different. So for most of the cases, we do a vaginally assisted nodes hysterectomy, and then the next step is to divide the uterosacrals. We also now take the sutures over the uterosacrals, and then we introduce the wound protector. Now, since there is place to place the wound protector just above the colpotomy, beyond the edges of the vagina, it sits inside the pelvis just below the pubic symphysis, and then a surgical glove is applied over the outer ring of the wound protector, and the wound protector is placed in such a way that the outer ring snugly fits over the perineum, and this retracts and protects the vagina while the surgery is on. Through the fingers of the glove, we place the trocars, we secure them with the suture, and this forms the glove port, and this finishes the leak-proof assembly of V nodes glove port. And then the endoscope is introduced. We use 0 degree 10 millimeter telescope. First thing that you will see is the cervix. The cervix is grasped with the grasper and manipulator, and it is deflected to one side. Initially, generally, we deflect it to the right side, and this exposes the pedicles on the left side. Only two instruments are passed. One is a vessel sealing device, that is, we are using a ligashore over here, which is in the right hand of the surgeon, and in the left hand, there is a grasper which deflects the cervix to the opposite side. And just simple deflection has created a good exposure of the pedicles of the left side. And you can see we have sufficient space to pass these two instruments and the telescope. The mild Trendelenburg automatically retracts the bowel, and you can further confirm the position of the bowel. And the entire surgery will be performed with only these two instruments. The job of the left hand instrument is to create a good exposure so that all the uterine attachments are seen well. Now we are dissecting the uterines over here by dissecting the broad ligament leaves anteriorly as well as posteriorly. So it is always a good idea to skeletonize the uterine vessels to a certain extent whenever you are using a vessel sealing device, so that there would be a good sealing effect. The advantage of V-nodes is that we can see a good length of uterine vessel entering into the uterus, so we can apply the vessel sealer at multiple places, and it is always recommended to apply multiple seals over the uterine vessels. Whenever we achieve this level of skeletonization, we try to place 2 to 3 seals over the uterine before dividing it. So the initial structure that one will see is the uterine vein. This is the uterine vein. Since we know that the uterine vein is a deeper structure, so while going transvaginally, the uterine vein will be the first structure that we will see. And after dividing the uterine vein, many a times you will see a good length of the uterine artery. So now the white structure that appears is the uterine artery. We can see about 2 to 3 centimeter length of the uterine vessel, which can again be sealed at multiple places before dividing it. And the release of broad ligament leaf will further increase the length of the uterine vessel that is available for sealing. After the uterine vessels are divided, this is the point where we will place the uterine grasper through the cervix into the uterus. The grasper goes into the uterus, and this would further manipulate the uterus to the opposite side. This particular kind of manipulation does 3 things. One is it will correct the axis of the uterus. As the pedicles are being divided, the uterus starts rotating, so it will prevent that from happening as the axis of the uterus is corrected. Secondly, it will deflect the uterus to the opposite side, which is an important step in the manipulation. And third, it will allow you to lift the uterus above, so that as we are sealing and dividing the pedicles, there is no harm to any important structures in the pelvis, and the bowel stays below. All the structures stay laterally. The wound protector, the ring of the wound protector, has retracted the bladder upwards, the rectum downwards, and the lateral pelvic wall and the ureters laterally. And the manipulation in this kind has given us clear vision of the uterine attachments, as during hysterectomy, we do not want to see the uterus, we want to see the uterine attachments so that they can be sealed well and divided. So for such size of uteri, we prefer to divide all the pedicles on one side and finish the hysterectomy on one side and then move to opposite side. And salpingectomy will be performed in the end of the surgery. Thus, we can clearly see that all the pedicles are up in the air above, away from the harm's way to any important pelvic structure. And the hysterectomy is completed on the left side. Now at this point, the instrument comes out of the uterus, and again, we deflect the cervix to the opposite side, and the pedicles of the right side are divided in similar fashion, sealing the uterine vessels on the right side now. Dividing the remaining part of the broad ligament. See, the entire exposure is being created by the left hand instrument. There is very minimal role of the assistant in V nodes. The camera person has to just stay in the place. The telescope rests on the posterior vaginal wall. There is very minimal to and fro motion, and there is very minimal left to right motion that the camera person does. The entire exposure is created by the surgeon, and the right hand ligashore does the entire surgery. Again, we will pass the instrument inside the uterus. That gives us excellent manipulation of the uterus and excellent exposure of all the pedicles. And thus, hysterectomy is completed. Meanwhile, we do the salpingectomy very easily by simply grasping the fallopian tubes, pulling them medially, and then dividing by the ligashore. After bilateral salpingectomy is done, the first thing that we like to do is take out the tubes outside into the reservoir of the glove port. And then finally, the uterus comes out. So, and the vagina is closed by the standard fashion transvaginally after we have removed the wound protector and the glove port. So what is the evidence of this kind of V nodes hysterectomy against the gold standard total laparoscopic hysterectomy? Now, there have been several studies that have compared V nodes and TLH, but the best evidence that we have is a randomized control trial, the HALON trial. It is a level 1B evidence, which showed that V nodes had certain advantages over TLH, that is shorter operating times, shorter hospitalizations, there were quicker discharges, the pain scores were lower, the use of analgesics was lower, there were lesser complications, and obviously there were no scars. We have observed in our series certain additional benefits because the requirement of pneumopressure is less compared to laparoscopy. Generally, we operate at the pressure of 10 or very rarely at the pressure of 12. This results in a better pulmonary compliance, and the requirement of head low is also low, and therefore we believe that this results in a faster recovery. So I think the possibilities which natural orifice are tremendous, and we cannot ignore them any further. If someone may ask that what is the benefit of V nodes over the classic vaginal surgery or the classical vaginal hysterectomy, then I would say that the job of the V nodes is not to replace the old vaginal surgery. The classic vaginal surgery has stayed the test of the time, and it is the gold standard approach. only in the cases where we feel that there is difficulty in continuing this vaginal surgery or difficulty in performing salpingectomy or doing adnexectomy. I think the role of V nodes comes in so that we can finish the surgery transvaginally without converting to laparoscopy, especially in cases where there is narrow vagina, the apex is very high, or you want to have an adnexal access for a large adnexa. And the real benefit is the magnification and space that makes the vaginal surgery even easier. So this is how we make the V nodes glove port, and I like the reservoir effect of the glove port, which is useful to store the specimen. There are also these
Nema, please announce to
commercially available pre-made V nodes port, but with the advantage of stable fulcrum, but these will certainly make V nodes procedures more expensive. And this is the instrument that we have designed, which allows you to grasp any size, any kind of uterus, as well as manipulate it. The important thing I want to talk about is the excellent ergonomics for entire team. You can look at the neck angle, the shoulder angle, and the elbow angle of the surgeon. Surgeon is absolutely comfortable in between the patient, the screen, and the target organ, and everything is in line. And the assistants are also not under any strain, unlike laparoscopy or the old vaginal surgery. This is how the wound retractor retracts the bladder, the rectum, and the lateral pelvic wall. And therefore, I think it further helps us to do surgery even in lower pneumopressure. It is important to understand the reverse anatomical orientation for V nodes, which is reverse compared to the laparoscopy. Therefore, the structures on the left side will appear on the right side of the screen. The left ovary appears on the right part of the screen. That is something to orient, and which comes very quickly once we start doing V nodes procedures. And here again, you can see the right-sided pelvic structures on the left part of the screen. And we can very clearly see the lateral pelvic wall, which is not commonly seen during vaginal surgery. We can clearly see the external iliac vessels, the ureter, and the internal iliac vessels. In cases of difficult hysterectomies, large uteri, or the adherent bladder, we can very well utilize the lateral window dissection as described by Dr. Shiri Sheth and continue that dissection under V nodes vision. As you can see in this case, the lateral window dissection has been completed and opened transperitoneally, and we have isolated the bladder adhesion. This allows us to target the adhesion and complete the surgery under V nodes vision. No matter what is the size of the uterus, we can go ahead and finish vaginally with the help of V nodes. This is the largest size of the uterus that we have removed. It weighed about 2.5 kg. It made to the record books. We have challenged many contraindications of vaginal surgery. This is a case with the ventrofixed uterus, and the V nodes vision has allowed us to do this adhesiolysis safely and completely under vision. This is a case of ovarian cystectomy. I am just showing this surgery to give an idea about how an adnexal surgery can be performed by V nodes. This is an exophytic ovarian cyst. We can see the right adnexa. The difference between the hysterectomy and the adnexal surgery is that the colpotomy is made only posterior to the cervix, only posterior colpotomy is made, and a smaller size wound protector has been placed inside, and the same assembly of V nodes glove port has been placed, which has given us this vision. And since this cyst has grown into the mesosalpinx, the dissection is similar to a paraovarian cystectomy. The mesosalpinx is being opened here. You can see there are only two instruments inside. One is a bipolar and a scissor. The triangulation that we are getting by V nodes is very good. It is almost as good as ipsilateral port laparoscopy, I would say, and it is much better than the single port laparoscopy. If somebody is doing single port laparoscopy, then you may realize that the triangulation is much better, and the standard steps of ovarian cystectomy are being performed. So in the learning curve of the V nodes, I think the V nodes vaginally assisted node cystectomy is the easiest case to begin with, then the adnexectomy, and then the adnexal cystectomies.
Dr.
And probably
Suyash.
the most difficult one would be
there is a little announcement that I need to make on behalf of the organizers, that the next talk will be Dr. Shailesh Puntambekars, as he has to go to the operation theatre. So once you conclude, Dr. Shailesh will take over.
Yeah. Sure, ma'am. And we can endobag the specimen and the cyst comes out transvaginally. So what are the benefits of V nodes? I think it is essentially a scarless endoscopic surgery. It is least invasive. It utilizes the preferred vaginal route. There is less pain, quicker recovery, and it is possible to do daycare surgery with V nodes, and almost all benign gynecological surgeries are possible by V nodes. It is very important to understand the contraindications. Currently, these are the malignancies, endometriosis, obliterated POD, history of rectal surgery, pelvic abscess should not be attempted by V nodes. Talking about limitations, space and triangulation is something which is a relative limitation, which I think which you can resolve with practice and experience. Complication management can be an issue by V nodes and may require conversion. At this point of time, training is the most important aspect since it is a young technique. International Node Society has made effort to make structured training programs and has also established a global complication database for further research. What is the place of V nodes today? I think today, for the easiest of those hysterectomies, vaginal surgery is the way to go. As the complexity of the case increases, and if the surgeon is trained in V nodes, then we can still continue by V nodes and finish the surgery transvaginally, just thus utilizing the preferred route, and only for very complex and severe cases, maybe in future only laparoscopy would be required at that point of time. The future is developing in V nodes. Robotic surgery is also developing in this direction. Single port Da Vinci may be utilized for V node surgeries, and also certain robots are being developed specifically for V nodes procedures. So in conclusion, V nodes is a new advanced approach in minimally invasive gynecological surgery. It is a true scarless surgery, and it has the potential to increase the vaginal surgeries. I think this is the most important aspect, and it may become a most preferred approach in benign gynecology.
Thank you
And
so
I think
much,
as
Dr.
far as
Naval.
from the patient's perspective, for women, I think it is nothing less than a gift if you can offer a scarless surgery. I am very happy to tell you that we have established V Nodes Academy of India that offers International Node Society recognized training courses in V Nodes. And thank you so much, Association of Gynec and Obstetricians Delhi. Thank you so much, Kanika, madam, for giving me this opportunity. Thank you.
Thank you so much, Dr. Naval. It was an excellent presentation. It was truly a scarless surgery, and almost you have highlighted very well. The video was very good.
Thank you.
There is a question in the chat box. What is the name of that wound protractor in the market?
Yeah, wound protector. It is called wound protector or wound retractor. I think there are a couple of companies that provide it. You can get it from Applied or you can get it from Medtronic.
Okay. Is there any history of dyspareunia after the ovarian cystectomy?
No. Dyspareunia, this has been studied extensively by general surgeons who did notes for a very long time. And we all do transvaginal surgery. I mean, vaginal surgeries, whether it is ovarian cystectomy or hysterectomy, the dyspareunia is not there. It is not significant at all.
Okay.
Dr.
So
Lakshmi,
almost all types,
we can take up the questions at the end of the
right.
session. Dr. Puntambekar has to wash up for a
Okay.
We'll start with this session. So I would invite, sir is probably traveling in his car, and I would invite Dr. Puntambekar, who would be starting the talk. The complications in laparoscopic surgery, we learn from the expert. And actually, this expert doesn't need any introduction. He's known not just pan-India, but all over the world. He's in the Guinness Book of World Records. And he's the surgeon who's done the first successful laparoscopic assisted uterine transplant with the delivery of a live baby girl. So over to you, sir. Without much wasting time, I would hand over to you.
Thank you very much, Dr. Kanika. And I will now share my presentation. So I will optimize and then share my presentation. So, 1 minute. Yeah, can you see my slides? Hello?
We can see, sir. We can see.
Yeah. So thank you very much, the Association of Gynecologists from Delhi. It's always a pleasure to be with you. I'm sorry to push my talk earlier because I have to travel to one of the hospitals for a emergency surgery. So these are the complications in laparoscopic surgery. We all know that complications in surgery are mainly because of lack of knowledge of anatomy and lack of applications of proper ergonomics of instrumentation. And finally, sometimes it is beyond our control. We all know the predisposing factors. Majority of them are previous laparoscopy, previous pelvic surgery, endometriosis, inflammatory disease, anatomical anomalies. And complications are classified according to the Dindo classification as early and late. The commonest complication that I have seen is a bowel injury, and this can be to the small bowel, large bowel, or rectum. So you can see that this was a patient who was operated 3-4 times, and there the first trocar was put very carelessly without doing a pneumoperitorium, a direct entry, and you can see a colonoscopy being done with the trocar. So it is the commonest injury which can take place, and that is what we have to take care of this. So this is the commonest injury that can be seen, and you can see that this is the bowel injury. This is a rectal injury. So you can see that, well, we were doing a hysterectomy, and when we were doing hysterectomy, what happened was there was a stool which came out as the uterus was being removed, and as the uterus was being removed, there was a perforation which was seen, which could be easily diagnosed and of course closed. It was a small perforation caused by the assistance instrumentation, and that is what caused the problem. Injury to the small bowel, very commonly seen. This was an injury which was done in spite of using an optical trocar. One of my residents entered into the bowel. We kept the trocar there, and we went from the other side and then traced the trocar which was going there, and you can see that the optical trocar is right into the small intestine. So in spite of using an optical trocar, it doesn't guarantee anything. You can see that it had perforated because the intestine was very, very closely associated with that. Large bowel injuries are very common. They are usually be seen in endometriosis, and this is a case of a rectal injury which was because of the drain. So one of the gynecologists had done an endometriotic surgery and closed the rectum when there was a small perforation, and they put a drain. And on the 4th day, there was a lot of stools which came through the drain. So we went in laparoscopically, and what we saw was really a disaster. The drain had gone through the perforation, through the sutured area of the rectum, and it had gone inside. So this was a fertility preservation surgery which was done. Unfortunately, the drain had perforated through the injury which was done. Naturally, for this patient, we resutured the thing, but we covered the patient with the ileostomy. And this was another injury which we saw when another one of my close surgical friends was trying to do something in the pelvis, which was a large mass, and in the process there was a damage to the rectum. I was assisting him, but I could see that there was a large perforation. So what do you do in these circumstances? Of course you will do covering ileostomy, but you will not forget to close this perforation. Now this was an extensive perforation. It would have required a complete resection of the rectum. Instead of that, I put a drain from the rectum, and over the drain we sutured the rectum. So over the drain we sutured the rectum, but again this was a very large perforation. Always cover large perforations with a covering colostomy or ileostomy. Now directly under vision, if there is a foul spring coming through the for you to identify that something is going wrong. The second thing is submerge the bowel under the irrigation. Very good and very nicely seen. Bowel safety, it should be done with parking of the bowel, not using traumatic instrument, and of course sometimes while doing adhesiolisis, prevent inadvertent devascularization. So you do this with remaining above the fat. Whenever there is a rectum which is attached to it, do the dissection with the idea of fat belongs to the rectum. What about the vascular injuries? Multiple vascular injuries have been encountered in my endeavor to reach the top. And some of the injuries that I would like to show you. This is a case of an anterior exentration post-radiation, post-chemotherapy. And this patient was taken up. So you can see that everything was stuck. Now we are trying to identify the internal iliac artery because the internal iliac artery needs to be ligated in an anterior exentration. Very old video. We are using the wrong instrument. Instead of using a Maryland, I am using overconfidently time inside what happens. This is the internal iliac artery I wanted to tie when I could have easily iliac artery got torn. So this was a disaster. Now, whenever there is such kind of bleeding, then you can see that you need to suck the entire area. And at that time, what you want to suck normally doesn't get sucked. It only sucks what you don't want to suck. And this is what exactly was happening. You can see what was happening. Fortunately, I knew at what level the ureter was and at what level the internal iliac artery was. Kudos to our anesthetist who allowed us to do this. So, who allowed us to do this. We used the water. And in a moment, this is an unedited film. You will see that in a moment, with my left hand, I could see and catch the internal iliac artery. So with this, we could catch the internal iliac artery, and you can see the large ligature, which is the atlas, which was used way back 10-year-old. This I used it, and I could clamp the internal iliac artery with the ligature. Now, once we clamp this, you can see we could control the bleeding with this. And after we controlled the bleeding, what was most important, you will see at the end of this, that once we have controlled the bleeding, then once bitten, twice shy, then you try and apply a lot of clips. So we applied a lot of clips. The bleeding was already controlled. But the most interesting thing was the vicryl thread, which had gone underneath, was already there. All I needed was to lift it up, but the presence of mind was not there whenever there is a bleeding taking place. This is the problem. Huge panic reaction. For the purpose of sanity, I have edited the sound of the inside the operation theater with all the galis that you can all remember, which were given to the technician and the assistant for doing it wrong. The surgeon is never wrong, you know that. And therefore, we put a lot of clips there, and you can see it was like a titanium poisoning at the end of the day. Then every bleeding need not be controlled. You can see that there was the nodal dissection, which I was doing. And when we were doing a nodal dissection, suddenly there was spurting of the bleeder. Now, these bleeders are very, very small. Don't have to immediately go in and try to control the bleeding. Just use a piece of gauze there. Once you use a piece of gauze there, and once you do this packing, you can continue with the dissection. When you continue with the dissection, you can see by the time you come out, the entire bleeding has already stopped. So this is very important, that every bleeding need not be stopped. But when we have a bleeding like this was again a post-radiated patient where we were trying to do exentration. These are my early days till I reached the expertise to do these very carefully. These are my early days, and there was a tear in the external iliac vein. Now, a tear in an external iliac vein is a disaster. So in the advent of having the barb sutures, the art of suturing is being lost. But remember, if you are doing advanced surgery and there is a vascular injury, there is nothing that you can do but to use a suture. We use a 4-0-proline suture, and we could control the entire bleeding. So this is something which we could easily control and take care of that. It is a simple way of controlling this, and this was completely controlled using the 4-0-proline, and the bleeding stopped completely. So whenever you have a major vessel bleeding, invariably the important thing is there may be a carbon dioxide narcosis, or you may get a carbon dioxide aneurysm. So you have to be very careful. We could control the bleeding very easily. And then we had a very disastrous bleeding when we were doing an exentration. Again, you can see that there is a huge bleeding coming from below the obturator nerve. It was a large internal iliac vein tear. Now, whenever there is an internal iliac vein tear, it is our ego which comes in the way, that I can control the bleeding. But remember that when you do any kind of such major venous injury, there is a chance of CO2 being absorbed. So immediately, what you would have done in an open surgery, try to do the same in laparoscopic surgery. We packed the entire internal iliac vein with at least 4 or 5 strips of gauze. And once we packed this, the bleeding stopped. What is important now is to restore the anatomy around it. And once it was restored, after 5 minutes, the bleeding was seen in a little bit better way, controllable, and then we could take a stitch and control it. But had I continued with the dissection, so a little amount of bipolar, and then taking a stitch along, we took a stitch of 2O Vicryl, and we went underneath the internal iliac vein, and we could control the bleeding. Just simple packing, and you can see that there is a stitch that we took, and that was the end of the story when we did this. So these kind of bleeding are major bleeding. You try to duplicate whatever you would like to do in open surgery. This is how you can control the bleeding. But not every time you can control the bleeding. This was a para-aortic dissection which I was doing, and I damaged the left renal vein. And in the process of trying to catch the renal vein, we further damaged it and further damaged it. So you can see, I thought that we would be able to take care of the bleeding. This is being recorded, and then you can see as we are trying to control the bleeding and trying to take out, we thought that we had controlled the bleeding, and you will see what happens. Suddenly there was a gush of blood. We had to, of course, open the patient. We could salvage the patient, but even then, sometimes there is a delay. So here in this patient, you can see there was a delay of at least a minute before sanity evolved and ego was overridden with a correct thought of opening the patient. And this is what we did finally. How to tackle the venous bleeding? You should know that the plane of dissection should be always right. There is a long length of internal iliac artery. And of course, you should also be aware that below the obturator nerve lies the obturator vein, and there is what we call it as the corona mortis area. Now, this was another thing. We did a para-aortic dissection, and as we were doing a para-aortic dissection, you can see that there is a bleeding which is taking place. And when the bleeding, we applied a clip because there was a bleeding. And then when we realized and we took out the large node out of the aorta, we realized that we had clipped the renal artery. You can see the renal vein. You can see the two ends of the renal artery, and the middle part of the renal artery was clamped. In the process to take out the node, which was very large, now the important thing is in this patient is likely to lose the kidney, but fortunately we realized it immediately and we took out the clip. There is a clip remover for these plastic clip which is available, which we have, and we took out the clip. You can see, and then both the arterial ends were then anastomosed with a 5-O proline. Now, this we were just plain simple lucky that day that the time between the application of the clip and doing this suturing was less than 10 minutes, and therefore we could immediately understand, and there was no thrombus formed over there, and the kidney was salvaged. So these are some of the injuries. Of course, bladder injuries, very, very common. You can see a lot of bladder injuries can take place. We all know how to identify the bladder injuries, and therefore whenever there is, now this is a patient, we do not know where the bladder perforation is, and this patient, after doing a radical hysterectomy, we have this checklist. So we fill up the bladder in every patient, even if I do the surgery, and you could see that there was a small leak from there. This would have led to a little amount of urine leakage and sepsis, and therefore we sutured it. It's a fairly simple way of suturing it, but identification of the injury is more important. Now, in this patient, we were doing a radical hysterectomy. We are going near the ureteric tunnel. You can see the ureter over here. And as we are dissecting near the ureteric tunnel, I am now using a Maryland forceps again because this was a little bit adherent. And as we were dissecting that and dissecting and lateralizing the ureter, in a sudden moment, our anesthetist noticed that there was a little gas in the urobag. And at this point of time, even we didn't think there is anything wrong. But then we tried to mobilize and we realized that there was a small hole in the bladder over here. So you see that it very, very important was to identify the injury. This would have gone unnoticed. Of course, suturing this is very, very easy later on. Injury to the ureter, which is the most common thing we all know. We have all encountered this. Majority of them are it is because of the avascular necrosis of the bladder, of the ureter, and the injury amounts to only 2.5%, but unfortunately it gets magnified because everybody sees it, and therefore whenever there is a ureteric injury in a laparoscopic surgery, it is actually exaggerated. So it can be transection, angulation, or ischemia. When to operate? If the detection of the injury is within 5 days, immediately operate. If later, then you can take the use of your urologist, or you can do it, or you can do a DGS stenting or PCN. So the management depends on the type of detection, extent of injury, and site of injury. Various techniques are there: injury without the loss of the length, injury with the loss of the length, and injury with significant loss of the length. So here you can see this was a patient of total laparoscopic hysterectomy, a large fibroid done by one of my friends. And you can see when they were doing this, this is what happened at this point of time when they were taking the last clamp. There's something which looked like a lumen. You can see this is looking like a lumen over here appeared. Everybody thought that it is a vessel, but you can see a star-shaped lumen, and the ureter was completely Now, when we try to look, majority of the time, what do? We try to look at the brim, and we could identify the ureter very well. You can see that the ureter is here, and the ureter looked very, very well, and it was having a nice peristalsis. So you can see the ureter very well. So everybody said, no, 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 there is no problem with the ureter. It looks good. There is good peristalsis. But then when we thought that it is a star-shaped lumen, we continued to do the dissection. Still, the ureter is looking good. And then when we were trying to go in the tunnel, I opened the tunnel, and then you will see that once we opened the tunnel, then there we realized that the ureter had gone, and this is the area where the ureteric injury had taken place. So it had taken place very, very close to the bladder, but the identification was very important. You can see that this is the same ureter which is carrying ahead, and this ureter we could then re-implant into the bladder. But what was important is we traced the ureter, we did not leave it. You can see now the injury. This is where the injury has taken place, and there you can see the urine coming out. So this is important to trace the ureter, not really only see at the level. If you have any suspicion, do not leave the patient till you are satisfied, and then you will find that it is easy. Injury with a primary repair, if there is a small injury, you can see that it can be easily done. There is a small injury in the ureter, and here what we did was we did a cystoscopy. With a cystoscopy, we passed a guide wire, and over the guide wire, so this is just stent that we pass, and then after that it is a fairly easy suturing. We sutured it with a 4O vehicle. So this is what we did, and this is what was important. This could be easily done. So these are important things, but sometimes you have to implant the ureter. In this case, you can see that this is a completed radical hysterectomy, and we thought everything is good, but the stent was not going correctly, and as it is, because it looked a little avascular at that point, we realized that there is an injury which has taken place. You can see that. Once there is an injury, then you get the bladder down, which is very simple, like going in the cave of Radzius, what you do for birch repair. Once you do that, then you take the bladder down and then suture the bladder to the muscle. This is important so that there is no tension on the anastomosis, and then you fill up the bladder with the water. Once you fill up the bladder with the water, make a hole inside the bladder. So this is the bladder which is filled up, and with this you can make a hole inside the bladder. Once you make a hole inside the bladder, the water will start flowing, and the ureter then can be easily completely anastomosed to the fundus. This is called as a Gleroy-Rich method. Very, very simple. I have taught a lot of gynecologists, and 5 or 6 of my gynecological friends now are able to do this procedure. It's a fairly simple procedure. It's like a tubal anastomosis, but with the water there, you can see it can be done. The important thing is the medico-legal aspect. You can ask your urologist to be there, but urologists will come and open the patient. So if you learn these techniques, it is very good. And this was another patient where we could see an endometriosis operated 6 times. 6 times the patient was operated. We could not identify the ureter. It was stuck to the infundibulopelvic ligament. And when we were realizing that it is stuck to the infundibulopelvic ligament, as we were dissecting it, we realized that the infundibulopelvic ligament did not exist. It was actually the ureter which was there. This was the ureter which we damaged, and then we implanted it in the same manner. Now, Ureteric reimplantation is usually done when there is a ureteric fistula which is diagnosed later on, where the patient presents with a ureterovaginal fistula. You can see that there is a ragginess on cystoscopy. The stent cannot go because there is avascular necrosis. Then you go in laparoscopically, you find that there is a ureteric fistula over there. This ureter cannot be anastomosed after the 7 or 8 days. It is completely avascular. So you take the ureter away, you completely dissect it away. Then the same way, you can take a small stitch on the tip of the ureter, and then you mobilize the bladder in the similar way in the cave of Retzius. Once you mobilize the bladder in the cave of Retzius, take a stitch to the psoas muscle, the bladder lies there, and then you open the bladder, take 2 sutures on the end of the bladder, and then you can open the bladder, and through this you find out whether the ureter is fine by putting this, and then you can do a submucosal tunneling and implant the bladder, implant the ureter. So these are the various techniques. These are very advanced techniques that you have to learn. But what is more important is to understand that these complications are known to everybody. The important thing is to identify the complications. So preventive strategies to reduce the risk of ureteric injuries is to have a complete idea about the ureter, and in case you are difficulty, start your dissection at the level of the sacral promontory. Intraoperatively, adequate exposure, avoid blind clamping. We all know this, but the important take-home message is, if you see that the ureter is not dissected well, do the stenting in the post-operative period. Do not leave it to God. That is the most important thing. I always say, ureteric stenting not required pre-operatively, but in a bad case, you know how bad it is. You can do it at the later part. And last, I'm showing you is the only time that we have had a lot of lymphocyl after a radical hysterectomy. We do not keep the drains, but we can see that there was a huge amount of lymph which was collected. We had to go in again on the 7th day, and there was a lymphocyl which was formed. So there was a lot of lymphoria, and this could be easily taken care by just doing a re-laparoscopy in these patients. So, ladies and gentlemen, accidents can happen to the best. It is not necessary to think that you are God. Nobody is God. Only person who says that I don't have complications who is not operating. It is like a ship remaining in the harbor, no damage done. But well, accidents can happen. What is the most important thing is to identify them and correct them and take care. Of course, last word, which I always say, it's all about anatomy and nothing else but anatomy. If you know the anatomy correct, if you know how to dissect the anatomy correctly, 9 out of 10 times you will be fine, even if there is a complication, because you know what exactly you are doing. Never do the procedure blindly. So thank you very much. Thank you, Kanika madam, for an opportunity to give a talk to you. I'm always associated with the AOGD, and thank you very much again.
Thank you, sir. It was
Thank you.
Excellent.
Thank you, Dr. Puntambekar. With your experience, which is quite unparalleled, you have told us everything about complications and shared the videos which are so important for us from your personal as well as handled cases. So I don't know if you have time, we can just...
yeah, surely. I have.
Yeah.
I have.
So, like, these are, of course, worst kind of complications that you have shown us. But would you like to tell us something about nerve injuries or any other things that if we are careless, we might face?
Yeah, the majority of the times we are finding the nerve injuries, which are very common. And this happens in the process of trying to find the nerves without the anatomical knowledge. And these patients invariably land up into, and I have seen at least 4 or 5 obturator nerve injuries, which are the worst injuries you can ever have. I have seen the obturator nerve getting, so one nerve you can afford to damage is hypogastric nerve. The bladder will recover itself. But one nerve you cannot afford to damage is an obturator nerve. The obturator nerve damage is something, there is an adductor weakness, and I have seen this happening. It is also very difficult complication. The second complication that I have seen is a blind application of the bipolar energy source to the infundibulopelvic ligament, carrying it right onto the external iliac. So whenever you want to do anything, we always say that take the organ in the air, take the organ in the air, take it towards the God. Don't use the energy source when it is close to the body. Take it away. And these are the things which you should be very, very careful about.
And one more thing, normally we discharge our TLH and other cases on the second day or the third day post surgery. So then we call them only on the 7th or 8th day. So in the meanwhile, we should caution them about some symptoms, because we know that many bowel injuries may manifest on the 4th day or the 5th day. So what do you suggest? How should we catch those undiagnosed injuries?
Madam, it's an excellent question, because this is something which I tell my residents, and I always tell them that if you do not expect what you are expecting after 48 hours, that means something is going wrong. If you are expecting, you have a clear idea in a TLS, the patient should not have pain, the patient should do all the activities, the patient should not have problem with burning, micturition, passing stools. Any complaint of the patient after 48 hours to be taken with full cognizance, with all antennas up, because you know that things are not going to happen. In a routine TLS, this is not happening. So everything is surgically related unless proved otherwise. People refer the patients to ECG, get an ECG done, there is a pain in abdomen, they refer for sonography. First important thing, think something has gone wrong. So you should take a cognizance of symptoms if the patient tells you, and you need to counsel. Bowel injuries are the worst injuries because they can lead to peritonitis. Bowel and bladder and ureteric injuries, you can salvage the patient. So we have had a lot of times I had to go at 2-3 places, and it's not that only my colleagues have done. Sir, complications which I showed you today are completely mine. I own the complications, because you cannot say that you have not done complication. That is the message I wanted to give. But if I have done a mistake, let not the other do the mistake. Therefore, this talk, so that they can use the knowledge to do good surgery and avoid the same problem that I faced. So correct choice of patient, correct anatomical knowledge of the patient, and correct continuous sixth sense and high antennas in every patient that you operate, it is very important, and you will never miss a complication.
And you have to listen to the patient. Listen to the patient.
Yes, you have to listen to the patient. You have to listen to the patient, no doubt.
Thank you so much. I'm sure there are innumerable questions and thoughts coming to the mind, but I think we will free you now. And thank you for your.
Thank you, Sanjini madam. It's nice to see you after a long time.
And your presentation and every answer you have, everything that you sense from our point of view is so precious for us. Thank you so much, Dr. Shailesh.
Thank you. Bye-bye. Thank you so much.
Bye-bye. Thank you. Over to Dr. Kanika.
Yeah. Thank you, Dr. Puntambika. That was indeed very nice. In fact, it needs some courage and boldness to be able to share your mistakes with others, so that the others can learn from your mistakes. That's very bold. So I would now carry on with the session, and we would invite Dr. Chatterjee, Dr. Abhinivesh Chatterjee. He would be telling us about the various techniques of laparoscopic vaginoplasty. He is from Calcutta, a senior consultant, gynae, endoscopic and laparoscopic surgeon. And over to you, Dr. Abhinivesh.
Yeah. Good evening, ma'am. And thank you for the opportunity. And thanks to Association of Obstetrics and Gynecologists of Delhi. I will be presenting on various techniques of neovaginal creation. One sec.
बीच में इसका तो वो हो गया
Sir, you can stop
मैं
share,
जब
sir,
तक
and we'll
चार्जर
start
लाके
again.
लगाई तब तक ये बंद बूंदी हो गया अब मैंने फोन पे ही कर लिया फिर तो अब मैं दोबारा
Some message is coming.
Open your presentation first, sir.
Can you see? Hello?
Please continue, sir.
Yeah. Laparoscopic creation of neovagina, different techniques. Now, causes of vaginal aplasia is commonly due to Mayer-Rokitansky-Kuster-Hauser syndrome. The incidence is 1 in 5,000 female neonates, caused by inhibition malformation of the Mullerian duct, absent upper two-thirds of the vagina and rudimentary uterus. Primary amenorrhea is the first indication. Neovagina created if the woman wants to have intercourse. Rokitansky syndrome in 38% have malformations of the kidney and the urinary tract. In 20%, it has malformation of the skeletal system. Now, methods of laparoscopic neovagina we will be discussing is modified Vecheti, where olive and traction suture technique is used. Wharton, shears and peritoneal pouch technique, modified Davidoff's technique, and neovagina creation in lower third vaginal agenesis. Now, operative technique of the modified Vecheti. Operative principle is stretching the vesicorectal space intra-abdominally via olive connected to two threads which are taken out subperitoneally, which are fixed to a traction device, and neovagina is formed by traction in a matter of 7 to 10 days. Now, neovagina instrument sets, this is of Karl Stodge, which has the traction device and different thread guides. In the modified techniques, we use common instrument like port closure needle, number 2 ethibond suture, 3 centimeter diameter polymer olive, 3 mm ports, 5 mm port, 3 mm Maryland, 5 mm needle holder and scissors, and simple rubber catheter and mosquito forceps for applying the pressure dressing. So this is the modified laparoscopic neovagina creation with Vecheti method. You need an olive medicated polymer device with 3 centimeter diameter, ethibond number 2, port closure needles. The port closure needles introduces one end of the ethibond into the potential space between the rectum and the bladder, and the other end is also introduced. Then use 3 mm ports and 3 mm instruments to get this thread, which is inside the peritoneum, subperitoneal, and take it out through the skin where you have made the incision for the ports. Then use mosquito forceps to apply traction and shorten the string. This way, the potential space will be developed every day 1 centimeter by shortening of the threads, and traction device is used. You can see after 7-10 days, good 7 centimeter, 8 centimeter neovagina has been created. Results are good. Now coming to the remnants of the Mullerian ducts are always there, which is 1.5 centimeter dorsal and lateral to the urethral meatus. Start dilating these ducts with Hegar's number 2 to number 14 using lot of jelly for lubrication, and dilatation should be in the axis of the pelvis. Dilate both ducts simultaneously, and through the laparoscope see whether you are in the potential space between the bladder and the rectum. That is also very important. So once you have dilated with Hegar's 14, then you are left with 2 cylinders and a ridge in between. Cut the ridge with diathermy pencil such that you unify the 2 cylinders and make the potential neovagina. Then use a sim speculum and an anterior wall retractor to push the bladder up and the rectum down to mobilize the peritoneum there. Once the peritoneum is mobilized, catch hold with long artery forceps with the help of your light reflex, and then cut with scissors. Once you cut, you will see pneumo gushing out. So catch hold of the peritoneum and pull it towards the introitus and take stitches with Vicryl at 12 o'clock, 6 o'clock, 9 o'clock and 3 o'clock positions. So there is the direct communication of the peritoneal cavity with the newly formed introitus is created. So just give couple of more reinforcement stitches as well if needed, and then plug this with betadine gauze such that the pneumo does not leak. Now, with PDS or ethibond or proline, use a purse string stitch which should be near the ovary, taking the peritoneum, the serosa of the bowel, and also the remnant of the Mullerian ducts as well for reinforcement. So there will be the newly created introitus will be elongated with this peritoneal pouch, such that whilst you do ovum pickup, then the transvaginal probe will be near the ovary. You see, we are just tying the purse string stitch and ensure it is totally watertight or airtight. If air is leaking, you need to reinforce that area with a couple of more purse string stitches, as we are doing here. We are taking the serosa of the bowel and just reinforcing the area from where bit of pneumo was leaking. Otherwise, the omentum or bowel will herniate through that potential space. So it is very important to make it airtight. So once this is done, the patient needs to wear mold. That is very important. Initially day and night for first couple of months, then only during night till she is sexually active. The success of any neovagina depends on wearing mold. It's a good space being created. Now coming to the next method, it is the modified Davidoff's technique of creation of neovagina. You hold the rectosigmoid and dissect it down with harmonic scalpel. Then use harmonic scalpel to dissect the peritoneum from the bladder. Mobilize the peritoneum as much as you can and push the bladder down. Dissect the remnants of the Mullerian duct as well. The whole idea of this peritoneal mobilization is to ensure the anterior wall of the neovagina is tension free. So you ensure it is quite tension free because this will form the anterior wall of the neovagina. The remnants of the Mullerian duct gives lot of reinforcement to this neovagina. Now your assistant holds the sponge-on holder and pushes on the created neovagina by Hager's dilator or the vaginal pouch, and you incise with harmonic scalpel and see that 2 fingers come in very easily. That is very important. And then use PDS stitches to form the anterior wall of the neovagina from the mobilized peritoneum which you have already mobilized. You can also use non-absorbable material like proline or ethibond in these stitches, but delayed absorbable PDS gives good results. So you can see the anterior wall is well formed with this peritoneum and the remnant of the Mullerian duct. So once this is stitched up, then you use a purse-string stitch, taking the peritoneum of the lateral pelvic wall, the serosa of the rectum, and also the peritoneum of the left lateral pelvic wall. Ensure you have completely covered it up such that there is no leak of pneumoperitoneum. This is very important, otherwise bowel or omental contents may herniate out. Once the pursing is done, you ensure the ovaries should be at the side because that is very important for ovum pickup during IVF. Now you go vaginally and you will find a good neovagina being created, but the success of all neovagina depends on wearing mold initially day and night for 2 to 3 months, then at least during the night time. Next is neovagina creation of vaginal agenesis. This is a case of lower third of vaginal atresia which we are planning to do laparoscopically. First, we go in and then establish the anatomy of the pelvis. Then the lateral pelvic wall is open between the round ligament and IP ligament. The external iliac vein and the ureters are traced, and the internal iliac artery is dissected carefully. You can see the ureter, and LT400 clip has been applied at the internal iliac artery. Again, the bowel is dissected down and the lateral pelvic wall open. Again, dissection between the ureter and the external iliac vein, and the internal iliac artery is temporarily clipped on the left side as well with LT400. Now the bladder is dissected down to open up the vesico-vaginal space. Dilute vasopressin is injected in the anterior wall of the vagina, which is then incised with harmonic scalpel, and you can appreciate mucocolpus being drained. Dilute vasopressin is then injected vaginally at the atretic vaginal cylinder or thick transverse septum from the introitus. A gauge on a sponge and holder is held by the vaginal assistant who pushes the introitus from below. Using the harmonic scalpel again, we incise the thick atretic vagina under vision until the gauge piece is reached. You can appreciate the gauge piece has been reached, and then the flaps of the vagina is refashioned such that it can be pulled down to form the vagina, where we will be using vaginal stitches. Usually, assistant holds the flap laparoscopically, and then you go vaginally and hold it with long artery, one on the right side and one on the left side. You can appreciate. Then you give vicryl stitches between 4 and 5 o'clock, and again 7 and 8 o'clock positions, and couple of more stitches such that the flap is anchored in the right and left side properly. Usually, you then prepare a plastic mold with the help of a 10 ml disposable syringe by cutting off the upper portion of the syringe, and usually using 11 scalpel blade to cut it off. You then use this mold, insert it through the newly created introitus, and over which you can see the plastic syringe 10 ml which has been pushed inside inside the vagina, and the anterior wall of the vagina which we had incised with harmonic scalpel is been now stitched up with vicryl continuous stitches. So you can also use interrupted stitches here or barb stitches as well, but we are comfortable using the routine vicryl which we normally use. So this is a relatively easy procedure, and everything done under vision. The only issue, once you are done with the surgery, we open up the LT400 clips on the internal iliac arteries. First, it was the right one which was opened. Now we are opening up the left one gently with using Maryland forceps. So after this, you can give a drain and come out. The 5 to 10 ml disposable syringe mold needs to be worn for next 3 months to keep the patency of the tract which has been created. And the results of this surgery is excellent, and patient can be discharged 1 or 2 days post-surgery as well. You can appreciate how well the vagina has been formed. Fertility outcome, genetic pregnancy possible with the help of surrogate mother.
Dr. Chatterjee, 2 minutes, please. 2 minutes left.
I'm almost
Thank you.
finished.
Thank you. Thank you.
Ovum pickup through transvaginal sonography via neovagina. Congenital malformations of the lower genital tract are not commonly transmitted as dominant genetic trait to this offspring. So these are a few poster and presentations which has been done. And thank you very much for the opportunity. Any questions is more than welcome.
Thank you so much, sir, for the wonderful session. We have seen so many good videos of the different techniques. Likely, we will get back to some questions from the chat box. I think after the session get over, we'll get back to you with some good questions.
Okay, thank you very much.
I think, Dr. Tarun, there was a message from the organizers that I think we are already running late. So I think the questions can be answered in the chat box only. That will be much better. Because I think the questions can be written in the chat box, and I think that can be answered in the chat box.
Sure. Thank you very much.
Okay.
Right.
Thank you so much.
Thank you. Thank
The
you.
lectures are so good. They really video sessions are very nice, and we would like to go on and on, but we are hard pressed on time and we're running late. And there are speakers from Atlanta, US also waiting, so we'll have to speed up. So thank you, ma'am. I would next invite the next speaker of the day, none other than Dr. Dinesh Kansal. She is the head of department and a senior consultant at B.L. Kapoor Super Specialty Hospital in Gynae Ops, and a very excellent endoscopic surgeon. So without much ado, I would hand over to Dr. Kansal. She would be talking about the laparoscopic sentinel lymph node mapping. Ma'am, you have to unmute.
Yeah, unmuted. Thanks a lot. 1 second, we just need to share. I opened my presentation. 1 second. I'll just start it.
You can stop share and share again.
Yeah. Okay. Stop. Thank you. Thank you for the opportunity, Dr. Mala, Dr. Kanika, and the entire organizing team. Am I audible properly?
Yes, please continue. Thank you.
Thank you. Greetings from BLK. We have Dr. Lakshmi also in the chairpersons from our hospital. Dr. Kanika has given me a very nice topic, lab sentinel lymph node mapping in endometrial carcinoma. And let us see how practical it is and why it should be done. Sentinel lymph node is the first node which receives lymphatic drainage from the primary tumor. And this is more likely to detect micrometastasis. And can it replace complete lymphadenectomy, which we normally do for staging of early endometrial cancer? So we'll talk about the identification, dissection, and ultrastaging. We have a patient who is 68 years old with 13 years of menopause history. She had bleeding off and on for 2 months, diabetic, hypertensive, obese, and she had normal deliveries. And she was O negative. The MRI showed a thick endometrium with suspicious area at fundus. Hysteroscopically guided biopsy and curettage done. Turned out to be well-differentiated endometrioid carcinoma and grade 1. So then we were thinking, should we go for hysterectomy with BSO and the complete lymphadenectomy, para-aortic and pelvic, or we should do hysterectomy BSO with only lymph node sampling, or just hysterectomy BSO because she falls in the low risk category. But we decided to go for sentinel lymph node mapping. I think because various workers are applying different modes of management. So why sentinel lymph node? Let's see. Let's see, we will start with the right side sentinel node first. Dissection between the right round ligament and the infundibulopelvic ligament, the standard approach. Soon we will be you will start seeing the external iliac. here. That's the external iliac artery. And as we go deeper, this is the dye in the right parametrium. We had put intracervical methylene blue in this patient. That's my mouse, yeah. So that's the external iliac artery. We are beginning to see the vein, and that's the ureter that is coming. So as we go below, we go parallel to the vessels. We are beginning to see we saw the lymphatic over here. That's the obliterated umbilical artery, that is continuation of the internal iliac. And here we change our direction of dissection. This is for the uterine artery. Separated from the underlying vein because we don't want to damage that. So that's the uterine artery, ureter, the external iliac artery and vein. That's the anterior division of the internal iliac and obliterated. So that's the dye in the parametrium. And you can see this lymphatic going laterally. So this is going to be the sentinel node somewhere here. So you catch hold of this stained lymph node. That's the first lymph node which you came across. So dissect it all around. So this is the one which is most likely to contain the tumor cells. After that, only the next lymph node spread will take place. So we don't send it for frozen section because frozen section will alter its anatomy and its staining also. This will be subjected to ultra staging. This node is sent for a permanent section, and we will just talk about what is ultra staging. Taking very thin sections and subjecting it to immunohistochemistry for cytokeratin 19. So this node comes out and that's all. So we don't do complete lymphadenectomy because that is not necessary for staging. And for treatment also, for treatment point of view also, complete lymphadenectomy is not indicated in early endometrial cancers. So now this is on the left side, little fast forward. So that's the ureter, iliac vessels. You can see ureter crossing, and that's the lymphatic coming from the left parametrium. That's the uterine artery. That's the uterine vein. And so again, we follow the lymphatic laterally, and we begin to see the stained lymph node. That is the first node, sentinel lymph node. Dissect all around. So you don't have to go very deep. You don't have to have extensive dissection. Of course, identify the retroperitoneal structures and take out the lymph node. After this, we proceed with hysterectomy and BSO as usual. So we just said what is ultra staging, multiple thin sections. If it's negative for malignancy, then we must do immunohistochemistry for C19. So this patient had final histopathology as FIGO stage 1A grade 2 because sentinel nodes were negative. So good, we didn't do complete lymphadenectomy. So this patient had no blood transfusions. We just took 10 to 15 minutes on each side to complete this extra procedure. No ICU, she was mobilized very fast and ready for discharge after 24 hours. So how do you detect it? There are two techniques. One is blue dye technique that we just showed you. We used methylene blue in this case. You also have radioactive tracers. Radioactive tracers mainly used are, one is ICG dye, that's indocyanine green. And this is used along with near infrared imaging. So it's got a special camera which is available in most of the newer laparoscopes, and also it has a handheld camera for open surgeries if one needs. And the second is technetium, which is used with a gamma camera. This is how we inject the dye or the tracer. So this is injected in the cervical stroma. You take 4 ml, 2 ml on each side. So 1 ml is given superficial, 1 ml is deeper. This is Dr. Pooja giving the dye. She's co-consultant with me and assists me for all the surgeries. She's having a camera on her head, so that's being focused so well. So similarly on the right side. So this you do just before the procedure and you are ready. Within 10 minutes, the dye will be in the lymph node and it will stay there for about an hour. So no need to hurry up or mess up. You can coolly do your dissection. So what are the sites for injection of tracer? Cervical injection is most common and gives the best results. It's been seen in the studies. You can also, because people have tried it hysteroscopically also, subendometrial, and subserosal laparoscopically also at the fundus, but cervical injection has been standard till today. So this is with ICG dye. You can see this paracervical tissue being stained, and you'll be seeing the lymphatic. The advantage is with ICG dye, without opening the peritoneum also, you can see which lymph node is stained. But ultimately, you have to open the peritoneum, so you can see where the lymphatics are leading to. So this is the handheld camera I was talking about. This we did just last week. And this is how you can see a very prominent lymph node and the vessels and the lymphatic vessels leading to it. So some people use just take out all PET positive nodes, but the standard one is ICG dye with the near infrared imaging. So for low risk endometrial cancer, that is for stage 1 endometrioid, which is common, about say 80% of the cases, and it's G1, G2. So this is one cancer we normally see in very early stages, and it is a very common cancer. So for this patient, complete lymphadenectomy, that is para-aortic and pelvic, is an over treatment and too radical a procedure. But if we don't do any lymphadenectomy, then if it's 1A, 3% of the patients would be deprived of the adjuvant treatment. And if it is 1B, almost 11 to 15% will be deprived of adjuvant treatment. So why miss any case which requires adjuvant treatment? And why do over treatment with all the possible morbidities? So how does ultra-staging help? The sentinel lymph node mapped patient had twice as many lymph node metastases as compared to the non-mapped group. So if you do complete lymphadenectomy, the upstaging was lesser compared to the sentinel lymph node biopsy and ultra-staging. So sentinel lymph node biopsy gives you a better yield regarding upstaging rather than the complete lymphadenectomy. So this has been proven in various trials. This was the largest trial, FIRES trial. So you can have sentinel lymph node at any of these places. And the trial showed negative predictability, 99.6%, positive 97%. But here, why it was not 100%? Because they had taken even high-risk population also, high-risk group also. But for low-risk group, it is definitely recommended, as evidenced by other studies also. Hello, please mute yourself. So by other studies also, where it was 100% negative and positive predictability. So my friends, why not sentinel lymph node mapping for early endometrial cancer? Why give her a huge incision when you can do it with robotic? Robot also has a firefly technique, the latest one, the XI model which we have. So either do robotic or laparoscopy, but why go for a large incision with all the morbidities? So give her advantage of the minimally invasive. Why have lymphedema? Dr. Shailesh just talked about the lymphedema and the lymphocele. Too much of operating time, blood transfusions, anxiety. So for decades, the patients have been exposed to this procedure. Fine, this has been gold standard doing complete lymphadenectomy for endometrial cancer, but let's rethink about it. So this radicality of treatment is doing more harm than benefit to the patient very often, especially in the low risk group. There may be injuries to vessels, nerves, prolonged convalescence. So should we do it? When we have a very sensitive method, that is sentinel lymph node results were superior to complete lymphadenectomy as it combined the use of tracers and ultra-staging, and also cost effective. As you saw, there was no need of ICU stay, no blood transfusions, very short hospital stay. So it turns out to be cost effective also. And patients' work hours are also saved. Many of the women are working, so they would like to join their work as soon as possible. Even if they are housewives, they like to be up and about as soon as possible. And sentinel lymph node mapping is already a standard practice for CA breast, malignant melanoma, and CA vulva. And all the recommendations you can have from the topmost societies and even NCCN guidelines to go for sentinel lymph node biopsy, then why not? Why do no lymphadenectomy or complete lymphadenectomy? Let's do sentinel lymph node dissection for the best results and If required, patient can go for adjuvant therapy as soon as possible. Thank you so much for the patient hearing. And let me thank everybody for wholeheartedly supporting me for IIG Managing Committee elections also. I'm so thankful to you. And thanks to the chairpersons, Dr. Sanjeevni, Vice President DGES, Dr. Tarun, and Dr. Harshakulla, and of course, Dr. Lakshmi from BLK. Thank you, Dr. Mala, for giving us this opportunity.
Thank you, Dr. Dinesh, for an excellent presentation. It was very short and sweet, and you explained beautifully that we can always decrease the morbidity in cases of CA endometrium if we do this thing, sentinel lymph node. Thank you very much.
Thank you, Dr. Abdullah, for such sweet remarks. Thank you.
Thank you. Over to the organizers, please.
Thank you, ma'am. And I think the questions can be addressed in the chat box itself since we're short of time. And these were excellent sessions, and we've got 400 plus registrations. So 400 plus people are logged in to attend to these lectures. So moving over to the 8th session of the day, I invite the chairpersons, Dr. Subhash Malaya, Dr. Sabhyata Gupta, and Dr. Shweta Gupta Mittal. Dr. Subhash is he's from Calicut, and he's the Foxy secretary-elect for the IAG, and he's the secretary of. Okay, so welcome, Dr. Subhash, and Dr. Sabhyata is the head of department of Gynae and Gynecology at Medanta Medicity, Gurgaon. And Dr. Shweta is a senior consultant in the Department of IVF at the Institute of Obs and Gynae at Gangaram Hospital, and our treasurer for AOGD this year. So welcome to you all, chairpersons, and I would like to now invite the moderators for the panel. It will be a very interesting panel on surgical management of endometriosis. Dr. Manju Khemani is the chairperson of the subcommittee of endometriosis in AOGD. She has been director professor of Obs and Gynae at Lady Hardinge Medical College, and now director department of Obs Gynae at Max Super Speciality Hospital, Saket, New Delhi. And Dr. Madhu Goel is the co-convener with me in this workshop. She is the associate director at LAFM GK. So over to you, Madhu and ma'am.
Anika? Dr. Khemani?
Good evening, Madhu. I can hear you. Start the first session, Madhu. Should I start? Okay. Can I have the introduction of the first speaker, Dr. Nutan Jain? And Dr. Nutan Jain actually does not need any introduction. She is, I think, director of Vardhaman IVF Center, Muzaffarnagar, and she has also been the elected, board of director, AGL 2019. And she has published 8 books. Many credits to her. Over to you, Dr. Nutan Jain.
So much for a lovely and kind introduction. So my pleasure to be with all stalwarts of AOGD. So just start the screen sharing, please. So I shall be talking about managing ureteric or how to safeguard the ureters during extensive surgeries. So greetings from our new center. Do you see my slide?
Yes, we can see, Nutan.
Sure, fine. So greetings from our center. And the ureteric safety in extensive endometriosis is paramount. And to complete all this, a little history is very important. TVS preferably done by the gynecologist herself, and MRI to complete. And what we do is always do the renal scans ourselves and look for any hydronephrosis and any other, because endometriosis is the biggest cause of silent loss of kidney function. So we should, so rather than talking more on slides, I will just take you through some interesting cases where the ureteric injury was really at jeopardy. So this is a case who had a Hirschsprung disease open laparotomy when she was at the age of 5. And then she had extensive endometriosis. And now she came to us for a total laparoscopic hysterectomy. And as we all saw, Dr. Shailesh Puntambekar was showing some injuries through the laparoscope and by the first trocar at the umbilicus, even while using the optical trocar. So as all of you know, that we have introduced this GEN point, and I'm happy to share here that in this AGL meeting, which is going to be held in the postgraduate course, which is the pushing the laparoscope, the boundaries of the surgical envelope, I'm having a half-an-hour talk on GEN point in challenging situations. So here you see that the GEN point port is still free, whereas we have adhesions all over. So in this particular case, it was very difficult to even see the uterus for about an hour or so. A lot of adhesiolysis had to be done directly from over the bowels, and because of her previous history where resection, reanastomosis, and then a colon pull through, and then a colon pull back, all that was done. So there were extensive adhesions, not only because of endometriosis, because of that also. So to reach to this point of dissection, so safeguarding the ureter all through the surgery, and she had willed for total adenectomy also, it took quite a while. So all these surgeries, they really need that we take a good care for the ureteric safety. So like for this case, we had planned much in advance. So we had put the ureteric stents already. So then as you proceeded in the surgery, all of you can see what a relief must have been to see this white glistening rectovaginal septum and to enter the rectovaginal space to completely immobilize the rectum. And here, once the rectum was mobilized posteriorly, then we did the uterine artery, and you see that the ureter nicely stented and far away. The same was here on the right side, but still it was still more difficult than the left. So then we did an anterior colpotomy over the roomy cup. So this is the completed picture. But all through this 2.5 hour surgery, I would like to emphasize on some novice and mediocrity level endoscopies that we can take care of the ureters itself also, but few techniques like stenting and the others which I will talk in the later half of the talk. So this was the completed picture. So now this is these surgeries of excision of the rectovaginal nodule. They definitely need a lot of care for the ureters. So as Dr. Puntambekar also said, firstly that we should know very well the anatomy, where we are proceeding. So like in this case, so you know, as Dunej used to say that endometrioma and DIE are two different platforms, spectrum of disease, but I find them every day coexisting. So now, for all these surgeries, we have to start opening up the ureter at the pelvic brim. So it's not only that we have to rely on the stents, we should know the exact surgical technique. So we proceed gradually opening up the space and then using electrosurgery or harmonic ACE, or even you can use cautery and scissors. So now proceeding on to the left side, we open up widely the medial pararectal space after identifying the ureters, and then from the medial pararectal space, we enter into the space, into the rectovaginal space. So as we see here, the ureter is being fully mobilized, as you see here, and now we have to make entry into the rectovaginal space, as you see here. So all the fibers in between, all the tissue, all the nodular tissue is being removed, and the right uterosacral ligament, which forms the bulk of the rectovaginal nodule in this particular case. And as we see here, the ureter has been dissected far away. So these are the cases where we really need, and these are done on such regular basis. In the morning also, we were doing, me and my daughter-in-law, in both the theaters. So like in India, I feel there's almost an epidemic of endometriosis and very, very severe and fibrotic disease. So I'm just holding this entire rectovaginal nodule, and it has been shaved off. And now whatever the other portion of the nodule was remaining over the rectum is being taken care and excised by the scissors. So now we see that the total POD is nicely seen clearly without any rectum over there, and both the tubo-ovarian relationship nicely restored. But these cases just emphasize that we need to have recourse to some use of, like what I'll be showing here is the illuminated stent. So this is another case, total obliteration of the pouch of Douglas. So these are the stents made by Stryker endoscopy, and we have to introduce this stent by cystoscopy up till the mark of 4. And then when, now in this case, after the cyst has been drained, then we go in, like they are the blinking ones. We could keep them on the pulsatile mode, or we could keep them on a continuous mode. So the good point after, because with these stents is that there is no thermal injury. We can keep them all through the surgery, and we've used them quite a lot. And this is the way that helps you in your initial graph at least, or the cases as I showed you the other one, where really even whatever you know, but still like in the Hirschsprung disease, when colostomy was done, then a colon pulled through, and then severe endometriosis. So these are the cases where we really need to recourse to some of these newer technologies. So this is how the ureter being there helps you with the catheter. So now, other thing which Dr. Dinesh was talking about, that is the use of indigo cymene green. So we are putting these are the uretic catheters, and by them we inject 10 cc of ICG in one of the in both the ureters before the start of the procedure. So you definitely need special cameras which are made to show the ICG as a fluorescent green. So we show it over here. You can see the green ureter, and so this is the 1588 camera, in which we have to switch over to a special ENV, the near infravision mode. So here in this case, you see that the bowel is so densely stuck, and before we remove the bowels, we cannot enter from the pelvic brim to show the ureters. So for all such type of cases wherein the adhesions are really tough, and usually they are seen with recurrent disease, but nowadays I'm seeing in India that the patients are taking a lot of medical advices and medical treatment in the form of even homeopathy or long different types of medications. So then the fibrosis is too much. And here we see that with the ICG in, you see that the right-sided ureter is so beautifully seen. And here there was a little that there were double ureter or a single ureter. So we could see very clearly in the ICG vision that there was only just one single ureter. And then if you see, like this was a case of hysterectomy. So in hysterectomy, when you have to ligate the uterine artery, at that point, it really makes a difference, and it can speed up your surgery if you can be very, very sure about where the ureter is and how far and how much tissue is remaining to be transected before we can take over the uterine artery. So here is the benefit of using these modern gadgets. So this is the left-sided ureter, and we just switch on. Now you see that this much tissue was still remaining. So with the green fluorescent ureter, you can just cut away and without the risk of any thermal injury or a direct cut of the ureter. So this is very easily you can do because the ureteric stents cost a lot, and the ICG is just about 2,000 rupees. So I'll just go over to the last application. Now supposing we have the 1688 camera, we have the onlay mode that we can see the green ureter, the fluorescent ICG shows beautifully over here, and then on a screen which is a normal laparoscopic screen, you can see the fluorescent ureter. So this is a nice application which we are using every day. Since we are doing a lot of sentinel nodes, having these recourse to these type of camera systems, so we devised that by injecting them into the ureter, we can have this fluorescent, and in the contrast mode, it almost gives you the picture like it is a CAT scan. So this addition of these modern gadgets makes a lot of safety profile, increases the safety of the ureteric management while doing your extensive endometriosis. So at the end, I really would like to thank AOGD, especially Dr. Kanika and my chairperson, Dr. Madhu and Dr. Manju Kimani, for the excellent opportunity given to me. Thank you.
how do you choose which patient you will use the ureteric catheter? Do you have any criteria set in your mind? How do you choose which patient of endometriosis you will use ureteric catheters?
Catheter, yeah. So
and what is the cost to the patient?
Right. So as I said that we take a very important history. That means that we look into how many surgeries she has already got done. And then on my physical examination, if there is even protrusion into the vagina, there is a bluish nodule into the vagina. And then the MRI, which tells you the exact size of the rectovaginal nodule and its distance from the ureters. So the more complex the case, then we decide to go for stenting. But in our setup now, since we do it ourselves, so the stents and everything are always ready. And these, the stents, I think you are asking about the illuminated stents.
Yeah,
They are
yeah.
costing about 22,000. But nowadays, the recourse we do, like in this case, which had a Hirschsprung disease and then one previous surgery for endometriosis and now a TLH. So this case, we decided to put in the stiff ureteric stents right even before the beginning of the surgery. So this was a case where we went with the stents already in place. Now supposing one of the cases, though she's a young girl, but inside the disease comes out to be so fibrotic, then to safeguard the ureter, at times you have recourse to putting it ICG along with the, you just simply put a ureteric catheter and then you inject 10 cc of ICG. And that ICG shows up just like this fluorescent as I have shown you. So for these, the use of ICG, you need to have your camera systems. The striker system, which I am using for last so many years, has all these onlay mode, the contrast mode. So these, what I feel is that keeping moving ahead in endometriosis without having complications boost up your confidence a lot. So all these gadgets, as you move up, the more complex cases keep coming to you. So I feel that by the prior history, examination, investigations, we decide when to go in for such gadgets.
Thank you very much, Dr. Nutan. And we'll take the questions at the end. Madhu, I think you introduce the next speaker now.
Yeah, we'll invite our next panelist, Dr. Sanjay Patel. He's a renowned gynae endoscopic surgeon, infertility and IVF specialist, director at Mayfair Women's Hospital, Ahmedabad. So, Dr. Sanjay, over to you, please.
First, I would like to thanks to the Dr. Kanika Jain and Dr. Madhugal for giving me opportunity related to this wonderful workshop and conference. My talk is related to bowel resection in the endometriosis. Particularly whenever in our center there is some criteria related to bowel resection. In those cases, there is a circular ring or it's multiple nodules over it. And if the nodules is more than 3 centimeters, invades more than 7 mm, in those cases, we prefer to go for the bowel resection. But I think sometimes it's maybe associated with the cardinal involvement, parametrium involvement. Cardinal involvement and parameter may be associated with the ureteric. What then Dr. Nutan is telling, I think ureter is the first victim. So in this case, I think, look here, this is the invasion of the nodule more than 3 centimeters with the multiple nodules. In those cases, I think we prefer to take the bowel resections. Also, it's the circular ring. In those cases, the parametrium involvement, cardinal involvement, and whole circular ring is involved, and there is a stricture. Even though sometimes colonoscopy is not possible, even though PV examiners will find out the whole circular ring, in those cases, you have to go for the bowel resection in the endometriosis. This is very interesting case, patient having not able to pass the stool, dysmenorrhea since 2 to 3 months. MRI finding suggestive rectal stricture with a bilateral tumors with the left hydronephrosis hydroureter with the non-functioning kidney, particularly in this case. And upper 1/3 of the vagina is also involved with this one. In this case particularly, I think first we go for, because it's the non-functioning kidney, we also prefer to go for the nephrectomy. Previously, this is the multiple time surgery, and even though in our center we also do the uretrolysis and even the stenting of this case, and then we go for the IVF and patient is delivered the twins baby, and after 5 years later, patient is presented with the non-functioning kidney. Look here. This is the whole area affected. The most important part, particularly whenever you think for the bowel resection of endometriosis, you have to have the learn related to middle pararectal space dissection. And second important part, you also dissect the holy plane. between the posterior surface of the colon and between the sacrum. And this is the strong circular ring. Even the parametrium is involved. First, we do the dissected. Newton is also showing related to in such kind of the cases, you always start from the virgin to the non-virgin area. Never jump directly at the site of the pathological site. And first, in these cases, we do the nephrectomy first. We try to make the dissect parallel to the ureter. What the Newton is showing the same way, we dissect parallel to the ureter. This is the most important part in the endometriosis. But this case, I think there is no preservation of the ureter. So we flush to the ureter, we dissect properly, and we reach up to the level of the cardinal ligament where the ureteric tunnel, where the stricture is formed. Then you look here, this is we mobilize one side. This is also we dissected the proper cardinal ligament, and we apply the clip over this proximal ureter. We also fix with the ligature, and then we cut it. So first step, we remove the kidney. The uterus is adherent with the anterior abdominal wall due to the previous cesarean sections. So we mobilize this uterus first. Harmonic is really the wonderful tool in these cases. And the most important part in this case is then we dissect further in the Horley plane and middle parietal space. And once we go below to this adhesions, we find out the free plane of cleavage. Same procedure we do on the opposite side. We try to make the flush to the colon, parallel to the colon, and we enter in the middle parietal space. Second important part, try to make the preserve the nerve, hypogastric nerve and rectal plexus. This is very important. Here, this is the dense, also this is the vaginal involvement in these cases. So we try to make the split the nodules. The splitting of the nodules is very important. Just like what we do in the previous cesarean sections, I think we go below to the scar area, you find out the good plane of cleavage. In the same way, in these cases, if you split the nodules and then you enter in the two layer of the denominal spacia. This is the part of the vagina. This is the dense circular ring surrounding to the rectum. And once we mobilize and dissected and splitting the nodules, we enter in the two layer of the denominal spacia. Same dissections we did surrounding to the colon. We try to make the mobilize and we do the free. This is the posterior parametrium part also we dissected. And there is a small adhesions band, I think, we split it. And this is we find out rectal tube. The fat is very important part. You try to make the mobilize the whole fat whenever you go for the bowel resections in the endometriosis. This is the lateral fat. Also, we remove it because once we apply the stapler, I think try to make the avoid the fat is coming between the stapler. Otherwise, there is ample of chances of the leakage in such kind of the cases. The most important part in the such kind, also we in our center, we prefer to do the ligate the mesenteric artery and vein. Because if you do the good anastomosis, tensile-free anastomosis in such kind of the cases, I think you have to have the compromise the mesenteric artery. So it's the tensile-free anastomosis is the key success part, and you get the good length of this particularly colon. And now once we cut it, it's the absolutely colon is free. We freely mobilize. Further, we laterally fat. We also excise with the harmonic scalpel, and we try to make the naked the colon. So all the surrounding to the colon, I think we try to make the clear the fat properly. Rather than the vertical, we prefer the applying the stapler transversely. I prefer sometime 45, sometime depend upon the size of the colon. Sometime I prefer to 60, and we cut it. These cases we do the hysterectomy already. We bring outside through the vagina. Again, we mobilize the fat from the distal end, and then we cut it. The little bit oozing from the muscularis portion, this is the signs of the healthy muscularis. Then we put the anvil. First, we take the stitches with the proline. This is very important part. And we put the anvil remaining side. And we again further we tied it. So we create the circular ring surrounding to this anvil. Then we push back. The most important part to, I think, all the excise surrounding fat is first to clear it. Then we push the plunger from the below through the anus. Before that, we correct the axis rotations. And then we fire the stapler. And look here. Both the two ring on both the sides is very important. If you get the good muscular circular ring on both the side, that means this is the good anastomosis. And at the end, also very important part to, I think, check the colorectal integrity. On the left side also we do the, right side also we do the erythrolysis and we remove all the nodules. And look here, this is the cardinal involvement with the endometriosis. This is kidney. And this is the multiple stricture. And this is the whole circular ring involved due to the endometriosis. Thank you. Thank you very much.
Thank you very much, Dr. Sanjay Patel, for telling us in which case you have to do the resection, how to preserve the nerves, and very nicely showing the technique. They say you need a multidisciplinary team, but I think you yourself are a multidisciplinary team. Just tell me one thing, what are the, like they say, there are a lot of complications like hemorrhage, leakage, rectovaginal fistula. In your setup, are in your cases, what all complications you have seen, doctor?
I think sometimes the leaking is happen. This is some of the criteria we created in our center. This is the low anastomosis. In those cases, we prefer to go for the ileostomy, because it's very important. If this one is a high anastomosis, more than 8 centimeter, in those cases, if you try to make, because the tension over this anastomosis side is very high, and there is one of the part of leakage. Second important part is the fat is come in between the stapler. In those cases, also there is ample of chances of the leakage. So surrounding the whole colon, try to remove all the fat, and then you fire the stapler. This is the key part of the success. And second, sometimes if you find out there is some muscular tear over it, in those cases you took the little bit stitches with the Vicryl 30. I think this is the one of the part. But the mesenteric artery ligations and cut, tension-free anastomosis, we realized this is the key party. In those cases, we couldn't ligate the mesenteric artery and vein, and just you do the end-to-end anastomosis. In those cases, the pressure effect is much more higher side. In such kind of the cases, there is ample of chances of the leakage. But I think what people is, I think, thought that there is no much more percentage of the leakage. In our center, I think there is hardly 2 to 3% chances of the leakage, because we stuck with so many criteria related to this anastomosis.
So that means in every case you do an MRI to find out how much from the anal verge you are, with diseases, one thing. And secondly,
MRI is must. MRI is must. Sometimes you find out with the transvaginal sonography. Sometimes colonoscopy is also very important. In those cases, the mucosa is involved. So I think MRI, sometimes because in the PR examination, you couldn't reach up to the higher side. Sometimes it's the multiple nodules over it. In those cases, I think MRIs give them more information. Sometimes colonoscopy is also very important. And the second important part, judiciously, whenever you feel, you go for the divergence. Ileostomy. Ileostomy is the key part, because it gives the healing part. Only in those cases, we not prefer to give the lavage in all the cases, like the pigleg or exolighting in all the cases. But in those cases, we need to go for the divergence, because the mapping and planning related to bowel resection is very important. In those cases, we go for the ileostomy. We always prefer to give the pigleg. In those cases, we couldn't do the divertification in such kind of, even though whatever the advanced cases, we do not go for the pigleg. We just give the Dulcolex and Dulcolex.
Do you give them post-op hormone therapy, Dynogest or something to prevent the recurrence?
I think also the Nutan is telling, this is all our marketing gimmicks. Because why in the India we face a lot of problem related to this placebo drugs like Lupride and Dynogest. It's create the nuisance for the tissue. It's create a lot of fibrosis, and that's why the complications rate is much more higher. The company people is earn the billions of rupees due to give the placebo treatment, and this is the little by short time it gives the benefit related to pain. But I think it's a mess. It's create the chaos in the pelvis related to all the tissue, and then the plan of cleavage is absolutely different, and the complication rate is much more.
Sanjay, I'm very happy. I hope more people are listening to this, that medical therapy has no place in the management of endometriosis.
Yes,
Sanjay Bhai and Nutan, right? So there is a paper published I think in just 6 months or 8 months back. So for 7 years in deep infiltrating endometriosis gut lesions, they have tried these Dynogest, and they are quoting fantastic result. In fact, if you read in the human reproduction, they say only if the VAS score of the pain is more than 7, or if patient has had 2 failed IVF, then you should do surgery because of the complication. But all the surgeons will disagree from me on this point.
Dr. Manju,
There is two school of thoughts. One is the IVF school of thoughts. One is the endoscopic school. We do both the things. We do the IVF, and even though we do the endoscopy. So we realize that this is all are because people is try to find out the easy way, easy pathway. And that's why people is give the IVF, people is give the diagnosis and switch over on the IVF side. But I think real fact, I tell you, this is the adenomatous tissue. Adenomatous tissue. The drugs is never reach, even though we couldn't know. I spent my 30 years to understand this adenomyosis and endometriosis. Just I understand the peanuts. I think if we couldn't know the exact etiology, exact pathology, and whatever we know the certain fact, accordingly that we design the line of treatment for the endometriosis.
Actually, in the rectovaginal nodule, there are no glands. It's all fibrotic tissue.
Like all the fibrotic, how the drugs is reaching inside.
So nothing reaches there. Nothing reaches there.
We need them just to make the lysis treatment. Once you know the etiology, then it's possible to find out the right line of treatment for the endometriosis.
I think the bottom line is first surgery has to be the best surgery.
Sanjay Bhai and Nutan,
first surgery is considered to be last surgery.
Yeah, it has to be the best one.
80% of lesion, deep infiltrating lesion, it is fibrosis, but it still has estrogen and progesterone receptors. So this concept has evolved that because of patient should not be subjected to recurrent surgeries. That's why this concept has come that you should utilize medical therapy, and it is very underutilized.
The moment you stop medical therapy, the result is the benefit is gone. And you make the
side effects. There are side effects.
Side effects, cost, and her fertility years are lost in taking those medicines. So her time, her body, and her money, all three is lost.
Rather than you give the placebo treatment, you delay your treatment. You just jump for the patient is carry the pregnancy, whatever way you feel that, whether it's the IUI or whether it's the IVF. Once he carry the pregnancy, even though I show this case, this patient is 7-time IVF failed, then we perform the surgery, and then we do for the again IVF. The patient is carry the pregnancy twins. But look here, due to the people is give the post-operative. Once the influence with the IVF people, what's happened? Then people is thought that my surgery is over. Then these people is give the diagnosis for the longer time, and that's why they compromise the kidney. Why I put specifically this case? Because due to the
compromise is coming every day.
And it's delayed.
I think we are running short of time. This is an endless
Dr. Madhu, it's true, but we should give the feedback that even me and Sanjay were talking one day on phone, and I had 4 patients, young patients who were absolutely lost of kidney function because of long term of medical therapy and not coming up for definitive surgery. So
Dr.
we should give this
it is very interesting to hear someone called Dynogest a placebo therapy. I think this will be an ongoing debate. We should move on to our next.
Thank you so much for the opportunity.
Panelist.
Take home message from the
debate.
Take home message from this August audience. Never use the placebo drugs for the deep infiltrating.
Yes.
I think the take-home message should be that the first surgery should be the best surgery, should be done by a fairly experienced person. And I think now we should move on to our next panel.
Choose your patient, Madhu, for surgery or for medicine according to the patient's, if she has a ureteric condition.
I would prefer that, to choose wisely.
Sure. Thank you so much.
Ma'am, let's introduce the next panelist.
Okay, so next is Dr. Punita Bhardwaj. She also does not require any introduction. She is, I think, consultant and I think HOD of the Department of Endoscopy at Sir Gangaram Hospital. And she has taken training in endoscopy and robotic surgery. Over to you, Dr. Punita.
Thank you, Dr. Kimani.
And Dr. Punita is going to speak on the pain management in endometriosis. Am I right, Punita?
Yeah, it is a mixed bag actually. Can Sumit share my presentation?
Sumit, are you there?
You need to share your presentation, ma'am.
Yeah, thank you.
You have the right to share as well.
Madhu, can we start with Dr. Datta's if it's taking time?
Sumit, is it going to take time?
No, I don't think so. It's
Dr. Punita, can you see the share screen button on the screen?
That is the green button which says share screen. Just click on that.
yeah, it says screen, but I can't get to start the broadcast. Just a minute. It's coming. It's coming.
All right.
Yeah, it's there.
But I think you haven't chosen her presentation. Why isn't showing?
Sumit, can you help me out, please?
We need to open your presentation. Can we go to the next one and then I'll give you a call right now?
Yeah.
Okay.
I think let's move on to Dr. Debashish Datta, our next panelist. He is Senior Consultant, Institute of Obstetrics and Gynecology at Sri Gangaram Hospital, and currently only doing endoscopy. Welcome, Dr. Datta.
Yeah, am I audible?
Yes, you are.
Yeah. So, good evening, everybody, respected chairpersons, and everybody online. A very good evening to you all. Don't start with this straight away.
So we can't see you.
Yeah, I'm just getting it. Hmm? Yeah.
You need to start your video, sir. Yeah, we can see you now. You need to unmute yourself.
And share my screen.
Yes, you can.
Yeah. Can you see the screen now?
Yes, yes, we can.
But this is not the first. The other one is the first. Endometriosis. Yeah. Can you put it on a pause? Yeah. Good evening, everybody. Whenever we talk of endometriosis, what comes in mind is severely inflammatory disorder involving the uterus and the pelvic organs. Symptomatology will depend on how severe the extent of the disease and severity of the disease. So I will present, there's a whole spectrum of symptoms and clinical picture of endometriosis. I would share just 3 clinical pictures, and I'll start the first, the case. Is a 29-year-old lady with infertility issues, and imagery studies reveal that bilateral ovarian endometriosis is the so-called kissing ovaries. So there are no other medical treatment options available for this size. So surgical option offers a treatment, a permanent cure to start with. And since this lady was aspiring to raise a family and infertility issues, so conservatism practice of minimalistic surgery is what we should try to do. And here I would like to, as the other speakers have already mentioned, that the first instance we do the surgery, we should actually be prepared to go the distance as far as alleviating the symptoms and the causal agents for that is concerned. So just puncturing the cyst and taking out the chocolatey material is not what would suffice. Taking out the cyst wall completely is what should be practiced. Then comes the restoration of the anatomy. Suturing the separated ends of the ovary is a good idea that restores the normal anatomy and limits the use of thermal energy, which actually causes a lot of damage to the healthy ovarian tissue. So the other points I would like to say is, since we're running short of time, we'll come to this next video.
Hello, मैं अपने आप ही करूँगी यार. They've lost my.
The other one. Yeah, this is not really the endometriotic nodule now. What
Dr. Datta, you don't use vasopressin?
Yes, sometimes. Now, the next thing is a 35-year-old lady with her main complaint is just dyspareunia. Imagery studies revealed endometriotic nodule in a rectovaginal area. So the problem with rectovaginal nodules are that besides being very symptomatic, the depth of nodule, the invasion of the tissue, the deep invasion of the tissue cannot be really gauged unless we do the imagery studies, the MRI and all that to know the depth. So fulgurating such a nodule is not a good idea. The recurrence will definitely occur. Excision is the treatment of choice, and in that direction we have to, going ahead with excision. Mapping out the nodule is of prime importance. For that, we have to open up the rectal spaces and dislocate the rectum from the rectovaginal space and open up those spaces so that the nodule can be mapped out and the limits of the nodule can be made out properly. We are doing exactly that, and the dissection was proceeded in a minimalistic way, and the rectum is slowly being dissected out to a safety distance of safety. And now we can see the limits of the nodule. And here, yes, once the rectum is totally separated, the nodule can be now, excised without causing any damage to the bowel and the ureter. The ureter has been the first when opening the rectal spaces. The ureter has been lateralized, and now with harmonic we can use and we can excise the nodule. See, the nodule has totally come out, and at this time we do take the help of a colonic manipulator, and the assistant places a finger, and we use that manipulator again to see the way. And while cutting, we should be careful. The cervix is not. One can see the ureter safely away, and the nodule is removed and delivered vaginally, and the vaginal defect is stitched. We use Vital to do the same, and that's it. The nodule is totally excised, and we generally place a drain, and we can see that and we do colonic testing, and so that the colonic integrity is maintained. So that brings us to the third case in my presentation. A 55-year-old lady who's still having her periods, and all her periods are very heavy and painful. So we decided to offer. We offered her hysterectomy as a treatment protocol for giving her complete relief. And imagery studies revealed a bulky uterus with the posterior compartment adhesion between the colon and the pouch of Douglas and the posterior surface of the uterus. Conventional hysterectomy is carried out with the steps, the steps are followed. Here we are using bipolar ligature device. This is advanced, nothing but an advanced bipolar with increased safety margin. So the dissection is carried out anteriorly, the usual way. The bladder, UV peritoneum is mobilized and the bladder is pushed down. And the mirror image dissection is carried out on the other side. The fundal structures are desiccated and divided. And now once we approach the posterior compartment, we try to limit the use of hot instruments. And so that there is, the spread of thermal injury is prevented. And we carry on the dissection till the colpotomizer cup is visible. We use a colpotomizer cup for this in these cases, because that helps us in lifting the uterus from the area of all the adhesive bands, and we can find a plane more easily. Generally, as we still believe in actually the old school thoughts of taking the uterine artery, endosuturing the uterine artery. So the arteries are endosutured, and after that they're desiccated and divided. A figure of 8 stitches taken with a 1 or number 1 vicryl, and they're desiccated and divided. Now the hysterectomy is completed. The mirror image procedures is done on the other side as well. The fundal structures are,
can we run it faster, Dr. Datta? We are running a little late.
Okay. Right.
Maybe you can sum up and give us the take-home message, Dr. Datta.
Yeah. So the vagina is cut across the colpotomizer, and the vault is sutured. We sometimes use a vicryl, or sometimes nowadays we prefer to use a barbed suture, and the uterus could be delivered vaginally. And generally in such cases, after closing the vault, we do a peritoneal lavage and we liver drain.
All right. I think that's pretty good.
I think you highlighted very well about the steps of the cystectomy, and of course, in a patient, who has endometriosis, how to do the cystectomy without injuring the bowel and without injuring the ureter. I think we can move to the next speaker, Madhu.
Yeah, Dr. Punita, are you ready?
Yeah, I'm ready.
All right.
Yeah, ma'am. Just a small request, ma'am. I'm Dr. Subhash here, ma'am. I have actually a case. I'm one of the chairperson for this. May I just leave, ma'am? It's an emergency case, ma'am.
Any comments of
So
yours?
I'm thankful to AHOD for giving me an opportunity.
Can you hear can you see my screen?
No, ma'am. Thank you very much, AHOD, for giving me the.
Okay, thank you, Dr.
No,
Subhash.
Dr. Punita, we can't see your screen.
Dr. Debashish, if you have some inadvertent bleeding during the surgery, how would you handle that? I think we can answer till Dr. Punita is ready.
Yeah, tell me. Please come again. I couldn't get you. Please tell me.
If you have some inadvertent bleeding during the hysterectomy, how will you handle that?
Bleeding from which? I mean, managing the uterine artery, or generally cutting across the endometriotic deposits are not.
Can you see my screen, please?
Yes, we can see.
Yes, we can. Yeah.
Yeah. Okay. I'm sorry to interrupt, Dr. Datta.
Yeah.
This was a case of a lot of pain, and she was a primary infertility, and we realized that she had very small endometriomas, but her pain was immense. So we scoped her and we mobilized the ovaries, and we realized there was a little scarring in the broad ligaments, and we excised the leaves by dissecting from the healthy area, and I used automatic grasper and scissors. No energy source is being used here except for excising at the base where you expect bleeders. Otherwise, you can do blunt dissection with the suction irrigation and you take off these leaves. The literature says that it gives a lot of good results as far as the pain relief is concerned. We do send it for histopathology, and they have discovered micro deposits of endometriosis in these, and we just covered the area with Surgicel. Now, this was another lady with pain, and she was secondary infertility. We did an ultrasound. We found bilateral TO masses, and we scoped her, and we realized that there was a frozen pelvis. We mobilized the ovaries. One has to be very careful in such cases because, the vital structures are all closed. And the uterus is jammed into the pelvis. I use my suction irrigation for a blunt dissection. Works very well and without causing trauma. And when you are mobilizing these structures, you realize, the cyst inadvertently ruptures. But that's okay, so long as you clean it up, and that's the POD coming in view. And that's the right tube. Invariably, the tubes are patent, we don't have to do anything to the tubes. Majority of the times you get a dye spill, and you realize that no pathology of the tube is there except for the obstruction. And that's the dye spill coming through, and the POD has been cleared. And then we do a cystectomy. Of course, the IVF people will be not very happy, but when you're doing a clean surgery, that means you are in the right plane of the cyst. You can remove, and instead of yanking the base from the hilum, you can just release it. Of course, you see the bleeders and you cauterize it and put in a drain there in case, and you can remove it the next day or depending on the drainage. It's not because you are expecting too much of drain, but I'll just forward this because, this was another case. This was another case. She had a cystectomy done. She had got a cystectomy done beforehand, and she again presented with severe pain because she had an element of adenomyosis also and menorrhagia, and we realized there was a recurrence of the cyst. And endometriosis is an amazing disease, to decipher. Like Dr. Sanjay Patel said, that after years of studying about endometriosis and adenomyosis, it's peanuts you get to know. And this case was all stuck up on the left side because of endometriosis and the previous surgery, but the right side was totally clean. And here we are releasing the infundibulopelvic, all blunt dissection except for the coagulation of vessels. And once you get the blood supply, you are a little more bold in dissecting, and that's the round ligament. You realize the anterior segment is all clean in the front. And of course, like everyone knows that harmonic is a very good dissector, and it cuts and coagulates at the same time with very little lateral spread. That's the bowel stuck to. You realize the right side is all clean, and it's an amazing disease to decipher. So the suction irrigation works very well as a blunt dissector, and we release the bowel. We tease the tissue, we release the tissue. This case didn't give me a breather till we reached the uterines, which we ligate, like Dr. Datta said, with number 1 Vicryl in open surgeries. Now, this was a case where she had oophorectomy on the right side for endometriosis, and she presented for a hysterectomy later on. And why I'm showing you this case was that it's very easy to just clamp and cut the area where the jumbled up adhesions are there. But you realize that if you are ureteric minded, there is a ureter lurking there. ready to be injured in case you are not aware of the fact that it might be pulled into adhesions. So that's the ureter being delineated. And again, the suction irrigation, I think I love that instrument. It's very beautiful for dissection. Obviously, certain areas where you need to use sharp dissection, scissors is to be taken. And once you have the uterines and the ureter delineated, then hysterectomy is almost done. So that's the ureter laid down. And I think we just, as a gynecologist, have a hitch about dissecting ureters. But it's a level 1 lateral pelvic wall surgery. So, and once you have it inside, you don't tend to injure it. Dr. Nutan Jain did show very glamorous glowing stents, but at times, I think if you dissect out the ureter and delineate them and see them, you don't tend to injure. This was another wonderful case. This was a case of third time entry, the first time for a cystectomy for endometriosis, the second time for aspiration because of a recurrence of endometriosis, and third time she was presenting with a left EO mass with fever or hectic fever running and not responding to antibiotics or this thing. We did a CT scan. We got a phlegmon there and we entered, and it was totally distorted anatomy. She was a previous 2 cesarean with 2 times entry for the endometriotic cyst, and third time she had multiple pus pockets, and the principles again remain the same. High chances of injuries in this case. And I had a backup team of gastro surgeons, of course. The principles remains the same as in open surgery. You need to release all the pus pockets. You need to have all the loculi broken, because then when you use your triple antibiotic, it is more effective. And since we are a third time entry, although she was very young, we did plan to do a salpingo-oophorectomy so that the focus of nidus of infection is taken away. And again, the harmonic came to the rescue. We remained very close to the tube because all we could identify was the fimbria of the tube. Since the lateral spread is less and we didn't keep pressing at a certain aspect of the tissue, we could manage to get away. Salpingo-oophorectomy, we sent it for culture and we realized that it was E. coli. I am showing this case for a presacral neurectomy. Very judicious use of presacral neurectomy, used usually for conjunctive surgery with conservative surgeries where you've not done a complete excision and central plane is the element. You go to the presacral area and you excise the areolar tissue. We send the areolar tissue for frozen so that we identify the neural fibers. The fibers are reeling pain from the uterus, cervix, and the proximal fallopian tubes to the brain. So when we excise that, we stop the transmission and stop the pain. But it is only effective in the central plane. And areas of injury can be ureter, the iliac vein, and the iliac artery. So one has to be really careful about it. Thank you very much, and sorry for the all the interruptions. Thanks.
Thank you very much, Dr. Punita, for showing such wonderful cases. So I highlight again, this patient had 3 surgeries. This you can prevent by judicious use of Dynogest. We'll keep on arguing, reach no consensus. So I think any comments from the chairpersons? Are any chairpersons around? Dr. Sabita?
I just want to ask that since we heard so much of...
Can I just say something to Dr. Manju Khemani? Dynogest in an abscess is not suitable.
No, not in abscess, not in abscess. After first surgery, firstly you should do surgery.
No, the first surgery again had pus.
Punita, let me just
speak. Aspiration of endometriotic fluid with pus. You can't do Dynogest.
No, listen, Punita, what I'm saying. If patient do surgery only when patient is planning to conceive, right? And once patient has finished her pregnancy, put her on Dynogest till she reaches menopause so that you don't have to do another surgery. That is the concept coming up now.
No, so I understand all that, but you can't do conservative surgery on abscess.
No, I'm not talking about abscess. I'm not talking of abscess at all. I'm talking of only endometriotic cyst. You are justified in doing surgery because if it's an abscess, you have to do. She has fever, you have to do surgery. I'm talking of endometriotic cyst. What I'm trying to convey the message to all the audience that in an endometriotic cyst, do surgery only when patient is ready for pregnancy. Because if you do surgery, say in a young girl who's not married, 5-6 years she's not on any medication, she again has a recurrence. So you
that's a different case scenario. That's a different case scenario. But for abscesses and What I'm trying to suggest is that aspiration is not the answer.
Yes, that's a wrong treatment.
Not the answer, because you inadvertently infect the cyst because of blood being a good culture media. So I think one has to be careful to pick up the cases that need and the person who's doing the surgery.
Dr. Shweta, your comments, you were saying something?
No, I just wanted to ask that after all the extensive surgeries, I think one major chunk of endometriosis is the primary surgery, which is cyst and adhesions, which really needs to be done for fertility, promoting fertility. But how often do you need ureteric catheterization really, or is it the surgical skills which are just good enough most of the times?
Most of the time. In fact, literature also supports the fact that you don't need to stent the ureter, provided you delineate them and you are ureteric minded, like we used to be taught as postgraduates, ectopic minded, So ureteric minded, the ureters are going to be pulled in. If you dissect right from the beginning, you identify, because in the middle of the surgery, if you want to delineate the ureter, you can't. Because of the carbon dioxide, you tend to have fuzzing of the peritoneum and you can't delineate. And grade 4 surgeries, definitely you can't delineate the ureter. So it's a good idea to dissect and delineate the ureter. It is not so difficult, even in grade 4 surgeries. And stenting, they say, can be traumatic. In fact, when you are handling and doing the surgery, the ureter becomes less pliable. So I don't think I am a proponent of ureteric stenting, but yes, everybody has to be safe. The bottom line is you have to be safe for the patient. And first dictum is do no harm. So
Actually,
I
would like to add a point here. I do support the view that ureter should not be stented prior to its dissection. After dissection, you do have a worry that the ureter might have been compromised.
No, if you are doubtful about injury, if you are doubtful,
doubtful in the sense, I mean, there has been extensive dissection in the ureteral area. You can do a post-surgery, after surgery, you can do the ureteric catheterization.
Yes, that's another option.
But
I think, Punita, you are absolutely right, because stenting is lost the elasticity of the tissue. And once you put the stenting, it's the rigid. Then elasticity and movement of the ureter creates a lot of problem. If you do the stenting and then you do the ureterolysis, you end up with the iatrogenic injury of the
More
ureter.
injuries, yes.
So never do the stenting before that. What that Dr. Datta is telling, after later on, if you feel that there is a compromise in the vascularity of the ureter, you put the stenting. Stenting is much more easier than the hysteroscopic tubal cannulation.
Yes.
Okay, because it's the thick vascularis, the big lumen. I think it's much more easy than the hysteroscopic tubal cannulation. Put the stent and came out.
And moreover, once you put the stent right before surgery, what it gives you a complacency. You tend to handle the ureter much more. If they, other than during delineation procedure, you are very careful with the ureter. So the elasticity and everything is maintained.
I think we will
mobility of the ureter.
I think we should wrap up the panel discussion.
Session. Yeah.
I'm really sorry to intervene every time, but Dr. Nezat is waiting. I can see in the participant list. So it was a really good discussion, very enlightening. And I think Dr. Kanika, you can take over from here.
Yeah, thank you, Madhu.
Thank you very much.
Thank you very much. Thank you all the participants.
Because that didn't want to intervene at all. But Dr. Nezat has been waiting from Atlanta for a long time, and maybe it's very late out there. So good evening, Dr. Nezat.
Good morning to you.
Lovely.
And good evening to you, everybody.
Good evening, India. So I invite the chairpersons of the day, Dr. Lalita Badhwar and Dr. Panchampreet Kaur for his session. Dr. Jyoti Bali, I think, has gone. And so these are my co-chairpersons. Dr. Badhwar is a senior gynae endoscopic surgeon. And I've learned a lot from her, watching her surgeries. And she's at Apollo Hospital, New Delhi. And Dr. Panchampreet Kaur, she's a consultant, gynecologist and obstetrician at alumni of Army Hospital. And at present, she's at Sitaram Bhartiya Institute of Science. So welcome, Dr. Pancham and Dr. Lalita.
Thank you.
Thank you.
Thank you.
Thank you very much.
And I welcome Dr. Sienna Nezat from Atlanta. He is an excellent surgeon as far as endometriosis is concerned, and shows amazing. He's got amazing videos and develops newer strategies in the management of severe endometriosis. And the topic of his talk today is newer developments and strategies in the management of severe endometriosis, the intelligent light. Over to you, Dr. Nazit.
Well, hello, everybody. Let's see if we can share this screen with you. Joanna, we have problem again.
Okay.
I enjoyed, let's see if we can figure this out. I have enjoyed, this is the presentation is in the background. We just have to share it.
Okay.
Oh, here we go.
Okay. And hit share.
And we can share. This is Johanna, my assistant.
Hello.
She's sending her greetings.
Hi, Johanna.
Hello.
We've had quite a number of conversations.
Yes, I have enjoyed listening to all this conversation. It's really a pleasure for me to be with you. I wish I could be there in person, but I was amazed by all these talks that I heard. Some of you have been in our operating room for years. So I really, after listening to all excellent presentation, I don't have much to tell you, but I have modified the talk. I'd like to thank my fellows, my assistants to help me with this presentation. I do work with these companies, but no relationship to my talk. The good thing about Zoom talk is that it's recorded. You can go back and look at it. So these are the publications we have about in the Journal of Nature and Urology recently. So you can address all these, access all these publications easily and get all the statistics you want. So I briefly talk about light. And here I want to show you one of the earliest light we used in surgery, endoscopic surgery, and that's the CO2 laser. CO2 laser is also light, and I call it intelligent light. I heard a lot of people refer to harmonic device be the best energy. When it comes to endometriosis, I believe CO2 laser is superior. The reason is, it is intelligent light if we know how to work with it. It goes layer by layer. And this is a video I have shown for many years. You could do excision with it. I heard a lot of discussion about absolute excision. I disagree. At times you should do vaporization. Vaporization could give equal elimination of the endometriosis without damaging the surrounding tissue and the nerve tissue. And this is just a focus on urinary tract endometriosis. I won't elaborate on the statistics, but on the video that I showed you, and that videotape is almost, this video is almost 20 something years old. You can look at the ureter on the side wall, you can look at the hypogastric nervous plexus. While we have excised the endometriosis from paraureteral area, we have not damaged the surrounding tissue. The problem is the literature doesn't go far back. This is a recent search I did in a urology, and if you look at Journal of Nephrology, Urology, it's still talking about bladder and ureter endometriosis like it is an enigma. If you look in the center, they even call the bladder, ureter endometriosis of the bladder penis. And you read this description, it looks like this is the first time they have seen it. So my point is, we do need to go back in the literature and look at the other people's experience. Yes, I do agree that a combination of medical and clinical management is important in care of the patient. It is not all we can do with surgery, and certain pathology does not respond to medical management. So individualizing the treatment is important. As far as focusing on a urinary tract endometriosis, The clinical manifestation is not always pain. I'd like you to look at this variety of the symptom by looking at the bottom. Cyclic hypertension or cyclic acute renal failure. These are the symptoms that could be associated with endometriosis of the GU tract. So our role is not only taking care of the patients ourselves, our role is increasing awareness amongst the other disciplines, other specialties. You saw about the anatomy of the pelvis, and that's very important. But I'd like to bring to your attention on the left side, the anatomy by laparoscopy is different than what it is in the Netter's book. The ureter on the left side crosses the internal iliac, not at the bifurcation, contrary to the right side, which is at the bifurcation. So my point here is that with video endoscopy, even the anatomy could be different, and some of the material that we've learned in the medical school should be rewritten based on the current technology. Specifically, when we talk about anatomic relationship of retroperitoneal structures, bladder, ureter, and I focus on ureter and bladder today because I saw all this presentation, and as I was listening, I put in this talk together to be a little bit different than what everybody else showed. So this is an bladder endometriosis here, that polypoid structure, and I showed the robot here. I know there are some robots in India, but I thought it may be of interest. That the principle of resection of the bladder endometriosis or any endometriosis is identification of the anatomy separating from healthy from unhealthy tissue and excising the lesion with clear margins to decrease the chances of recurrence. So I heard some discussion about putting a ureteral catheter for the ureter dissection. If we do bladder resection, it would help us identification of the trigone, the proximity of the ureter, and then approximation of the bladder is important. I've seen beautiful presentations from our colleagues in India, so I wouldn't bore you with it. But this is the robotic approach. What it does, we approximate the tissue without tension, avoiding strangulation, and of course, we avoid devascularization. Leave the Foley catheter for 10 days and do cystogram. On the right side, however, I show extrinsic bladder endometriosis. So it is in the paravesical space. And when I was talking about excision and vaporization, so this is a CO2 laser that it goes like an onion peel, layer by layer from superficial. As you can see here, we are following microsurgical principle. And then in certain area, the lesion is excised without compromising the integrity of the bladder wall. You see here, the bladder is hyperdistended, and there is no evidence of trauma to the bladder. When we talk about endometriosis of the ureter, it's a different entity. I saw a lot of ureter dissection on this day's presentation. A majority of the ureteral disease are extrinsic. And if we restore the anatomy of the ureter, there is no need for aggressive resection. So on the left of the screen is extrinsic, and on the right of the screen is intrinsic. Anatomically, if the lesions surrounds the paraureteral area, then ureterolysis, paraureteral excision is adequate. Less than about 1% goes deep enough, like the first diagram on the top left, that it would require resection. We've been publishing about ureteral endometriosis since early 90s, but this is a recent search I did in the urology literature. You can access this, even it is on Medline, and I believe it may come up on the Google also. But still, even in urology, laparotomy is a way of approaching ureteral endometriosis, which I like to disagree with that. I believe with laparoscopy, we can see better. When we can see better, we can do better. Regardless, as far as dissection, here, these are the steps we follow in our operating room. But one thing I'd like to elaborate is at the bottom. We should remember vascularity of the ureter in the upper part, in the abdominal part is medial, and in the pelvic part is lateral. And that helps us when we do dissection. So in 1992, the first ureteral resection and reanastomosis, we reported it in Journal of Urology. The same principle I follow today is first hydrodissection, separation of the normal from abnormal anatomy. You can see a large segment of paraureter is involved with the fibrosis, but when we restore the anatomy, only a small part is actually infiltrated, is intrinsic. And then these are the principles that were being followed by the urologists. Mobilize the ureter, avoid the vascularization of the ureteral sheath, spatulation, then approximation. This is a non-absorbable 4-OPDS. Usually 4 sutures are adequate at 6, 9, 12, and 3. Leave the ureteral stent for 6 to 8 weeks and follow. This is one of the earliest primitive way you see those 4 OPDS were made by laparotomy, but we used it by laparoscopy. Today, technology has gone way far, multiple needle holders, suturing, etc. This one is a case of infertility. As the time when we realized that not all of the ureters would require resection. If you look at the top IVP, you see a large segment of the ureter is obstructed with severe hydronephrosis. And this is the video that I just published it in fertility sterility, the same case. You can go online on fertility sterility and watch the whole 6 minutes video from the beginning to the end. And what I'd like to show you briefly here is the ovary and sigmoid mesentery are separated from the ureter. Then the ureter is isolated. You see a large segment is affected by paraureteral fibrosis. But as we shave it off, and you see that we go between the healthy and unhealthy tissue. And I want to refer back to Victor Gomel's publication in early 70s of using microsurgical principle. The results are better, adhesions is less, complication is less. And that's what I think CO2 laser is a better device doing micro surgical technique. And this is the final outcome. I've been showing this video in some of my presentations, and one of the participants came and said, well, the long-term results is only 2 years, and how do you know the disease didn't come back? So that's why prompted me to publish the whole video in fertility sterility. On the left side of the screen, you can see the first one. In the middle, 2 years later. And on the right side, 14 years later. So as you saw, that narrowed ureter responded very well, and the long-term results are good. The problem comes when the disease is on the distal ureter and it invades the ureteral sheath. This is the very distal part. And I have been publishing the ureteronocystotomy. You could refer to the literature. In 1999, I reported the psoas hitch. On the 2005, reported a series of them. And then in 2009, actually on the right side, you could see a double ureter. And the reason I tell you all of this, because going back in the literature, if we follow principles of restoring the anatomy, avoiding trauma to the lesion, and making proper choice of treatment for the patient, the long-term results are good. So it's a double ureter reimplantation with psoas hitch on the right of the screen. In the urology literature, you can refer to this nice publication. It tells you how to choose when we do reimplantation. Depends on the pathology and the surrounding disease. The whole idea is to mobilize the bladder from the space of the reticulus. When we do reanastomosis, we would like to allow lungs to avoid the stricture and also efflux. I do show you two brief cases of the robotic. One on the left of the screen shows robotic ureterolysis. On the right of the screen, I would show you the robotic ureteral resection and reanastomosis. And if you notice here, the same principles are followed. Even here, we use monopolar electrosurgery. The idea is to create space between normal and abnormal tissue. On the right side of the screen is mobilizing the ureter until identifying and isolating the actual disease part, then resecting it without devascularizing the ureter. Here on the left of the screen, you see we push the ureter laterally. The only thing is with the robot, we have to be cognizant that we do not have tactile feedback. Therefore, if we mishandle the tissue, we could crush the tissue. The rest is straightforward. I am sure on the YouTube, you can access any of these videos. You can also go to our website and we have these videos stated. So having seen that you've had a long day, I heard about artificial intelligence enlightening. These are the drawing you could do with the computer. But I saw Newton Jane showed the presentation that by retrograde injection of the ICG dye, we can identify the ureter. Here on the top hand side, you can see. And then I saw blue light and the green light. I'd like to elaborate. For ureter and bladder, blue light is better. For blood vessels and vascularity, green light is better. So I use the green light, ICG, to see if there is any vascular compromise. If you look here on the right side, you could see on the ureter, and you can follow. This is, and then the difference between the green and blue. If you notice, blue is more prominent. On the side of the screen, I show you the final outcome, that the lesions of the paraureteral area has been excised. And we look, the green light showed there is vascular compromise. And then we follow the path of the ureter. So I see the technology is more advanced in India than even some parts of the United States. I was pleasantly surprised to hear that. And I do not think, considering this fact, lightening ureteral stent has any more indication. Specifically, lighted ureteral stents are larger diameter. It could traumatize the ureter. itself. So for many years, we have not used it, but I do use this technology. In conclusion, I'd like to let you know about the ureter endometriosis. You know the statistics, we just have to be aware of it. I heard a lot of four or five patients of the Newton gene, you said they have lost their kidneys. So it's good to be cognizant, detect them early. And I saw Dr. Danish showed the ICG injection for sentinel lymph node. These are excellent. So these are the intelligent light I was going to refer to. I want to re-emphasize that resection is not always necessarily the answer. Shaving paravesical and paraureteral disease is adequate. Specifically, when we talk about the ureter, rarely ureteronocystotomy is indicated. Majority is ureterolysis, occasionally reanastomosis. The whole idea is to adequate mobilization, avoid devascularization, and approximation without tension. On that line, I'd like to thank you again for allowing me to be with you. I hope you enjoy the rest of the meeting and hope to see everybody in person soon.
Thank you so much. Dr. Badwar and Dr. Pancham, do you want to ask something?
Thank you so much, sir. It was an excellent
Yes,
presentation. Yes. Yeah, please, Dr. Lalita ma'am, please.
Thank you. Dr. Nezat, it was an absolute treat to watch your presentation, and it was wonderful. And as you rightly pointed it out, that so much of chronic kidney disease is possibly related to an underlying endometriosis, and that is not recognized in time. And by the time, the kidneys could be bilaterally affected actually because of ureteric strictures and so on. Now, my question to you is something which has been, you may or may not have heard it raging in previous sessions about after a surgery, continuation with progestational therapy for patients of endometriosis, especially young patients who may not at that moment be trying to conceive. What is your opinion on that?
Excellent. As I mentioned briefly, endometriosis, if I had to compare it, endometriosis is very similar to ovarian cancer. We need a combination of surgical and medical management. The same with for cancer, medical management and chemotherapy. Nobody as of today can cure endometriosis with surgery. And unfortunately, when there are obstructive and invasive disease, medication would not take care of it. A combination of surgical and medical management, it is my recommendation.
That is wonderful. That is such a good balanced approach. Thank you.
Well, thank you.
Dr. Paramji.
Yeah, thank you, sir. Thank you, ma'am. Excellent presentation, sir. It was a visual treat for our eyes. I have two questions. One is a very basic question, like how do you do the bowel preparation for your patients for grade 4 endometriosis? And number two, how is your experience with only medical management if done with Danogist if you're using? So if you can guide us on both these questions.
Sure, thank you. Bowel prep really depends on the location of the disease and what we are going to do. It's always a good idea that if we are working in deep rectovaginal septum, we don't have to deal with the stool. So an enema the day before the surgery is pretty much very helpful. There are mixed literature about bowel resection that do mechanical and chemical bowel prep or not. Individualize the case. I cannot tell you really who do we do what. Okay. But most of the time I do give them an enema. As far as experience we have with Dionysus in United States, we have pretty much a lot of medications. The problem is individuals' response, like patients with polycystic ovary, they don't respond to the combination of estrogen and progesterone. So progesterone alone may be a choice. Some people have contraindication. So it has to be individualized on what medicine fits which person.
Thank you. Thank you so much, sir. Any other questions from the house?
May I make a little discussion here, Neza? The only possible cure in inverted commas, and obviously that is not to be done lightly and not in young women, but say a lady of 45 who has been bothered by this ghost of endometriosis through most of the previous 15, 20 years, one can offer her bilateral salpingo-oophorectomy. Because once the hormones are knocked out, the endometriosis will go dormant unless and until she receives HRT. I want to start a little controversial discussion here.
No, let me just repeat if I understood you correctly, that you mentioned on certain individuals, salpingo-oophorectomy would be indicated to control recurrence or the symptoms of endometriosis. Am I correct?
Yes, but only after she has crossed 45 years of age, not in a young woman.
Well,
45 is young too.
I agree for the first part, but I wouldn't limit it to the only 45. That only 45 needs to be rewritten. So if I may, I elaborate on what you said, that on certain individuals that they are not candidate for medical management, or they do not desire to keep their ovaries, or oophorectomy, in addition to treatment of the endometriosis, would decrease the chances of recurrence, and removing the fallopian tubes and the ovaries decreases the risk of ovarian cancer also. So yes, on individual persons, it is indicated.
Right.
I agree.
Thank you.
We agreed on almost everything today. That's perfect. I mean,
this is wonderful. This is just too good to be true.
I was so pleased to hear all these presentations. These are great.
Which patients do you choose to do IVP on? Do you do it in all your patients or only those where the ultrasound is showing some evidence of hydroureter, hydronephrosis?
No, IVP, actually these cases, most of them I showed now. It's because I like to show the historical value of these cases. So these days, most of the patients who come to me, they already have their own MRIs, or if I have concern about the ureter involvement and function of the kidney, then we do CT urogram, but not on everybody. But not on everybody.
Right. And that's when you plan on on what you're going to do next for the ureter, the uretrolysis or reanastomosis and so on.
That is correct. Helps us identify the location. But as I said, majority of the patients, even I have gone with the preparing to do ureter resection reimplantation, and as I dissected the ureter, I found out that we don't have to do it. Like the case that I showed you, we were going to do reimplantation, but as I shaved it off and I saw the disease came up, we just left the stent for 6 weeks and the ureter is back to normal. Intraoperative decision also is important as we restore the anatomy.
Yes.
Take you back in the literature, in 1997, we published a paper, Infertility Sterility, and that put our experience on GU endometriosis. And that's the first time that we realized most of the GU, like bladder and ureter endometriosis, it could be shaved off and not need to do resection and reimplantation. regardless of what the urology literature was telling at that time. That they said do resection, reimplantation if it is too far from the bladder. We pretty much overruled the urology literature.
Sometimes you find endometriotic deposits and nodules inside the bladder, on the side of the bladder mucosa when you do a cystoscopy. I have had 2 such patients who used to have hematuria every month during their periods, and they had large endometriotic nodules towards the mucosal surface of the bladder. And of course, I had invited my urology colleagues along with to have a look. And when they did a cystoscopy, they found that, and they, with the resectoscope, resected off the nodules from within the bladder. And patient relieved of her symptoms.
Well, but if you do laparoscopy, you can do deep ultrasound. Majority of the intrinsic bladder endometriosis are transmural. Rarely they are mucosal only. So like the video that I showed you, you saw the polypoid lesion in the bladder, but the lesion was going all the way to the vesicouterine space and the complete macularis involvement. Controlling of her symptom is good, but I believe she would have residual endometriosis in the muscle wall of the bladder also.
Dr. Nezat, good evening.
Hello.
Congratulations for a very informative talk. I had a question in mind. Sometimes the ovaries are very badly stuck to the sigmoid, and we tend to leave a part of the ovary over the sigmoid. The ovarian remnant syndrome, how do you tackle it?
Well, that's a good point. Remember, all literature what used to say it's better to leave a piece of ovary on the bladder or the bowel. Even if you read Tallin's textbook, the latest one, it still may say that.
Okay.
But unfortunately, that's a wrong teaching. I take the opposite approach. I would rather do bowel resection and remove the whole lesion than leaving the ovary behind. And the reason is, since 90s, we've been publishing on ovarian remnant. That as I heard some of our colleagues mention during their presentation, your first chance is the best chance.
Yes.
So if we do complete excision the first time, it's better than leaving ovarian tissue behind for 2 reasons. Number 1, pain continue because of the ovarian remnant. I've had bowel obstruction and ureter obstruction because of ovarian remnant. Number 2, patients with endometriosis have a higher chance of ovarian cancer. The risk is doubled. So you're leaving ovarian tissue on a patient with endometriosis, the risk of cancer arising from endometriosis is higher for the future.
Right. So it's a good idea to take off everything that you can see.
That is correct. It's better to excise it with surrounding tissue, especially if it is ovary. A lot of time, if you go for the second time after somebody has done quote unquote pelvic sidewall excision and deperitonealization, the ovary is stuck to the retroperitoneal fibroadipose tissue. So it's better to remove the ovary and the fibroadipose tissue around to decrease the risk.
So I thank you, Dr. Nezat.
Put an adhesion band in case the ovaries are not too involved and we don't have to do a oophorectomy.
I beg your pardon, I missed that question.
Yeah, I know. In other patients, you can't remove the ovaries. So we put an adhesion barrier where we have a raw surface. Does that work for you?
I still believe microsurgical principles are the only proven way to decrease the adhesion. Barriers may work, may not work, but avoiding excessive use of energy, avoiding traumatizing the tissue, it works better.
Right.
So
Thank you.
In that regard, Dr. Nazit, we are aware that you're passionate about the CO2 laser.
Yes.
Which is not always available everywhere. What would you use if your PET CO2 laser was not available?
I showed you this. I show monopolar electricity with the robot.
Right.
The high cutting mode, but I follow the same principle of going layer by layer.
Right.
Now we do have, actually, I have helped Luminous develop fiber laser for robot. And until it becomes really good, then I would think using monopolar energy with the burst technique works better. I kind of like the harmonic if you want to go and cut bulky tissue, but going for burst and layer by layer, like we call it, millimeter by millimeter, this is too bulky for me. I like to go millimeter by millimeter when I deal with the tissue.
Yes. And CO2 also gives the added advantage of vaporization, which you don't get with the other modes of energy.
That is correct. You could get vaporization with monopolar electrosurgery, but then we have to be cognizant about the depth of penetration. Monopolar could penetrate up to 7 millimeter. CO2 laser is 0.4 millimeter. So it requires knowledge of the energy and how we approach it. If you notice, when I dissected the ureter with robot, I didn't use the actual energy on the top of the ureter. I used it on the fibrofatty tissue and the peritoneum. When I was close to actual ureter, I used the tip of scissors to cut, sharp cut.
Yes, yes, that's right.
Thank you, Dr. Nazir. That was indeed excellent. And I think we would never be satisfied and the questions can just go on and on. But the back-end team needs to wrap up because they have to start another session. So that was indeed excellent. And very nice of you to have logged in and joined us from Atlanta. Thank you so much. And it's my honor and pleasure to propose a vote of thanks. I would like to thank our chairperson of the conference, our co-chairperson with me, Dr. Mala Srivastava, who's the president of the Association of Obstetricians and Gynecologists of Delhi. And I would like to thank my very dear colleague and friend, Dr. Mamta Daga, especially because I had network issues today and this workshop would have really flopped had it not been for her and her family, who I am sitting at her place since morning, and the entire family is just keeping mum so that there's no disturbance for us to be able to log in for this workshop. So I'm a real pylon today, but thanks, Mamta. And I would like to thank all the chairpersons and speakers for such interactive discussions and keeping the audience glued to the screen. We've got more than 406 registrations. It goes up to 415, then comes down, then again people log in. So it was amazing. And I would like to thank my co-conveners, Dr. Devashish Datta, Dr. Richa Sharma, Dr. Madhu Goel. Without them, actually, we wouldn't have been able to do this event at all. And I would like to thank the backend team, Mr. Sumit and his team, for this flawless presentation that he's given an amazing support. He's available to us all the time round the clock. So that's really amazing. And I would like to thank the entire organizing team of AOGD, my seniors, Dr. Kamal Gujral, Dr. Harsha Kulla, Dr. Abha Majumdar, and my scientific committee. These are the scientific committee chairpersons, including Dr. Geeta Mendirata, especially Dr. Geeta Mendirata. We really disturb her any time of the day to ask for her advice, and Dr. Chandra Mansukhani. Apart from that, my colleagues, Dr. Shweta, Dr. Neeti, Dr. Ruma, Dr. Sharmishcha, Dr. Ankita, Dr. I'm sorry if I'm missing out on somebody, Dr. Sakshi and Dr. Tarun and Dr. Ela. And I would like to, again, last but not the least, thank all the delegates who had logged in. Without that, obviously, we wouldn't have been able to do this workshop and we would have been talking just to ourselves. So thank you all, and very nice connecting with you. And we would welcome you for the next workshop tomorrow, which is by MAMC, Maulana Azad Medical College, and the other conference events which are going on till 6th of November. Dr. Nezad, you're also welcome. You can join us daily till 6th of November.
Thank you. Bye-bye. Thank you. So long. Okay. I had to.
I know.
Thank you, team AOGD Endoscopy. A big namaste to everybody. You've done a great job. You guys rock. You ladies rock.
Thanks, everyone. Okay, bye.
Bye.
Okay, bye, Madhu. Thanks a lot.
Bye. Bye, Mamta. Bye, Kanika. Bye, Richa.
We must congratulate each other at the end, you know.
It's really a job done.
Yeah, a job done.
I would like to thank every one of you all. Tireless work. You have been really working hard, and it's a grand success, the event. Dr. Madhu, Dr. Kanika, everybody, you have really, Dr. Mamta, everybody has put forth the best foot forward, and great show, really great show. Wonderful.
Thank you, Dr. Bhatta.
Particularly Dr. Nizat, the presence of Dr. Nizat really brightened up the whole thing. Dr. Sanjay Patel, Dr. Nutanjan, and everybody. Wonderful show. Thank you.
Thank you, sir.
Bye-bye.
Thank you,
Bye-bye.
sir.
Thank you, sir. Thank you so much.
Bye.